Dr. Neha Reddy is a very good friend of mine and very good, determined and dedicated fetal medicine specialist. She runs her own clinic, Dr. Neha Reddy's Fetal Medicine Center, and I welcome her for the talk.
Thank you so much.
ఇది ముందుకెళ్తే వెనక్కి వస్తుంది లేజర్
ఒక్క నిమిషం చెప్పరా ఇది వెనక్క ఓకే very good morning everyone and thank you for having me here. So without wasting time I would like to go to the our topic. So placenta, the forgotten organ in perinatology. So to start with, actually with the advances in ultrasound and with increased high-risk cases in obstetrics, our focus is mainly these days shifted on to mother and fetus. Fetus in terms of is there any abnormality, is there any growth defect, is the fetal well-being fine. But in between these, somewhere we are forgetting the main connecting link between the mother and the fetus, which is the placenta. So today we are going to take a close look at the placenta, how important it is. So mainly the placenta is the place where the maternal and the fetal worlds meet. So if we see this circulation, so there are three important compartments in the placenta where we can see that there is a maternal side, intervillous compartment, and the fetal side. So these three are the important backbone of the placental function. Whenever the maternal side spiral arterioles are working abnormal or any dysfunction in the villus compartment or any abnormality on the fetal side in the form of increased umbilical artery resistance, we can see the consequences and they are going to be either maternal or fetal complications. One more important thing I wanted to emphasize is the trophoblastic invasion. I know everybody knows about the spiral artery remodeling and that's a key concept. But I just wanted to emphasize that there are two steps of invasion. One is in the early trimester where the decidual spiral arteries are remodeled. And the second key further invasion happens in the 14 to 18 weeks where the myometrial spiral arteries are changed into low vascular channels so that most of the blood supplies well to the placenta. So this is the main thing. Maternal causes, they will affect they'll cause changes in the placenta, and that's how placental dysfunction, which ultimately we see in the form of maternal-fetal abnormalities like maternal PIH or fetal. When we say adverse perinatal outcomes, we take fetal growth restriction or the preterm delivery or fetal distress or stillbirth. So can we actually do something about it? How is going to this assessment help us is checking the placenta in detail. So this can happen in two stages: during pregnancy by the ultrasound and after delivery by the clinical examination or histopathology examination of placenta. So first we'll start with antenatal during pregnancy ultrasound assessment of placenta. So it goes as structural assessment and a functional assessment. Structural, on the gross, you have to look at placental morphology. How is the thickness? Is there any cystic spaces anywhere in the placenta? How is the location? Where is the cord insertion? Is it central or is it marginal or is it vasa previa? So coming to the morphology, these are the gross pictures. Due to lack of time, we'll not be able to go very in depth about the structural abnormalities. These are the cord insertion abnormalities. First is showing marginal placenta previa. Second is velamentous insertion, where the cord goes and inserts in the membranes. And these are the different focal placental lesions. So first is, whenever you see any placental lesion, make sure that what is its consistency, what is its size, and how are the peripheral margins, is that infarct, is that a lake, and always make sure that you put a Doppler on it. And that gives a very important clue about the lacunae which may otherwise miss. So whenever you see placental spaces, we have to correlate with the mother clinical scenario and the fetal growth and then interpret these spaces. So when the abnormal implantation also have to be given a view where if it is low-lying or it is marginal or complete placenta pria, whenever you see a low implantation of the placenta, make sure that you have ruled out, you have checked the retroplacental region, you have checked is the vesico-uterine surface is vascular, you have checked and ruled out other ultrasound features of adherent placenta. Main important thing that needs emphasis is always put a, whenever you do a TVS and cervix, see the cervix, you put a Doppler so that you don't miss any vessels which are going over the internal os, which is condition called vasa previa. So this finishes the structural assessment. Placental assessment, this is the most important way of assessing because this says indirectly how is the placental function and how is it going to affect the fetal growth. So what happens is so functionally we check this by checking at the maternal side uterine artery, fetal side umbilical artery, and villus compartment with the help of histopathology. So whenever there is a uteroplacental resistance, there will be abnormal uterine artery waveform, where usually the waveform shows increased diastolic velocity with the gestation, but whenever there is a remodeling or spiral artery remodeling has been defective, we see that persistent of early diastolic notch and there will be decrease in diastolic velocity. So whenever this happens, this again in turn affects the placental intervillus compartment, causing the changes, and this will be seen as increased fetoplacental vascular resistance, and this is interpreted in the abnormal umbilical artery waveform. And whenever once umbilical and uterine artery waveforms are abnormal, it indirectly affects the placental reserve and the fetal growth, and ultimately we see in the form of MCA redistribution or DV Dopplers depending on the intensity of abnormality. So this is a waveform, normal waveform where the end diastolic velocity has been increasing with the gestational age, whereas whenever there is abnormal umbilical artery Dopplers, the end diastolic flow decreases. In this picture, almost is an absent diastolic flow, and this is showing reversal of diastolic flow where the flow is seen below the baseline. So the most important part of this topic is how the Dopplers are correlating with the histopathology and why histopathological examination is important for us. So ultrasound finding, whenever we are seeing the uterine artery Dopplers in the baby, when they are correlated with the histopathology, there were basic pathology was defective spiral artery remodeling, and it was seen in the form of maternal vascular malperfusion and decidual vasculopathy. Like you can see here, there is peripheral fibrin deposition and spiral arterial obliteration and vasculopathy. Like the same way, umbilical artery Dopplers, whenever they are there, the main pathology is reduced tertiary villi and small blood vessels in the placenta. This will be seen as distal villus hypoplasia. So we can see this almost villus are gone. Small fibrotic villi are seen on histopathology. So ultimately the effect is adverse perinatal outcome in the form of FGR or fetal compromise or stillbirth. So placental histopathology, just on a gross, what are we actually looking? What is our report is going to show us? So these are mainly 5 important key lesions are to be seen, and they will be correlated with the clinical condition so that we can see if it is going to recur or not. So the main key lesions are maternal vascular malperfusion, which can be seen as we discussed in the vasculopathy on the histopathology slide, or villitis of unknown etiology or chorioamnionitis, where we can see on the histopathology infiltration of these chorionic villi by T cells. And other mechanisms are massive perivillus fibrin deposition. Like in this histopathological slide, you can see that there is a massive fibrin deposition across the villi and the exchange is hampered. The other one is fetal thrombotic vasculopathy, which causes fetal vascular injury and hence the effects. Other one is villus dystrophy. So basically, how are we going to correlate them with our clinical scenarios and what to do with this histopathology report and how to interpret it? So whenever these key lesions are seen on the histopathology form, there are maternal conditions which they correlate with. Like vascular malperfusion correlates with maternal PIH or FGR. Villitis of unknown etiology is going to correlate with autoimmune disorders or thrombophilia disorders. So whenever vascular dysmaturity is also seen, it is very characteristic feature on moms with maternal diabetes mellitus during the pregnancy. So interpretation of this correlation of the maternal condition will help us. So what to do in the next pregnancy, how to prevent it. So maybe we can answer the recurrence risk. We can do lifestyle modifications, like in diabetes, it makes a very important role. Or we can start prophylactic therapy like low molecular weight heparin or low dose aspirin whenever we find thrombophilia indicate like conditions. So ultimately, histopathology is answering the present pregnancy as well as guiding what to do in the next pregnancy to have a better fetal outcome. So when should we actually consider the placental histopathology? There are some essential criteria where we have to send histopathology, like stillbirths or late miscarriages or severe FGR, severe prematurity, and above all, whenever somebody is having an adverse perinatal outcome which is unexplained, it is empirical to send a histopathology for better correlation. So to concise, ultrasound tells us what is happening with the help of structure and function Dopplers, but sending a placenta for histopathology tells us what actually caused it. So together, they guide us for better fetal and maternal outcomes, which is the main aim which we are doing these CMEs for. So key takeaways are every pregnancy scan should include assessment which is structural as well as functional, and ultrasound and Dopplers tell about the function, but histopathology is the one which confirms the pathology if it is there whenever the functional aspects are abnormal. So your placental assessment should not end in the scan room or during the just beyond the delivery, but anyways, anytime you have any abnormal maternal fetal outcomes, you have to think about the placenta. Consider histopathological examination as a option, and whenever you have some findings on it, it will definitely be a supportive to the fetal testing. So, thank you so much for your attention.
Thank you, Dr. Neha. It was a very comprehensive and illuminating presentation.
Thank you.
Yes, you are very rightly said. Placenta is not just a passive conduit. It is a very important organ. It is a almost third organ which supplies respiration, metabolic, and also endocrine functions of the fetal survival. So which is very rightly said from your side. You're open for questions now or at the end of the session? Okay. Thank you.
Thank you so much. Thank you so much for KIMS and the
Open
entire
for
department
questions?
for having me here.
Okay, it's Aparna ma'am has given the green signal. So any questions from the audience? Okay. So if not, we move on to the next session. Thank you.
Next.
So we are just setting up the next talk, which is online. So before we start the next talk, we'll thank the speaker for the first session. I request Dr. Navya to please come over to honor the speaker, Dr. Neha Reddy. I request Dr. Vishwanath Nandiala, consultant, to join Dr. Navya on the stage. So, Dr. Neha Reddy, kindly proceed to the stage. Thank you for being the opening bats person. Thank you. So the next talk is going to be an online talk. We are just setting it up on Zoom, and to do this, we have a neonatologist, head of the department and professor of neonatology from Sri Ramachandra Medical College, Chennai, Dr. Uma Maheshwari. Dr. Uma has special interest in the area of inborn errors of metabolism, prenatal and postnatal genetics, and she is going to be talking about the need for speed, prenatal genetics, and the need for newer rapid diagnostics and advances in genetic testing. So we promise this will be an interesting session, and Dr. Uma has been someone who has set up an exclusive clinic on newborn neonatal genetic disorders, and she also has to her credit a cohort of babies who have been diagnosed to have various IEMs, and she is kind of working exclusively on providing them their special IEM diets and providing neurodevelopmental follow-up for these children. And she also deals with chromosomal anomalies, children with dysmorphism, trying to help them out with the right diagnosis. And this as a part of the bigger neonatal ICU work that they do. So I think she'll be on screen in a while.
Good morning, all. Am I audible now?
Yes, ma'am. Good morning. You are
Oh,
audible.
okay.
Can we
Good.
have the video on the screen now, please?
Yeah, yeah.
Okay. Yes, ma'am. You are visible. You are audible. Happy
Okay,
to
okay.
have you here.
I'm sharing my screen. Screen visible.
Yes, ma'am. Screen is visible. You can keep full screen now. Ma'am?
Uh,
Yeah.
is my screen visible? I am audible
Yes, ma'am.
also.
Visible, audible. Please.
Okay. So, a very good morning to all. I thank Dr. Aparna for to call me over to speak in this forum, KIMS B.O.N.D, and also Ishita, who is whom I can tell that I'm proud of her being her teacher. So the topic they have given, is the need for speed, prenatal genetics, and newer rapid advances. And also, I have to deliver this lecture in a speed manner because I have only 15 minutes to deliver this. So let me see how I am, going to get across this particular topic, um, which, sometimes could be perplexing as such. So we know that there is an evolution of the genetic testing which has been done from the time since Watson and Crick has found the invented the double stranded DNA, and Professor Sanger has tried sequencing from then the Human Genome Project to next gen sequencing. But after the Human Genome Project, the project, the next gen sequencing is a game changer. Like how we are, we are the generation who has faced many um, from traditional to what we have been now. So similarly, like the next gen sequencing has taken off in a clinical management, including the preconception and prenatal screening. So why? Because there is a falling price of the sequencing, because it could be done in an efficient manner, and also we have an advanced bioinformatic capabilities. With that, like my objective is to discuss on the need for rapid prenatal genetic testing. Why do we need it? And to learn on various testing which are available and to discuss on practical rapid prenatal genetic workflow. So before that, like I would like to, there are some misconceptions existing. People think whole genome sequencing would diagnose all genetic conditions. But what we need to remember is we need to choose the right test for the right fetus. For example, if we are suspecting Down syndrome, whole exome sequencing is not going to give an answer. A simple FISH and karyotyping will give an answer. So a negative genetic testing means that it is non-genetic in etiology, not necessarily, could be to do with the test chosen as well. So counseling can be done at the time of test report. It is 100% not right. We need to spend time in prenatal counseling, which is mandatory, and more rapid you want the results, more time you need to spend with the couple as such. Why need to spend a great deal of effort looking for something that you cannot fix? We cannot say that the prenatal period is a very, very vital period where the couple is standing in a crossroads and, looking forward for some answer in how to deal with this. And also sometimes it might help us in managing the newborn as such, the genetic testing which is done in the prenatal period, and what we need to anticipate and what we need to predict. So for all these things, genetic testing are important. These are the tests available by and large. There could be conventional karyotyping, chromosomal microarray. Both these things are cytogenetics. And in addition to this, you have QF-PCR, FISH, and MLPA to deal with the chromosomal level testing. You come to gene level testing, there could be whole exome sequencing and whole genome sequencing. So sometimes it might be perplexing, like how this kid is perplexed. So to a little bit simplify on the concept, if you take the whole orange as a whole genome, all the exons which forms only 1 to 2% of the whole genome is on. You sequence that 1 to 2%, which will give an answer in 85% of the omic or Mendelian inheritance. That is, whole exome sequence. Exome is just a part of genome, and they are protein coding region of the human genome. And as I said, it forms 1 to 2% of the genetic code. So if you have to demystify this, what is this clinical exome, and whole genome? So whole genome is whole exome plus whatever information you are going to get in a chromosomal microarray, which is a chromosome based, plus UPD plus repeat sequence. Whereas whole exome sequencing is only the exonic region of the gene. This is the entire gene. The gene has exon as well as intron. If you want to sequence only the exonic region of the entire gene, that is whole exome sequencing. There are about 25,000 genes. To add on it, there is also something called as clinical exome sequencing, where depending on the lab, they sequence around 5,000 to 6,000 genes, sometimes even up to 7,000 genes. So they select the genes of a few of the genes and they sequence the exons of the few of the genes alone. So what is the evidence existing? So this is a article, a systematic review and meta-analysis on the diagnostic yield of exome sequencing for prenatal diagnosis of fetal structural anomalies. Where do we start? Prenatal exome sequencing provides a diagnosis in an additional 31%. So I would like to insist on that. When a CMA or a karyotyping is non-diagnostic. So we should not think that there is a structural abnormality. You have done a karyotyping and karyotyping is going to give all the answers. No, you could have exome sequencing. And also with the Indian population where endogamy and consanguinity is prevailing, I think exome sequencing would give more yield compared to even, whatever is quoted in the literature. So what about the whole genome sequencing for prenatal? This is a prospective multicentric study which is recently published, in 2026 in American Journal of Gynecology. What they have told is, if you are doing a copy number variant sequencing, that is your chromosomal analysis, and you are also doing a trio exome sequencing, They found in the 96 neonates, they had 3 additional fetuses where whole genome sequencing helped, and it did not miss. The most important thing is it did not miss anything which was picked up by a CNB, like in the sense CME, chromosomal microarray or exome sequencing. So, and that increased the yield to around 35%. So, to sum up, your chromosomal microarray will pick up aneuploidy and large copy number variations, which we call it as microdeletions or microduplications. Exome sequencing have limited capacity for that, whereas genome sequencing will pick this up. Single nucleated variant and will be picked up only by exome. Repeat expansion will be picked up only by genome. By and large, genome picks up everything, so increasing the yield from 31% to 35%. So this is a fetus where one of the fetal medicine is finding an abnormality. So it could be a soft marker or it could be a structural abnormality. We put here as a blue color. So your aneuploidy is this brown, which is 1 in 150. Copy number variation will be 1 in 250. Monogenic disorders are somewhere in 1 in 64. So, definitely monogenic disorders are higher up in the list. So we need to, now jump into exome sequencing. So there are like various time period in which these prenatal testing can be done. It can be, cell-free DNA, which is used only for screening. Please do not use this for diagnostic. So your diagnostic modality includes a chorionic villus sampling and amniocentesis, for which you will be sending out chromosomal microarray as well as next generation sequencing in terms of exome and genome. So choosing the test right, no structural abnormality. You just have to do a validated screening and possibly a carrier screening. Major structural abnormality, a rapid aneuploidy screening plus CMA, if negative, consider a trio ES exome sequencing or genome sequencing. Multiple anomalies, which is monogenic suspicion, send both simultaneously, chromosomal microarray as well as a rapid trio, known familial target fetal testing. Persistent unexplained, do for a reanalysis and a postnatal exome or genome. What is the need for rapid? Late detection of anomaly is common. Time-bound decisions and sometimes late referral to specialists, they may not reach you till that particular point. So the rapid testing available includes at a chromosomal level, QF-PCR, FISH for aneuploidy and FISH for known microdeletions, but this is only at a chromosomal level. At single gene level, you have rapid exome sequencing and rapid genome sequencing. Rapid exome sequencing has a turnaround time of 10 working days, and rapid genome sequencing has a turnaround time of around 20 working days. So trio sequencing, so what do, you do not do the fetus alone, because you might have struggle in interpreting the variant which you have found. So you have to sequence the mother to be, father to be, fetus, and if proband is available, it should be along with the proband. For better interpretation, better VUS analysis, and sometimes, autosomal recessive manifesting as compound heterozygous and also terminating the diagnostic odyssey. So when is rapid exome or rapid genome sequencing indicated? Please, we need to follow a phenotypic first model in terms of, multiple congenital anomalies with a negative chromosomal microarray or major anomalies strongly suggestive of monogenic disorder, severe growth restriction with some additional red flags. There is some structural abnormality, known familial disease without an established molecular. And also we need to know when we should not ask for it. When there is a clear-cut multifactorial etiology, only biochemical abnormality, only soft markers with a normal first trimester screening, clear explanation for the structural abnormality, teratogenicity. So the standard care is CME. The International Society for Prenatal Diagnosis recommends exome along with chromosomal microarray so that the diagnostic yield increases, and trio sequencing has an additional advantage of reducing the VUS rate from 15% to 6%. One particular point which I need to get across is prenatal counseling is very important. We need to prenatal counseling, pre-test counseling is very important in prenatal period. You need to say what is the yield, what is the turnaround time, what does a negative genetic testing means to the family, how the results will be. The results can be yes or no, which is very good. You have a clear-cut decision at least at that point. Sometimes it can be uncertain, and how to deal with that uncertainty, whether the parents would like to know the secondary finding or incidental finding. So secondary findings are genes with actionable, pre-approved list of actionable genes. Incidental finding may or may not be actionable. So now coming to the most important part, a rapid prenatal genetic workflow. How are we going to do it? First is define phenotype. Expert ultrasound. It could be added on with MRI or echo. Please do not forget the 3-generation pedigree chart. Select the test, screening versus diagnostic, depending on the ultrasound finding. If you are going to go for diagnostic, do a chromosomal microarray along with rapid exome or rapid genome sequencing. Collect samples, fetal sample, and both parents, and do a maternal cell contamination checking, because it is going to be either a CVS sample or amnio sample. Interpret be a phenotype-driven multidisciplinary review and act. It could be counseling, it could be termination, or it could be continuation. It could be to NICU handover and also recurrence prediction. So there are like advancement, because I need to talk on advances as well. So what is the advancement in this particular arena? So instead of cell-free DNA, we are moving to cell-based NIPT. So this particular thing would impact cells. Instead of cell-free DNA, which is floating in the maternal circulation, people are working on the workflow of segregating the fetal cells from the maternal cells and consolidating everything as a comprehensive genome sequencing from a maternal blood. How easy the job will be. You just have to take maternal blood and you have the comprehensive genome sequencing done on the maternal blood, and everything is done. Other technological frontiers includes an optical genome mapping. This is more of chromosomal, which can kind of detect complex structural variants. RNA sequencing, because sometimes you are get caught with VUS. RNA sequencing will tell about the functionality. Instead of short read NGS, you can go for a long read NGS, where the problem with pseudogenes are avoided. So moving on to two short case scenarios. Scenario 1, Mrs. R. She came with an ongoing pregnancies at only 18 weeks. Consanguineous marriage. She had the first child with spondyloepiphyseal dysplasia as a clinical diagnosis. However, there is no genetic testing done. So what do we do at 18 weeks? So this is actually the step: variant testing for the index, parental testing, prenatal testing, rule out MCC, like maternal cell contamination, and then variant testing in the fetus. But however, we don't have time. We need to rush rapidly because she has come to us only at 18 weeks. What we did a trio along with index. Index showed a homozygous mutation in the COL-L2A1 gene, and the fetus showing an heterozygous variant. However, they reported as autosomal dominant. This particular condition can be autosomal recessive or dominant. So we did with the parents. Parents are heterozygous and they are asymptomatic. So we continued pregnancy and the baby is well. So case 2 presented at 20 weeks with a fetal growth restriction. Femur length is less than third centile, and there was some arch abnormality in the echo, fetal echo. Otherwise, FTS was low risk. Third degree consanguineous couple. We were thinking, okay, third degree consanguineous couple, only risk is like femoral length less than third centile. Cardiac is not that, but still red flag, something red flagged us. So we sent a trio sequencing. After getting a sample negative for MCC, proceeded with a rapid exome sequencing. You can see the turnaround time is 10 days here. So the baby was affected with a homozygous mutation for Adam-Oliver syndrome, and the fetus was affected with the Adam-Oliver syndrome, and both the parents were heterozygous. Okay, coming to the last part, speed matters because prenatal decisions are time dependent. Although CME remains central for structural abnormality, think of ES if, especially if the CMA chromosomal microarray is negative. Rapid trio sequencing is increasingly valuable in selected fetus. The future is an integrated genomic, phenotypic, and fetal neonatal care. So the goal is not the fastest report, getting the right diagnosis with the right degree of certainty early enough to improve the care of the perinatology. Thank you.
Thank you so much, ma'am, for this very relevant presentation. Specifically, the last point which you mentioned, I think, even if we do have tests available to us in rapid time, in faster duration, but we should still have a proper systematic approach. Like you emphasize, phenotype first model should be emphasized. Just having the proper indications and a detailed history will definitely be still the cornerstone, even if we are having advances. And that, of course, who better to learn from you. Thank you so much for sharing your pearls and your unique cases as well. Thank you so much, ma'am. If any questions in the audience? I think your presentation was clear as day. Everybody has absorbed. Am I audible, ma'am?
Yes,
Yes.
Ishita, you are audible.
Okay, okay,
Yeah.
ma'am.
Yeah, that's fine. I think, what we need to remember is we should, move from the conventional and give, uh, be accommodative of rapid change in the genome in this particular field of perinatology to do, the best for the couple as well as for the fetus.
Certainly, ma'am. Yes. Thank you so much for joining us in the middle of a hectic Sunday with personal commitments. And we were very keen to have you, albeit online. Thank you so much, ma'am.
Thank you, Dr. Aparna and Dr. Ishita.
Thank you, Dr. Uma. I'm not sure whether you are able to see us.
Yes, I'm able to see.
Acha. Hi. So thank you so much, Dr. Uma, for joining us on a Sunday morning. And we all know and we all also learned from your talk how passionate you are on prenatal genetics and counseling. And, it comes from a lot of experience that you have created by, counseling many such families where you have made, comprehensive genetic diagnosis in the index child and then help the couple with the right kind of information for their next pregnancy. Thank you so much. We really appreciate your time and it was a great value addition for our conference today. Thank you, Dr. Uma.
Thank you.
So we'll move on now to the next session. Dr. Ishi.
So I invite Dr. Amita Anderson, ma'am, for her next topic. We'll be discussing some soft markers in ultrasound findings, which might lead to some tough decisions. So ma'am will enlighten us further with her vast experience. I invite Dr. Kavya Priya, ma'am, as a chairperson, and Dr. A.V. Ramya, ma'am, also. Please join us on the dais, madams.
Good morning, ma'am. So we are excited for this talk on soft markers and anomaly scans. I hope after this we'll have very crux points to take home.
all those kind of details. Yeah. So we are just going to look at scenarios, or how do we interpret these soft markers, how does it help us with our counseling for the patients. So basically, when we look at a soft marker, what is it? It is an ultrasound finding, and in many cases, it can be transient. Please remember that, because most importantly, say for example, your NT, or if you look at even the nuchal fold, it might be something that is present, but as the baby grows, even in an abnormal baby, even in a baby with a Down syndrome, that NT can reduce. The NFT can reduce and become normal, so it can be transient. It is not a structural abnormality, and it is important that we convey this to the patient. And in a vast majority, it is just a normal variant. So it is not something that the parent needs to worry about and start panicking, and neither is it a cause for termination. But just because these markers, they are more common in babies who have chromosomal problems or aneuploidies, we give them importance and we use it statistically to do a risk assessment. It is definitely not a malformation. So it does not directly impact the outcomes of the baby. Just because the nasal bone is absent, if it is a chromosomally normal baby, there's nothing going to happen to the baby. The nose is not going to be abnormal. The baby is not going to suffer because of that unossified nasal bone. So it is not a malformation. The only importance or the only value these soft markers add is by giving us that probable risk assessment which we can convey to the patient, and our focus needs to stay focused on the risk assessment and not on the marker per se. So even if you take all these unossified nasal bones, which is like the bane of our existence, so if we take these unossified nasal bones, you will see that the vast majority of those unossified nasal bones are normal babies. So in a low-risk population, they are quite prevalent, and they are present in about 11 to 17% of normal fetuses. So which is why it becomes so important to reassure the parents rather than scaring them. And as I said, the clinical importance is based exclusively on the risk assessment. So we always interpret it in context. We look at the prior screening result, take into account the mother's age, and look at whether it is isolated or multiple, and then we decide what we need to convey to the patient. So these are the usual conventional soft markers. Usually the single umbilical artery doesn't come into the list, but I've just added it there because it is causing a lot of confusion nowadays. So when the nuchal fold is more than 6 millimeters between 15 to 22 weeks, it's important. Ventriculomegaly more than 10 mm, echogenic bowel, a renal pelvis dilatation of more than 4 mm in the second trimester, echogenic intracardiac focus, short femur or short humerus less than the 5th centile, presence of aberrant right subclavian artery or a hypoplastic nasal bone or single umbilical artery. These are common things which raise that doubt of, is there a chromosomal problem in the baby? Now, all of these do not behave the same, and we do not give all of them the equal importance. So if you see the first few are stronger, much stronger markers, and which have a much higher association with aneuploidies. So if I see a hypoplastic nasal bone or an increased nuchal fold or an aberrant subclavian artery or ventriculomegaly, my antenna is out. I am definitely going to investigate, and I am going to always think about, is my investigation complete enough? Have I looked at all probabilities? Whereas if I see something like a mild renal pelvis dilatation or an echogenic focus, and especially if these not so strong markers are isolated, many a time we might as well even ignore them. For example, an isolated echogenic focus is something I tell the patients, it's like a mole on your skin. Forget about it. Nothing is going to happen. So another thing that we need to remember is these strong markers sometimes are not just markers for aneuploidy. For example, increased nuchal fold or a ventriculomegaly, we don't think of just Down syndrome. We think of infections, we think of structural abnormalities, we think of a lot of other things. So in which case, the investigation has to be a lot more comprehensive than just looking at the fetal karyotype. So when we see any of these markers, as I said, our mind has to think in terms of risk assessment, not in terms of whether this is an abnormality. Is this something that is, we need to tell the patient that the nose is absent, the heart is having a mark in it. Please let us think in terms of risk assessment and the likelihood ratios. So we look at the prior risk, which might be the maternal age-based risk, or if she's already undergone a double marker, that becomes the a priori risk. We include the positive or negative likelihood ratio of these particular markers and then give an adjusted risk. So now the whole focus shifts from the ultrasound finding to a risk assessment that you are giving the patient. And when you put it in terms of numbers, it becomes so much more easier for us to counsel and so much more easier for the patient to understand. For example, if you tell them the risk of you having a baby with a Down syndrome is 1 in 250, break it down to a percentage and tell them that is like less than 1%. So then it becomes more realistic. It becomes more, it conveys the information much better than telling them your baby's nasal bone is not seen, echogenic focus is seen, because they don't know what does this mean, how does this impact the baby. So when you put it as a risk assessment and give them numbers and tell them this is the probability, they are more likely to understand and accept the tests required also. So whenever we have an isolated marker, just one marker, and everything else is normal, if it is one of those low-performing markers like an echogenic focus or isolated renal pelvic ectasis, I will probably see if the previous risk assessment was done satisfactorily. If the patient is anxious, maybe offer them a cell-free DNA, but I will not be going in for the high risk or the more expensive tests like doing an amniocentesis or things like that. Whereas if it is an isolated marker, but it is a high risk marker like for example ventriculomegaly, I will still give it the importance it requires. I will still investigate to the extent of offering them an amniocentesis, to the extent of talking about whole exome sequencing. Why? Because these are markers not just for Down syndrome, it can be markers for anything, maybe even a metabolic disorder, or maybe a cardiac abnormality, or it can be a torch infection. So these things have to be taken in context. Soft markers are not just for Down syndrome alone. Whereas if you have two markers, then of course, yes, we say more than one soft marker, so it is better to investigate. Whereas if the soft markers are not very high risk markers, again, I will be happy with a cell-free DNA in most cases if everything else is looking good. I would offer them an invasive test if there is a background risk like say advanced maternal age, or if the markers are high risk markers or something of that sort, and if there is something like say single umbilical artery plus two other markers, then yes, I will think in terms of doing a higher testing than just ignoring it. But say it is just a 5th centile femur length, which is a very low performing marker, I will monitor them for growth. I will monitor the skeletal abnormalities, but I will not be thinking in terms of doing a karyotype for that baby or an amniocentesis for this Down syndrome. So increased nuchal fold. So this is kind of just reiterating what I've been saying. Increased nuchal fold is like an extension of the increased NT. First thing I tell people who have increased NT, no NIPT. No NIPT, because we are not thinking of just Down syndrome. We are thinking of any possible chromosomal or genetic disorder. We are thinking in terms of structural disorders. We are thinking in terms of infections. We are thinking in terms of a lot of other things. So when there is an increased nuchal fold, it is important that we do a complete comprehensive workup, and a patient needs to understand that we are trying to identify most common or most prevalent causes, and it is not a 100% guarantee kind of a situation. The same with ventriculomegaly. The scary thing about ventriculomegaly is we can never predict how it's going to go. So I tell my patients it can remain static, it can increase, it can decrease, and I don't know how it is going to go. So if it remains static, if it decreases, everybody is happy. But if it increases even by a millimeter, both the doctor and the patient starts panicking. Why? Because it's something that is concerning the brain. And when we are talking about ventriculomegaly, it can be something the pressure inside the ventricle is increased due to block in the drainage of CSF, or it can be because the brain around the ventricle is not developing because of maybe an evolving cortical defect. So we don't know what is happening, and many of these things become apparent in the third trimester. So that is a situation where we have crossed the 24 weeks deadline. We can't do anything about the pregnancy, and these things can carry significant morbidity. So it becomes very difficult to counsel, very difficult for the patient to accept something like that. So ventriculomegaly is something that is we have to handle with a lot of care, lot of counseling and testing as comprehensively as possible. So this is one such case we had. Patient had borderline ventriculomegaly. We can see that the upper ventricle is bigger than the lower one. At 27 weeks, she started showing nodules in the posterior horn. At the end there, we can see those echogenic bright nodules. So that was a development of a nodular heterotopia. And this was a patient who had ventriculomegaly of around 10, 11, just borderline. But this is somewhere we can never predict how it is going to go. Echogenic bowel. This is something which I will say is very overdiagnosed, and this is because we need to do our machine settings properly, and of course the workup should include infections, and we need to also think of genetic abnormalities like cystic fibrosis, though it is not as common in our population. Renal pelvic dilatation. Again, please understand there are cutoffs. 3.2 at 20 weeks is not renal pelvic dilatation. At time of TIFA scan in the second trimester, we use a cutoff of 4. After 28 weeks, it becomes 6. In the third trimester, we have a cutoff of 8. So if we have a renal pelvis dilatation of 4.4, it requires follow-up. And most of the association with aneuploidy is mild renal pelvectasis. Once the renal pelvectasis is hydronephrosis, that is if supposing instead of 4 we are having 6 or we are having 8 and there is a significant dilatation, we are thinking in terms of urinary tract obstructions. We are not thinking in terms of Down syndrome there. These echogenic focus and short long bones isolated don't really carry much weight. And saying that, here I'm showing you something a little different. You see that little bright thing over there, that was reported as echogenic focus, but then that is big. That is not like the normal papillary calcifications that we see. That was actually a rhabdomyoma. So it is important that we understand what these calcifications are. And echogenic focus, whether it is one, whether it is multiple, whether it is in the right ventricle, whether it is in the left ventricle, it still is echogenic focus, carries the same weight. And there is no need for us to keep measuring the calcification and seeing whether it is increasing. Doing repeated scans to see whether it is there, it is not there, whether it is growing, whether it is disappearing, it doesn't really require any of that. Now, when I'm talking about cell-free DNA, it seems like I'm talking about something which is from the previous generation. Now, cell-free DNA has become an over-the-counter. Anybody walks in, anybody asks for it and gets it done. But we must understand that cell-free DNA is a very good test for trisomy 21, 18, 13, but it is not for every other chromosome. It is not for every other genetic abnormality. If your NIPT is low risk, yes, I'm happy to ignore these weak markers. But like I said, in an increased nuchal fold, in an increased ventriculomegaly, I will not do NIPT. NIPT is not recommended because we are thinking not just of Downs, we are thinking of maybe some kind of a single gene mutation or a copy number variation or something else. So those are things that NIPT does not cover. And please remember, whenever there is a no call in a patient with soft markers, that is a red alert. A no call NIPT might be an indication that it is a higher risk for chromosomal abnormalities. So yes, we do reassure patients based on soft markers and cell-free DNA, but please, we need to be able to differentiate where we do soft markers and cell-free DNA and reassure, where we do not do cell-free DNA. So soft markers still hold their place. Now we have a situation where a 34-year-old, low risk in cell-free DNA done at 11 weeks, nuchal fold at 6.5 mm, just over the borderline, otherwise normal anatomy. Now this patient says, my doctor in the village called me an elderly gravida, so I'm already at high risk, which is why I did the NIPT. Now NIPT is normal. You're saying rest of the baby is normal. So why are you scaring me? Are we justified? Is she right? Can we let things go? Same, even though cell-free DNA is a good test, it is a screening test. Much better than just soft markers alone, but it is not a confirmatory test. So even though the cell-free DNA is normal, if I am going to offer this woman any kind of a testing, I will still do the microarray, I will still do the FISH to look at Down syndrome also. And as we had mentioned earlier, we will test for other possible genetic abnormalities also. And I would rather offer her an invasive testing rather than try to reassure her based on follow-up or frequent scans or things like that. So when we are counseling patients on soft markers, it is important that we are very clear about the terminology we are using. For example, unossified nasal bone creates a very different picture in a person's mind compared to absent nose bone. That is something that is very scary for a layman. So it is important that we agree on proper terminology and be very clear that many of them are variants, normal variants and not abnormalities. And we talk in terms of risk ratios. What was the risk before the soft marker was seen? What is the risk after the soft marker was seen? How do we interpret? We give them options regarding, does this require testing? If we do the test, what is the detection rate? If we don't do the test, what is the risks they will face? And after the reports come, do they need further testing? Does it mean that everything is fine? They need to be able to understand the report and understand those ratios that we are giving them. And it always helps to have a plan of action documented. So we say, okay, you have a renal pelviectasis, you have an echogenic focus, we are going to do a cell-free DNA. The risk assessment is going to come like either high risk or low risk. So if it comes as high risk, we do this. If it comes as low risk, we do this. And this is how we are going to take you through pregnancy. It helps to have a plan of action so that there is no confusion in the mind of the patient, and the doctor is also able to work as per protocol. So this puts things in perspectives regarding soft markers, and it's not something like you're handling, you're not firefighting all the time regarding soft markers. So we use markers to modify risks. So we always convert the findings into risk ratios. And isolated and weak markers, often all it requires is just reassurance. But strong markers, like I said, irrespective of the risk ratios, it still needs further evaluation. We need to standardize our counseling and the words we use. And in difficult cases, in bad cases, it helps when we support the decision making of the couple by giving them the correct information and guiding them regarding the possibilities of risk, possibilities of normal baby, give them the complete information and help them put things in context. Thank you so much.
Thank you, ma'am. That was a comprehensive talk covering all the gray areas we have in day-to-day counseling the patients. Ma'am, I have one doubt. In single soft marker, especially high-risk soft markers like absent nasal bone, what is your experience in micro-array abnormalities without aneuploidies, having CNV deletions and duplications without aneuploidies?
If you take, say, like you mentioned, hypoplastic nasal bone or unossified nasal bone, microarray abnormalities, yes, we have got positive reports, but they are very rare.
Okay.
So, again, as I said, when we counsel the patient, we give them an offer of an unossified nasal bone, telling them in very rare cases there have been other abnormalities which we do not expect. If you want, you have the option of a amniocentesis also, but this carries a 0.5% risk of miscarriage. So, the patient also knows that this is not, we are not giving them any kind of a guarantee warranty situation.
Okay, ma'am.
If it is something like ventriculomegaly, yes, I will say around in about 5 to 10% of those whom we test, we do find abnormalities.
Okay, ma'am. So we go for high resolution microarray in these cases, right?
If you are
750K.
doing a microarray for a nasal bone in the hope of finding something else, it has to be high resolution. If not, you are fine with the karyotype.
Okay, ma'am.
It was a very qualitative and you've put your point straight on. So I hardly have anything to ask, but I have few clinical scenarios. Recently, I was referred a case of IUGR borderline, borderline, and mother was having PIH, and it had abnormal Dopplers as well. But the IUGR child has a polyhydramnios, like say about 40. So what were the soft markers which were missed back then while performing TIFA or NT? Like how should we come to a conclusion that why did the child die? So can you add anything to this IUGR with poly combination?
This IUGR with poly combination is a scary combination.
What could it be?
And when we are talking about something like that, yes, of course, soft markers need to be looked into, but I will be looking in more in terms of whether there is some kind of a structural abnormality and whether the movements of the baby is fine, whether there is anemia in the baby, is there an open neural tube defect, is there any other cause, like is the baby swallowing fluid, is the esophagus patent, is the bowel okay. So that will be more in terms of a structural assessment and functional assessment of the baby rather than looking at soft markers. Here we are not looking at aneuploidies. We are not thinking of Down syndrome. We are thinking of, like say if it is a fetal akinesia sequence or something of that sort. It will not be Down syndrome. So then we are not talking in terms of soft markers. We are looking at structures and looking for major abnormalities.
So should we ask for anything in specific for an elaborative fetal autopsy? Because yes, it has to be only a predictive thing. I can't go back to the TIFA, NT where it was done somewhere else.
In such a situation, I will definitely recommend a genetic testing for the baby, and since it is postnatal, we don't have time constraints. If cost is not an issue, we can go as far as whole genome sequencing, which was just mentioned.
Yeah.
Work backwards, like do the trio sequencing with the parental testing and all of that. And autopsy is a huge plus. So definitely I will give them the option of an autopsy plus the genetic testing also from the fetal tissue itself.
Okay. Would a partial autopsy be enough, or should we send for an elaborative autopsy?
See, a partial autopsy is probably as good as your ultrasound.
Okay.
So I would want a detailed
Full detailed autopsy. Also, ma'am, we get to see certain cases where the nuchal fold thickness is increased. Say like now you said it is 6 mm. For say about a 5 mm where CFDNA is negative, they haven't gone for an amnio or whatever. So how should be the follow-up? How should we counsel them for the follow-up, and are there any specific markers that we should suggest from gynecological point of view?
See, when we look at an increased nuchal fold, as I said, it's like a workup for an increased NT. Most important thing is chromosomal. And when you're saying chromosomal, it is not just the karyotype, it is looking for single, it might be a uniparental disomy, it can be Turner's, it can be Noonan's, it can be anything. So in which case you cannot stop with doing a karyotype or doing just a low resolution microarray. This requires a higher level testing. You will have to offer them whole exome. And these babies, a very detailed examination in the sense like looking at even the cardiac function or
Yes.
looking at the neurological, dynamic neurological evolvement over the period of time. These are things which might help give information.
Okay. Ma'am, how many soft markers, like you've mentioned low risk soft markers, if we have picked up, say about 3 to 4 soft markers, what is the actually,
High risk.
oh, that's a high risk. So 2 is a low risk?
If it
One?
is a low performing, like say I have short long bones and I like a short femur and I have an echogenic focus, I'm still okay with it. I'm okay with their NIPT. If their double marker is low risk, I'm relatively okay. But if you have unossified any of those big, strong performing markers with additional markers, it needs testing.
Suppose if it's an EIF and echogenic bowel, should I send them for an amnio? Or from maternity point of view, can I counsel them for IUGR or PIH or?
You will counsel them for IUGR, PIH and all of that, and you will have to have a fetal medicine opinion
Yes.
also regarding the echogenic bowel. First thing is echogenic bowel, we need to make sure if it is really echogenic and it really needs testing and then take it forward.
Because it's a very common finding we get to see on the reports.
Yes.
Yeah. Also, ma'am, you spoke about the pelviectasis. So when should we, because patients often they are very worried, madam, is it a structural abnormality? After baby is born, what is the correct point I should put on table? No, this is a structural abnormality. This is how you have to follow up. And this is when you have to meet a pediatric urologist, because this I commonly face in my OPD.
So when I see pelviectasis more than 4 mm at TIFA, I tell my patients this is something which resolves on its own in more than 95% of cases. In that small 5% of cases, it might increase, and maybe in 1 or 2%, it might increase to the extent where it will require management after birth. And to tell them whether they need to meet a urologist, I will probably wait until the 3rd trimester, or if it crosses a 10 millimeter mark, then I say yes, definitely this needs treatment postnatally, so please keep the urologist in the loop.
Also, you have mentioned about the thickened bladder wall and also oligo. What does it signify when it comes to pelviectasis?
See, a thickened bladder wall is just like any other muscle which is overworking and hypertrophying. So if there is a lot of bladder obstruction, that is when you get the thickened bladder wall. And if there is oligohydramnios, it means that
The urine obstruction.
So that is not a good thing.
When do you say it is a posterior urethral valve issue when it comes to pelviectasis or?
That depends on your ultrasound findings, and you see a bilateral or an entire system dilated, you have a posterior urethra that is dilated, then based on the findings, we take a call.
Thank you so much, ma'am, for patiently answering. Thank you.
Thank you. I appreciate the question.
Yeah. These are very common scenarios which I get to see in my OPD.
These are common scenarios, everyday scenarios.
So when to involve fetal medicine, I think every issue I involve a fetal medicine, I'll be more tensed than the couple actually. So I involve fetal medicine in every scenario as you've mentioned.
For us, isn't it?
Thank you, ma'am.
Thank you.
Thank you so much, Dr. Amita ma'am, for your lucid presentation and the very interactive and the detailed questions have definitely helped many of us. I request Dr. Aparna ma'am to please hand over the memento to Dr. Amita ma'am. I welcome Dr. Nihal Reddy sir for our next talk on fetal neuroimaging and where do we stand now. While sir's presentation is getting projected, may I request Aparna ma'am to please hand over the memento to Dr. Kavya.
The next talk is about fetal neuroimaging. We have Dr. Nihal sir with us. He's a consultant pediatric neuroradiologist from Rainbow Children Hospital. Sir, stage is yours.
Thank you very much. At the outset, I thank Dr. Apana for the invite. All right. Without further ado, some basic concepts and advances on fetal MRI. I know most of the audience here is non-radiology or gynecologists, obstetricians, neonatologists. But my main question here is, visually, which is the best image for an optimal diagnosis? A, B, or C? Anyone for A? A is good. What about B? B also good. C? Not so good. Noisy. That's right. B is the right answer. So before going into the diagnosis, we need to get the protocoling right. But what is causing the difference? Is it because it's a low Tesla magnet or it's a higher Tesla magnet? Do you agree that possibly this could be a 1.5 versus 3 Tesla? Maybe. But all of them are 3 Tesla magnets. So if it's a 3 Tesla magnet, it's not always that these sequences should be optimal. You need to protocol it properly. You need to protocol the slice thickness properly. So usually around 3 to 4 millimeters is a good slice thickness. Whereas if you go lower down, there's more noise introduced into the scan. Hence the last scan, which demonstrates these noisy, grainy appearance. So even though it's a higher magnetic field, the protocoling is very important for diagnosing these field conditions. So 1.5 to 3 Tesla, I predominantly report the scans on 3 Tesla magnets. As you can see, the upper heat map demonstrates a more increased signal intensity. So signal noise ratio is more in a 3 Tesla magnet, so almost 4 times more in a 1.5 Tesla magnet. So more signal from the magnetic field is more details of the scan, whereas the noise slightly increases from 1.5 to 3 Tesla, but not as proportionally or as bad as what we see. So that's reasonable. So 4 times increase in magnetic strength, 4 times increase in signal details. So 3 Tesla is usually preferred for diagnosing these fetal conditions. We all know what are the main indications for a fetal MRI. The fetal medicine specialists send them most commonly as we are highlighted here. I'll not go into detail. So this is the main protocol which we use at our centers. Slice thickness is approximately around 3 to 4 millimeters. We do a 3D axial SAG coronal T2 weighted sequences. When we do a T1 gradient and a T2 gradient, and then we do a diffusion weighted sequences. I'll come to the applications of these with various conditions, but these are the main protocols. The patient is usually in the left lateral decubitus position. It approximately takes around 30 to 45 minutes for completing these scans. Once we have a scan on table, we first correlate the gestational age, look at the ultrasound reports, look at the corrected gestational age, look at the LMP EDDs, and then we do a various spectrum of biometrical calculations based on the gestational age. Then we go on to sulcation gyration pattern. There are many atlases which we use for correlating the sulcation gyration pattern. This is the one I use. This is developed by the Boston Children's Group. So it's a freely available online resource. From gestation age from 21 to 34 weeks is available. Normal sulcation pattern for this. So when you have a scan, you open up this window and correlate whether the sulcation gyration pattern is matching with the gestational age. Those are the main highlights of the sulcation gyration pattern. I'll not go into detail, but yeah, those are the main ones appreciated at various gestation age on the left side. Then once we see the sulcation pattern, once we see the biometry, then we move on to look at the lamination. So it is important to differentiate the 3-layer pattern versus the 5-layer pattern. So 3-layer pattern is seen commonly in the first 20 weeks of gestation. So if you don't expect a 5-layer pattern to develop before 20 weeks, that is at least before the early second trimester. So it is again divided, the 5-layer pattern, it appreciates more in the 28 weeks gestation. You have from inward to outwards, that is the germinal eminence, you have the ventricular zone, the intermediate zone, the subplate, and the cortical plate. So 3-layer pattern up to 20 weeks, 5-layer pattern after 28 weeks. Anything abnormal to that, any deviation, think of an abnormality in neural migration. So we'll first concentrate on the ganglionic eminence and the subventricular zone, that is the innermost layers. So look at the first scan over here in the circle. You can appreciate again focal nodular deposits. These are along the subventricular zone. So it is not smooth. We have already seen an ultrasound demonstrating the nodular foci. And on the MRI, you can appreciate these bottom bilateral occipital horns demonstrating these nodular foci. So abnormality in the subventricular zone, these are abnormalities of nodular heterotopia. Whereas look at the ganglion eminence on the later scan, on the left side scan. They are prominent, they are cystic. So this was a case of a ventriculomegaly associated with abnormal basal ganglia, abnormal thalami, because there is an abnormality in the ganglionic eminence. And this later turned out to be a case of tubulopathy. So appreciate the normal anatomy and then look for deviations and look for the abnormalities and conditions. Then we have the intermediate zone. That is, intermediate zone is the fetal white matter, predominantly associated with the afferent and efferent axons. That is the one in the light green area over there, the periventricular deep cerebral white matter. And then when you look at the abnormalities on the fetal scan, this was a case of CMV infection at 32 weeks. And you can appreciate the arrows pointing out there. You have some white matter rarefaction out there, some subependymal cysts, especially in the choriothalamus groove, ventricular septations in the occipital horns, and also ventriculomegaly. So abnormality predominantly in the intermediate zone, that is the cerebral white matter. Look for rarefactory changes, look for septations, and ventriculomegaly, and these should point towards a possible diagnosis of torch infection. Then you have subplate. The subplate is the one from the deep white matter going up to the almost of the cortex. So that is how the normal subplate should look like. It is the bright echogenic area between the cortex and the intermediate zone. And on diffusion weighted sequences, the periventricular white matter is bright, normal, then it should be dark, then the cortex should be again bright. So that is how the normal subplate area should look like on an MRI scan. Any deviation from this, the first scan, look at, there's complete absence of gyration over there. You can appreciate that the subplate region and the cortical region is abnormal. So that at 23 weeks this is a normal pattern, that's the abnormal pattern, that's dyssencephaly. And on diffusion weighted sequences, you can appreciate again that there's abnormality of the layers of the diffusion weighted sequence. Look at the abnormal layer over there, bright, dark, bright. Over there, there's an abnormality of the differentiation of the bright, dark, white matter layer. So diffusion can help in identifying neuronal migration disorders if missed on the T2 weighted sequences or T1 weighted sequences. Ventriculomegaly, again, the most common indication for a fetal scan. I'll not go into detail, as you know, many of these conditions are associated with it. But on the MRI, on the axial sequences, we need to appreciate, look at the cavum septum pellucidum, the trigones, and the calcarean sulcus. That is where you draw a line for measurement of the ventricles. It should be less than 10 millimeters, 10 to 12 is mild, over 15 is severe. Third ventricle, preferably on the coronal sequences, should be less than 4 millimeters. And fourth ventricle, preferably on the SAT sequences, should be less than 7 millimeters. Then midline abnormalities, again, once you suspect that on the fetal ultrasound, an MRI is sent. So that is how the normal SAG corpus callosum should look like. You have the rostrum, genu, body, splenium, and then you have the anterior and posterior commissure. So normal outline of the corpus callosum, very important to note. The gestational age is important because corpus callosum keeps developing. So look at the gestational age. If it's in the first trimester, it is not completely developed, formed. But usually in the second trimester onwards, if there's any abnormality in the corpus callosum, this is a classic case of commissural agenesis. You can appreciate that the commissure is absent on the SAT sequences. And on the coronal sequences, you have this bullhorn type appearance of the frontal horns and tiered up appearance of the ventricles. So this is suggestive of corpus callosum agenesis or commissural agenesis. They can be again acquired and genetic causes. Then we concentrate on the posterior fossa. So that is how the normal posterior fossa should look like. Axial sequence, that is the normal cerebellum. SAG, you have the brainstem anteriorly and the vermis posteriorly. And on the coronal sequence, again, that is how the normal cerebellum should look like. So what are the various abnormalities of the posterior fossum seen on the cerebellum? The first one of the most common findings we see on MRI, Dandy Walker malformation, you have vermian hypoplasia. The vermis, as you can see in comparison to the normal vermis, it is upwardly rotated. You have a cerebellar tail sign, that is the inferior vermiform lobule. So that's dandivacuum malformation. Vermis hypoplasia isolated. Look at the gestational age, look for the measurements. It's an isolated finding. And then you have pontocerebral hypoplasia. You have hypoplasia of the brainstem, especially the pons. Look at the normal pons out there, brainstem. It is reduced in volume. The vermis is also reduced in volume. So PCH, usually genetic. Then you have only megacisterna magna, more than 10 millimeters of the cisterna magna on SAT sequences. That's the megacisterna magna. The brainstem and the cerebellum is normal. And you have Blake pouch cyst, again, slightly increased tegmentovermin angle out there. And this usually causes hydrocephalus or ventriculomegaly. So these are the most common posterior fossa findings which you usually see on a fetal scan. Again, we have seen some changes of diffusion weight sequences. How is diffusion helpful? Especially in cases of ischemia and infarcts. Look at the ADC sequence out here. The left side is normal, that is the bright side is normal. Whereas on the right side, you can appreciate the arrow marking out a low signal on the ADC. This is suggestive of an infarct out there. And that's another case of hydrops vitalis. You can appreciate an extra-axial hemorrhage out there. Since it is acute and subacute in nature, it demonstrates bright signal on the diffusion weight sequences. So sometimes the timing of the blood can also be appreciated on the DWS sequences. If it is bright, it is usually in the acute to early subacute stage. The other sequences which use T1 and T2, predominantly T2 star images, predominantly for hemorrhage. You can appreciate on the T2s, you can have a heterogeneous signal out there in the right caudothalamic groove going up to the frontal white matter. And on the T1 weighted sequences, it is completely bright. So that is suggestive of blood products. Also on the T2 star images, again, bright signal, dark signals out there. And on the last image, you have cerebellar hemorrhage. Look at the pointer out there. The opposite side is normal, whereas a dark foci is standing out there on the right-hand side. So that is indicator of cerebellar hemorrhage. And this is the postnatal scan of the fetal scan. You can appreciate, you have some cystic porencephalic dilatation out there, hemosiderin deposits, dermal matrix hemorrhage. I will not go into the various grades, but yeah, starts from mild to severe in ventriculomegaly. Yeah, thanks. I think this is my last slide because my talk is only for 10 minutes, but yeah. So these are the advanced sequences. We don't usually use this at our centers, but these are being carried out. So diffusion tractor imaging, it is predominantly seen to use to identify the white matter tracts, especially the corpus callosum. That is the corpus callosum. And when you do tractography, you can appreciate the extent of the corpus callosum. It binds two hemispheres, that is the right and left hemisphere. That is the anterior aspect of the corpus callosum. That is the posterior aspect of the corpus callosum. So tractography can be seen to assess the corpus callosum. Spectroscopy, again, very initial stages. Sometimes can be, you can appreciate lactate peaks for mitochondrial disorders, infections, but again, not at the moment widely used for clinical practice. Then you have volumetric analysis. Volumetric analysis gives you the volumes of the various lobes. These can be sometimes reduced in torch-like infections or conditions with microcephaly. Again, these are the advanced sequences. We currently don't use them at our practice, but yeah, these are being used elsewhere and possibly can be come into clinical practice pretty soon. That's my last slide, so thank you for your time. If any questions, I'm happy to take them.
Thank you, sir, for this detailed topic delving into the insights of fetal MRI. Do we have time for questions? Or maybe one question from anyone?
Second trimester up from 20 to 24 weeks. Ideally, because before 20 weeks, the movement is slightly more, so there can be artifacts over there. And usually after, in the second trimester, the fetus is in cephalic position. So once it's in cephalic position, the movement artifacts are negated. And even for migration abnormalities and stuff, after 21 weeks, it's better.
Dr. Amita ma'am to kindly felicitate sir with a memento. And I request Dr. Aparna ma'am to please give memento to Dr. Ramya ma'am. So moving on to our next session, one of the very widely discussed and widely encountered conditions in fetal medicine, FGR. I invite Dr. Navya K.C. ma'am as the speaker for this session and Dr. Aditi madam as the chairperson. Madams, please.
So FGR is one of the topics that we, day to day we see it in our practice, and it's something that we need to revisit at regular intervals because of so many dilemmas involved with it, and there are so many guidelines, consensus, and the all important question about when to deliver the baby without compromising between the obstetric outcome or giving a very preterm baby to the neonatologist to manage. So I would like to invite Dr. Navya as the speaker. Dr. Navya is a fellow alumnus from PGI Chandigarh, and she's done her fellowship under Dr. Anita Kaul ma'am from Apollo. And currently she's working as a consultant and the director of the Fetal Life Clinic. So Dr. Navya, you can take over now.
Good morning, everyone. In the outside. Good morning, everyone. In the outside, I thank Dr. Aparna ma'am and Ishita for organizing this wonderful meet. The bond, which actually introduced both obstetrician, fetal medicine, and also neonatologist, and the concept of perinatology is wonderfully amalgamated in this conference. Hope I give justice to the topic what I'm given. And even though Ishita has introduced this as a very important and hot topic, I was given only 10 minutes. So I'll try to concise in this 10 minutes. And my topic is fetal growth restriction, the timing of delivery in this era of precision perinatology. And when we see the burden of fetal growth restriction, as already mentioned, it is around 3 to 10% of all pregnancies, and which increases stillbirth rate to more than 10%, 10 times more than the normal growth. And this is the cause if we see 20% are associated with chromosomal and genetic anomalies. And this not only stops there, it also is one of the important cause for 20 to 40% risk of long-term cognitive and learning disabilities. But there is one good thing in that, it is the leading cause of stillbirth, but it is an identifiable risk factor. Because the undetected FGR versus antenatally detected FGR, there is a 8 times fold high risk of stillbirth rate if we don't detect it antenatally. So I want to walk you through some case scenarios before jumping into the topic. This is a case. She is a gravida 2 and previous one abortion history. She came to me in her first pregnancy. It was terminated in view of some kind of a multiple structural defects, and we have worked out for the entire case. And with the trust, she came to me in the second pregnancy. Everything was going normal. NT, TIFA, fetal echo was normal. And her enhanced FTS was low risk for aneuploidies, and NIPT was low risk, which was advised by her gynecologist after the FTS, which were also low risk. But she was screened positive for preeclampsia. And yes, she also developed preeclampsia at around 24 weeks, and we started her on labetalol. And this is her growth charts, growth curves of abdominal circumference, which started showing at around 28 weeks of fetal growth restriction, and also the estimated fetal weight started falling below the red line. And we kept her under close monitoring with the Dopplers every weekly, and later every third day was essential because of the changes in the Dopplers. And suddenly the baby started showing ADF and also signs of REDF. Then we have to jump in and plan delivery at around 32 weeks. It was 1.2 kg baby, ill and healthy. And the couple were very kind enough to send me every first of their baby from day 1 and month 1 and year 1. And the baby is doing ill and healthy. And the case 2 is 39 years old, IVF conception with DCDA twins and with donor embryos, and referred to me at around 22 weeks with a FGR in 1 twin. And yes, we confirmed the diagnosis. It was a twin A, one baby with severe FGR at 6 centile with normal Dopplers, and twin 2, normal growth at 18 centile with no. And as a routine workup, we offered amniocentesis, but they opted out. We respected their plan, but the maternal torch and other things were normal. And we followed every 2 weekly as per the protocol, and then weekly after 26 weeks when the umbilical PI started showing high resistance, and delivered the baby at 35 weeks from 22 weeks. And twin A was 1.7 kgs and twin B was 2.2 kgs. And 1 year old, baby is ill and healthy. And case 3, it was a 24-weeker primary gravida, spontaneous conception with MCDA twins, referred to us as a FGR. When you see the picture, you can see one baby showing a poly, another baby showing a oligo. And there was bladders were visible. And you can see the AC and estimated fetal weight graphs which showing normal growth. Now you can actually, there is any change in the diagnosis now? Yes, it is obviously TTTS stage 1. So we counsel for expectant management, pulled her until 29 plus 3 weeks where she went on a spontaneous prom, and baby were 1 and 1.1 kg. She recently delivered, and baby is at day 10, ill and healthy. And this is another case, 27-year-old primary gravida, spontaneous conception and MCDA pregnancy. And they were referred to us at 9 weeks itself with the early onset FGR. Yes, when we did a 10-week scan for a viability, the CRL discrepancy was more than 33% between the twins. And so we kept her under close surveillance, this time every weekly instead of 2 weekly. And at 17 weeks, the baby started showing symptoms. Yes, it is SFGR of type 2. So we had to do a microwave ablation of one twin to save the other co-twin. And the baby is doing fine as of now. And this is another case, referred at 21 weeks with same kind of SFGR, where the scenario is a different thing. It is a SFGR type 3, where you can see the alternate cycle of AREDF. And we had to go for radiofrequency ablation to save the co-twin. And the baby delivered at around 38 weeks, the other baby, and 3.6 kg, baby is doing well, and 1 year of age. Why I'm saying all this, prenatal care should be individualized with a planned delivery protocol. As of now, this is what I'm going to emphasize in my talk, why timing matters, why we are more emphasizing on the timing. And now I'm not going to talk about the definitions or diagnostic criteria because my duration of talk is also very less, and I'm also going to say a few words about how is the Doppler cascade going to help me in diagnosing and surveillance protocol, how to time and what mode of delivery should we go forward, and what is the words about twin pregnancy and the fetal growth restriction. Because we are all very familiar with this chart, which we actually follow, every fetal medicine specialist follow this in every day-to-day life, and I'm not going to go in depth of definition of FGRs, and not even the pathophysiology of stage-based classifications which we are familiar with. I want to talk about the significance of time delivery. Why we are talking about delivery time? Because why to wait? If I find an FGR, why can't I go and deliver? If I give even a 500 grams baby to Aparna ma'am, she is going to save the baby. So why I have to wait in this era of advanced NICU care? Because survival, the live birth, is not the goal. It's a healthy fetus and healthy child with the intact neurodevelopmental outcome, and lifespan is the goal. So this both are, the survival and the healthy fetus, is not synonymous. That is what I'm going to emphasize here. As said, FGR is a diagnosis, it's not a disease, which is with early prenatal recognition. It itself is a life-saving intervention. So easily predicted in this advancement of field of fetal medicine, and management plan meticulously with precision care, we can have a better perinatal outcome. It cannot be done with one person. It is a multidisciplinary approach with the obstetrician, neonatologist, and fetal medicine specialists combined together to give a better perinatal outcome. So all these concepts are supported by major trials which shape the modern practice like GRID, Truffle, and Digitat, which says that immediate to delayed deliveries has given a very promising outcome in the 2-year follow-up of these babies. So how long to wait is the next question, for which we have to understand the physiology of organogenesis. In every day in the womb matters because it is the gain of survival, intact survival of around 1 to 2% every day inside the womb until 32 weeks. So it is a bigger thing because gestational age at delivery is a single stronger determinant of perinatal outcome. Because the fetal brain has a week by week constructive projects from 24 weeks to 39 weeks like cortical folding, myelination, synaptogenesis, which are most often sacrificed to iatrogenic deliveries. And you can actually talk about, there is a vasodilation. So why we have to think about more about this kind of a time delivery, that is, why can't I deliver at 28 weeks? Because this concept of brain sparing effect, that is MCA vasodilation, is going to protect only the circulation, perfusion of the brain. It is not going to fully give the oxygen or substrate delivery for this constructive project of the brain, which is happening between 24 to 39 weeks. So the lung also, in the racing between saccular to alveolar transition, this is very, very important between 24 to 36 weeks because it reduces the respiratory distress syndrome from 35% at 30 weeks to 10% by 34 weeks. So thus, every single day means more capillaries, every single day means more surfactant, and every single day means better survival. The survival rate increases from 50% at 24 weeks to 95% beyond 35 weeks. So since every organ is in the mid program, when FGR forces a decision like gut, kidney, cardiovascular system, endocrine, metabolic, immune systems, and thermoregulation as well, so now we are in a clinical dilemma between the hostile uterine environment and between the iatrogenic prematurity, and to intercept the fetus exactly at the transition where the risk remaining in utero outweighs the neurodevelopmental risk of the preterm delivery. So delivering too late we should not put the fetus into exposure of hypoxemia and acidemia, and delivering too early, we should not interrupt the organogenesis which is happening and cause a long-term neurodevelopmental insult and also metabolic programming injury to the baby. So how to predict this time of action and give a balance between the stillbirth and hypoxic injury is that we have to see what is the intersection, that is the optimal delivery window. By close fetal monitoring and surveillance is all that is needed. By looking for whether there is any changes in the Doppler or biophysical profile with stage protocol, there comes a fetal doctor. And the effects of this iatrogenic prematurity on this already ongoing superimposed preeclampsia is not going to be an immediate effect only in the neonatal life. The bill comes due across the lifespan. In the infant childhood, in the form of any kind of learning disabilities, cerebral palsies, attention deficit disorder, which we are seeing numbers are increasing very fast, and even in the adolescent life where it can cause extreme of disorders. So before planning any time delivery, we have to confirm the cause, be it a maternal, fetal or placental causes, by doing a detailed anomaly scan, angiogenic markers if there is any need, and also for genetic testing and also torch profile if there is needed. And how to do this surveillance? As I already said, this continuous fetal monitoring should be done whether to go for a Doppler, CTG or a combined. Still the gynecology friends of us will talk about CTG, but the literature says that nor in the form of seeing the intrauterine fetal status, or it cannot forecast any kind of fetal behavior during labor, but and not even it doesn't give any kind of optimize the timing of induction for labor. But the sensitivity and specificity of Doppler is much more than the electronic fetal monitoring, but we also be very much sure that it is all these tests are complementary to one another. So we have to be sure that Doppler is with biophysical profile should be used for antenatal period and CTG only reserved for the labor period. And how to predict this Doppler cascade? We all know the stage surveillance where first the uterine artery goes for the compromise, and then umbilical artery, then the middle cerebral artery, then the ductus venosus, and then comes your CTG changes. And these stages, your fetal medicine specialist will be able to tell you how frequently we have to surveillance this kind of a babies, whether we have to go for a weekly or a 2-weekly Dopplers, or whether there is a need for any kind of a closer monitoring when stage 2 comes, that is in every second day or third day, or every twice daily, or when there is whether there is any need for immediate delivery. This stage protocol clearly says that it is all practiced worldwide. And what mode of delivery, how to deliver safely? For a stage 1, yes, the vaginal or induction is okay. But stage 2, we have to give the patient for a cesarean, which is preferred. And stage 3, cesarean section. If the patient comes to you at around 32 weeks with the Doppler findings of reversed end diastolic flow or a ductus venosus showing 95th percentile, don't think twice. Go for cesarean section immediately after covering up for steroids. And if the patient comes with a stage 4, that is abnormal A wave, and regardless of any gestational age, we have to deliver the baby immediately because baby is undergoing acidosis. So there are some kind of absolute indication where we should not wait for this Doppler changes to occur, such like in fetus when the baby is presented with a recurrent or persistent late FHR deceleration, or there is a sinusoidal pattern in the CTG, or there is a biophysical profile, or absent or reverse diastolic flow in the ductus venosus. As I have already mentioned, we have to deliver immediately without waiting for any kind of a planned delivery. And we should not forget this neuroprotection and also magnesium sulfate, which the dosage and the time duration we all very much familiar with. And words about the twin pregnancy with selective FGR. SGA is the same concept, both in singleton and the twins. The definition is less than 10 centile. In DC, treat like a singleton. For MC twins, we have a different kind of a setup because the cutoff here is 24 weeks for a early and late onset FGRs. And there is also a Doppler patterns which says that whether the baby is in type 1, type 2, type 3, accordingly the management changes. And what I want to say in the FGR in twins fetal monitoring is, after confirming the etiology, after offering them amniocentesis if they prefer to, we have to treat the DC twins with the FGR like a singleton. And estimated fetal weight discordance should be mentioned in every scan from 20 weeks onwards in a DC, and in a MC twins it is from 16 weeks onwards. Follow-up scan should not be waited beyond 28 days. That is, in DC, every 4th weekly you have to follow the baby, and in MC every 2 weekly, which is a very, very important guideline. And umbilical artery Doppler weekly if there is a discordance of greater than 20%. And if there is any substantial risk of fetal demise of one of the co-twin in the MC twin before 26 weeks, don't wait for it. Go for selective fetal reduction in whatever way you are comfortable with, like RFA, microwave, or bipolar, to avoid the co-twin demise and also neurodevelopmental delays. Further progression to any estimated weight discordance of greater than 25%, please refer to a specialist fetal medicine unit for further assessments. So I want to end up saying that every day in utero is a physiological decision, balancing the risk of placental insufficiency against the risk of iatrogenic prematurity. So my take-home message will be, timing is the treatment. Timing is not very, very important for the FGR, and every gestational day shapes an organ. So stage, don't guess, just follow your Doppler cascade, and all guidelines converge with the same agreement on Doppler-based gestational age thresholds for delivery. And precision is the future. We are waiting for more research on this topic, and maybe I might be talking about angiogenic markers in the future. Thank you so much for this opportunity.
So thank you, Dr. Navya. That was very elaborate, and you managed to squeeze it in the 10 minutes. So is there any question from the audience? So I have one question. What would you say about the role of MCA Dopplers to deliver before 37 weeks in SGA babies?
That is a very clear-cut guideline that before 37 weeks, MCA should not be our guideline to determine when to deliver and deliver the baby. Yeah. It is done only after 37 weeks, that also after a careful examination of umbilical Doppler, which deteriorates before MCA.
Yes, I just wanted to reiterate that. Thank you.
Thank you so much.
Thank you so much, Navya ma'am, for the brilliant presentation. Thank you so much, Aditi ma'am. May I request Vinata ma'am to please give away the mementos to the speakers and the chairperson. Ma'am. I invite Dr. Sindhura Bandi ma'am to please begin. So the next talk is a very up and coming, very relevant topic, the topic of social oocyte freezing. So madam will be elucidating us on the science, the timing and the counseling. And I invite the chairpersons, Dr. Hima Deepti madam, Dr. Chandini Chinta and Dr. Monica Jampala. Please join us on the stage, madams. So Sindhura ma'am is a very passionate reproductive specialist who has done advanced training from Germany as well. And among the chairpersons, Dr. Hima Deepti madam is a director of Nova IVF at Banjara Hills. Dr. Chani, Dr. Monica are our very own in-house IVF specialists, and we congratulate them for the opening of the KIMS IVF Center.
Good morning. So we chose this topic, to bring about more awareness so that, we can avoid a lot of aneuploids and, whatever complications that can arise because of late pregnancies and planning. Can we freeze the biological clock? A lot of times in our OPDs, we do get, young girls or young couples coming to us saying, "Doctor, I'm just 34. I don't have a partner yet. I want children someday. Should I freeze my eggs?" But it's more than I want children someday. They come to us saying that, I'm not sure if I want to have kids yet, but I still want to keep my options open. Am I already too late? So for all the women who are going through this phase of life, or who knows somebody who's going through this part of life, this information is for them. Social oocyte freezing. You preserve the oocytes at their current biological age. So they are like an ice age. You freeze them today, even after 10 years, they're going to be the same, how they are today, the same biological age they have today. What's the science and what's the timing you'll have to do, and how do we do the counseling, and how do we plan the social oocyte freezings? Why should we even talk about this social oocyte freezing? I mean, I see the hall is full of women. Women are changing their timelines. Ovarian biology has not. I think, during our PGs and, our working times, we were already, I think most of us have got breaks. We have to plan the career, we have to plan the babies, we have to take care of the house. There are a lot of breaks for a female. Education, career, partnership, financial stability. And then the end, now the priority is the motherhood. Before it was like the motherhood, then everything else comes later. But now the priorities are changing, and I think it's absolutely right to have your priorities right, and you should know your options before you actually make a choice. So if you see, the life clock is career, partner, motherhood, stability, and the motherhood. But your biological clock, it doesn't stop for anybody. You can pause the career, you can pause the partner, you can, maybe get a stability a little later in life, but biology is something you cannot pause naturally. That is where our social oocyte freezing comes in, where we can pause biology to some extent. If you see this graph, the signs of ovarian aging, what actually happens? In your 20s, it's like the peak fertility, and then you come to 30s, half our life is gone in studying and, figuring it out what we want. And then your fertility starts accelerating, very, very decline. And then at 40, if you see the graph, it's almost like, too low to the x-axis. And your aneuploidy risk also increases with increase in your age. What do we actually do? What are we actually preserving? I know I spoke about, you can freeze your fertility, but is it really fertility, or are you, is it really the time? It's actually the oocytes at their current biological age is what we are freezing. How do we exactly do that? So there is a vitrification straw, wherein there is a minimal volume of media that holds up the oocyte. And then on the slide, if you see, there's a carrier for ultra-rapid cooling with minimum volume. And you actually freeze mature oocyte. Not all the eggs what you get, but it is a mature oocyte. And this is how you put them in the liquid nitrogen, and this is how a vitrification process is done. What exactly do we do? How is the egg freezing journey? What's the time frame you're looking at? You come for a consultation, we assess, we evaluate your ovarian reserve and a couple of tests. Then we start your stimulation with your starting day of your periods. Throughout the stimulation, we monitor. Roughly, the stimulation time is, most of the women are ready by 9th day. Sometimes plus or minus 1-2 days or 3 days. And then once all the eggs are ready, we plan a trigger. And then we do the ovarian pickup exactly at 35 hours or 35 and a half hours, 34 hours. And then you look at the number of M2 oocytes, that is the mature eggs is what, because these are the ones that actually accept the sperms and have the potential to fertilize. And then you go ahead with the vitrification process. What's the time frame? How is the time, categorized? Age is the biggest limitation when it comes to fertility. Less than 30, you have excellent biology, lower need of stored oocytes. 30 to 34, there's balance of biology, and utility-wise also, to some extent, yes, they're good. 35 to 37, now here, the counseling becomes very time-sensitive because your fertility is declining at a faster rate, your aneuploid risk is also going up at a very high rate. After 38, there is lower oocyte efficiency. Individualized discussion is very, very crucial here. Now, if you ask me what is the right age for oocyte freezing, there is no right age for oocyte freezing. You always individualize what is the scenario there, and then we go ahead. A good AMH at 39 does not make the oocytes 29 years old. Just because, we maintain our lifestyles, we look beautiful, we look young with all the dermatological treatments and regenerative medicine, doesn't mean that, our biological age is also going back. Our eggs are going to still age, even if you look 29 and 26. So AMH, what does it exactly say? It tells us about the quantity, it tells us about the ovarian response, expected oocyte yield for that cycle. Now all of this is only for that month. You don't create anything new when you're doing a fertility treatments. It is only we're using the biology for that month per se. Probability of needing multiple cycles. Now AMH just predicts the quantity. Age strongly influences oocyte competence, aneuploid risk, and future reproductive potential. Even a decreased AMH can have a better quality if saved with age. And I think we should all utilize this to our advantage here. I mean, not us, the young girls who are there. The procedure takes days, but the decision may affect decades. As an IVF specialist, what should we discuss before freezing? You discuss about the biology, age, AMH, AFCs is what we see. And then what is the expected yield if you go for a fertility cycle that month? What's the success rate you have? Because it's only a half of it. The ultimate result is the embryos. How many eggs are going to actually become babies in future is what you should have a realistic chat with your doctor. And then what is the procedure? What is the risk associated with the procedure? What's the treatment? How do you do the storage? And what do you do for the future use? And reality. Just because you freeze your eggs doesn't mean that you are guaranteed a baby. You are given a choice. You have an option. Your options are open. How many eggs do I need? Is there a magic number? If you see, out of 20 oocytes, not all of them survive. At every phase of life, just like how we are challenged in our lifetimes, the babies also, the oocytes are also challenged at every part of their life. You start with 20, but after survival, only few of them actually survive. In the end, if you do, the number of blasts are very less. They're only like 3 blasts, and then 1 single baby. So what do? We do an individualized planning when someone walks into our clinics. So let's bust some of the myths. Egg freezing is a fertility insurance.
I don't think so.
AMH tells me if I should freeze.
No.
Not alone, actually, yeah. I have good AMH, so I can wait.
Definitely not.
I think we'll put a few questions for the audience as well, I guess. Now.
I'm so sorry, I'm taking all the questions.
No. One cycle is enough. Nice, we've educated you well done. Maybe, maybe not. Frozen eggs guarantee a future baby. Anybody in the audience? Definitely not. Younger is always better? Not necessarily. Lifetimes are changing. Actually, in the OPD, when we ask about smoking history, drinking alcohol history, the lifestyle, when we ask, do you smoke? They're like, no, doctor, I don't smoke. I don't even go there. Then I do ask, do you do hookah? Oh, that we do, doctor. That we can't stay without vaping and hookah. Vaping and hookah is equally bad as smoking. So with the lifestyle does really matter when you're going for an egg freezing, because, with a bad lifestyle, you have a very good yield, very good M2 rate. Tomorrow, when you actually want to use them to make babies, you may not end up with any babies. The risk is there, so lifestyle does matter. Is procedure the hardest part? I think, emotional burden. Physically, it's not much. We do, my colleague is going to talk to you about the other options of freezing. But emotionally, yes. And actually, we are very good counselors, so I think it will make it easy on, the girls. So back to a patient, 35-year-old, no current partner, desires 1 to 2 children, expects to delay pregnancy, AMH 2.1, AFCs of 14. What we must counsel her? Yes, you must freeze, or would you say, no, you're still young, you can wait on it? You can't answer, you're a fertility consultant. I want other perspectives. So we assess, we explain, we estimate, and we counsel, and then decide what's the right option. So take home message, age at freezing matters the most. AMH estimates the quantity and not quality. More eggs improve probability, but there is no universally magic number. The more, the merrier. Egg freezing preserves an option, not a baby. The best outcome of counseling is an informed decision. So freeze your eggs now and have a baby whenever you want. I think that mindset should change. Freeze your eggs so that you have an option. Yeah, thank you. Thank you so much.
Thank you so much, Dr. Sindhura. Can I invite Dr. Navya ma'am to please come up and give the memento to Dr. Sindhura, please?
Can I ask Dr. Sindhura one small
question?
Yes,
please.
So, Dr. Sindhura, I'm very impressed with the way you presented. Started off saying that you cannot pause biology. I think that should be the take-home message. You cannot pause biology. And the way you burst the myths, beautiful, wonderful. But then how are you going to convince your patient when you say, this is not an insurance, you're not guaranteeing a child. You have to freeze early, whether you freeze, you said the age matters, so if they come at 39, the number of eggs, we don't know how much they have. So without calling it an insurance, without guaranteeing a baby, without promising anything positive, how are we actually going to convince the patient?
So the fact that they entered my clinic itself is that they're convinced that they want to go ahead with the egg freezing.
No, probably this patient has not entered your clinic for egg freezing.
Okay.
They've just come to you. So how are you going to convince them?
So again, madam, like I said, you assess the entire situation. You tell them the pros and cons. Now, you cannot force anybody to do anything. We always give them choices. You tell them the good choices and the bad choices, and then you give them the realistic probability of you having a child, even if it is 1 or 2, rather than not having at all. So keep your options open. Science is there. Tomorrow, what is there today might change tomorrow. You might get a much better and, advanced techniques. So what is there today, utilize it to your advantage.
I think I love your answer where you said you have to counsel the patient in the right way. They have to understand their pros and cons. But somewhere we also have to tell them that this might help them, because or else your patient is not going to take the treatment. Thank you. You've beautifully taken us to the concept.
Thank you, ma'am. Thank you.
One important point I want to ask you. When you talk about age is the limit, and as you given a case scenario, 34 years old patient comes to your clinic for the egg freezing. So we also in the position to counsel them until what age they can plan pregnancies. So how long we have to preserve, because what is the law says, how early they have to plan deliveries. So that also should be a point.
Yes.
Take home message to everybody. So
yes,
female means what is the age and male means what is the age. That also matters.
Yeah. So you can start your fertility journey as soon as a female is 21 and the male is 23, and it can go up, for men it can go up to 55, and women it can go up to 50. Eggs might seem, young when you freeze them, but when you fall pregnant is also important. Now there, your falling pregnant doesn't become important there. Continuation of pregnancy becomes important there. Yeah, so a lot of work for the obstetricians to work, and fetal medicine experts there.
So we have to tell them until what age they can freeze the eggs or the sperms, and until what age they can plan delivery, pregnancy as well.
Yes. Once frozen, you have permission to freeze them up to the 10 years. If you want to go beyond 10 years, we need to get legal permissions again to extend them. So anybody going through cancer treatments or anything any gonadotoxic, then yes, you do have an option of extending even beyond 10 years. Just because I said endotoxic, you came up.
No. So you said cancer, so I came up. See, it's a practical scenario. 34-year-old lady due for starting chemotherapy. She's a triple negative breast cancer, and she's nulliparous. She's very keen on conserving later. What is the quickest way that we can ensure? Do you suggest ovum preservation or make it an embryo? We're not sure if the same partner is going to be there or not. But what is the best way to counsel these patients?
So here, because her life is more important, we don't really wait for her period. We just start wherever she is, whenever she is, at any phase of the cycle, we just start. Because here something is better than nothing. And if she has a partner, we do go ahead with the embryo freezing. If she doesn't have a partner, we go ahead with the oocyte freezing.
So what's the minimum time that it takes to acquire these?
So minimum is 9 to 10 days, but if you're doing a random start, it can go even as slow as 8 days or 14 days, depending on the yield, what we get for that cycle. Yeah.
Thank you.
But I think roughly we could say 10 days. Yeah.
Thank you.
Thank you so much.
Thank you so much, Indura ma'am. Can I request Navya ma'am to present the memento, please? Invite Dr. Pooja Reddy ma'am for her session on a very much needed topic, needle-free IVF. As we all know, the journey of IVF can be fraught with so many painful procedures, needles and pricks, and that might itself be a kind of a trauma for many mothers to be. So madam is here to talk about the needle-free IVF, what is the hype, the hope and the reality. All yours, madam.
Good morning, everyone. So, can we reduce the burden of IVF without compromising the goal is the main question a lot of us have. How many injections do you think people take in an IVF cycle? Anybody can answer. I'm talking only about the IVF cycle, not the embryo transfer cycle. How many injections do you think people take in those 10 days or 12 days? Anybody? If we are doing a conventional IVF with the regular drugs, probably people will have 3 or 4 injections per day. If the growth hormone is included, so that's going to be like 40 plus injections in those 10 days. There has been this constant search, and there have been so many improvements wherein people have been trying to reduce the number of injections people are taking in an IVF cycle. So we could successfully narrow down the number of injections to just 1 injection per day when we shifted from the antagonist protocol to PPOS protocol. Now we have come up with the needle-free IVF where we have reduced that 1 injection also. So you can have an IVF cycle completely without a single needle prick. So the question is IVF possible without painful injections? And the answer is yes. And of late, we have some protocols wherein we can do a successful embryo transfer cycle also, even without a single needle prick. So will the protocol change? No. Are we using the same hormones? Yes. And we have an absolutely painless drug delivery system. Needle-free IVF is probably less than a year old in Telugu states, and KIMS is the first hospital to have introduced needle-free IVF. So why is everyone talking about needle-free IVF on social media? Because the main reason why people fear going for an IVF cycle is not the cost, it's about the needles. Most of us are anxious when we know that you'll have to take 3 pricks per day, 4 pricks per day, that too consecutively for a period of 10 days, 12 days. So we have optimized the stimulation protocols, we have changed the laboratory techniques a bit, and we have changed the embryo selection techniques also over the period of time. The latest advancement in the journey of IVF is the needle-free IVF. What do you think is the real burden in an IVF cycle? Anybody? Correct, madam. Next. Apart from cost, what else do you think is the burden in an IVF cycle? Yes. That is the second one, psychological burden. And the third thing is the needles. This article was published in CNN in 2018, where one particular lady has taken 1600 injections and she has had 3 miscarriages and 2 IVFs to have this baby. These are all the syringes that this lady has used to have this baby. Just looking at that image, it feels painful. Imagine what she would have gone through. We will be able to do this now without any of these pricks. So you have different drug delivery systems. Every hospital is using a different drug delivery system, and different pharma companies are promoting different varieties of drug delivery systems. Most of them work in a similar fashion. You have a high pressure drug delivery system without a needle. You have a very tiny orifice. The size of the orifice is somewhere between 0.1 to 0.3 millimeters in diameter. Once you load the drug and you press the piston, drug is delivered at in a high pressure delivery system, where the pressure will range between 15 to 35 megapascals, and the drug gets delivered into the subcutaneous tissue directly. The speed at which the drug travels is almost up till 100 meters per second. So these are the components of the drug delivery system. You have a cartridge to load the drug, and you have an adapter. The adapter is different for a PFS injection, it's different for a regular injection, it's different for a multi-dose vial. So you just load the drug, you put the drug delivery system on the patient's abdomen and you press the button. No prick, drug is inside, patient will not even know that the drug is gone inside. So you put the machine at a 90-degree angle and just press the button. The only disadvantage with this is you cannot use it for home IVF. Patient will have to come to you every day to take the injection. So what is the dose you can give? The maximum dose you can give in one go is not more than 0.5 ml. Probably 1-2 years down the lane, you'll get larger cartridges that will be able to accommodate 1 ml, 2 ml of drug too. So this device will generate a controlled high velocity jet that penetrates the skin through a micro orifice, and it delivers medication into the subcutaneous tissue, and it's not just passive transdermal absorption. When we say drug-free, needle-free IVF, a lot of patients ask, do you have gels that we are going to apply on the skin and from where the drug is going to enter the body? No. So it's the same destination, but different route of drug delivery. This is a comparison which shows when you are giving the drug with the needle and without the needle. So what changed? Nothing changed. It's just the drug delivery experience, and the fear has come down. Pain and discomfort has come down. So who are potential candidates for needle-free IVF? Everybody is a potential candidate for needle-free IVF. Nobody wants to go through those pricks when you have something like this. And the cost is also not very high. Probably we charge somewhere around 15,000 extra for a needle-free IVF cycle. So when somebody is spending 2 lakhs or 3 lakhs on an IVF cycle, 15,000 doesn't make much of difference. So if you are not using the right protocol, you cannot do a completely needle-free IVF. You should have good protocols for the embryo transfer cycle also to make this completely needle-free. And reality, only selected steps can currently be made needle-free. Only disadvantages, you cannot use the oil preparation progesterone injection in the needle-free IVF device. So if you want to do it completely needle-free, probably you should choose other embryo transfer protocols. Evidence is limited. We hardly have 2 or 3 studies, but we have been doing this and we have been getting better embryos compared to regular IVF cycles. Some patients have had their first IVF with us 2 or 3 years back when the needle-free device was not available. And now when we did an IVF cycle with the needle-free device, what we have noticed is we have gotten better embryos, better numbers and better quality also. Probably it's because of the reduced stress and anxiety. So final take home is needle-free IVF is an attractive concept. Needle-free drug delivery system is feasible. Early clinical evidence is promising but small. We are only a year old in Telugu states. We have started doing a study. It will take some time for us to publish. And complete needle-free IVF is not yet established in most of the centers. Probably we should explore more of transfer protocols wherein we are cutting down the number of injections the transfer requires. And the future should be judged by live birth and patient experience, not just by technology alone. Thank you.
Dr. Pooja, I think the way you've taken us through needle-free IVF, awesome, because I've seen that pain that the patients go through for the last 15 to 18 years. Now, if the patient is able to go through without pain, I think that's an added boon to the patient. And 15,000, like you have said, is definitely something a patient can afford when they're spending 2 lakhs or 3 lakhs. So you should give this option. The only worrisome part which you have highlighted is we don't have proper studies saying whether using this drug delivery system actually gives the same concentration of drugs. Is the M2 ratio being maintained? The quality of the M2s? What is the FERT rate? Is it affecting the take-home baby rate? We are too early to speak about that. But I'm happy to hear that you're saying that comparatively in few patients that you've seen that it's given a better result. So that's quite promising.
Our pull-up cycle rate also has increased after we started the needle-free drug delivery system because it's easier on the patient. Patient wants to go for more cycles and freeze more embryos.
That's nice. But yes, we still have to wait for larger RCTs to come before we pass that as a message to a common crowd.
Yeah.
Thank you.
I have one question, Dr. Pooja. In your experience, is there a difference in efficacy in the different medical conditions, like suppose endometriosis or PMOS or low ovarian reserve? Do you see any difference?
Nothing. We have not noticed any change. Whatever serum levels we were able to get in the same patients in a conventional IVF, we could replicate better serum levels, in fact, when we did the needle-free IVF for the same patients.
Okay, so it does not...
No.
Okay, that's good to know.
Probably
Thank you.
lesser anxiety is the answer.
Okay.
For better response.
Thank you.
Wonderful presentation, ma'am. Many congratulations. I have one question. Does BMI has to do anything with needle-free IVF?
No.
Because the subcutaneous fat in morbid obese patients, does that have anything to do with the absorption rate of the drug?
We had this doubt initially, but as we started doing more and more of obese patients, we have not noticed any change. Whatever
so
is
the
your
serum levels, everything?
Yes. Whatever is your calculation in conventional IVF, it holds good for needle-free IVF also. And what we have noticed is, it is easier to do in obese patients. Somebody who's very lean, it is difficult to, deliver drug via that NFIS. More abdominal fat, it is easier, and the ones with more abdominal fat have lesser, pain or discomfort, even post injection. We had a patient.
using
No,
the system?
no, ma'am. In case you have mild discomfort after taking the antag or the HMG, FSH, they're absolutely comfortable.
My patients did complain of pain and discomfort, and that is
After
the reason
recombinant drugs,
they have complaint of discomfort. And in fact, that was a point of counseling where we had to tell the patients, because when we say needle-free, they want it completely free.
one thing what we have noticed is if you give them ice pack for like 5 to 10 minutes before giving the NFIS, it's absolutely pain-free. I keep taking B complex injections in needle-free system every week. 1 week I take, 1 week I make Dr. Sindhura take just to make sure device is working well. So it's absolutely
Definitely, it's an added boon to the patient.
painless.
I would not say that, but that is one thing even I have faced.
Antag does cause some amount of skin irritation, so we moved from Antag to PPOS completely. So that is eliminated. FSH, they are very comfortable. Even the FSH-LH combination, they are very comfortable. It's only with the HMG, some people say there is mild discomfort. Recombinant HCG, they are very comfortable. Even Lupride, they are comfortable. This is from whatever limited experience we have in our center.
Any questions from audience?
Needle free? Probably that will also come now, ma'am, because you have a device. There will be improvisations in the device.
So another thing is the stimulation part will be needle free, but like you had mentioned, with transfers we need to come up with technology which could also maybe
If
make
you
it
have sufficient number of embryos, probably you can do an injection-free transfer also.
Natural cycles.
Vaginal, oral, natural cycle, anything. Anything. If you have good number of embryos. If you have one embryo, probably nobody will want to risk it with vaginal gels, and people will prefer going for injections more. Yeah, that's what we do, madam. But probably we have not done that for anybody with single embryo. We didn't have the guts to do it. More than one embryo, we counsel them for needle-free transfer also.
Also, natural cycle FETs are, I think,
Yes,
now
yes.
the talk of the town. Many people are moving towards natural cycle FET, in which invariably the serum progesterons are good on
So
the
you
day
don't
of.
have to pump too much
Yes,
from outside.
so I think that is one way. That was a very nice presentation. Thank you, Dr.
Thank
Pooja.
you, thank you.
Thank you so much, madams, for a wholesome discussion. I request Dr. Vasundhara, madam, to please come up on dais and felicitate the speakers and the chairpersons. I would like to invite Dr. Vinita Puli, madam, as the moderator for our panel. We are now moving to a multidisciplinary panel where we would like to be discussing all the multi-specialists and the various conditions that a pregnant mother can go through. So I hand over the mic to Vinita madam. Madam is a very senior and experienced obstetrician and gynecologist practicing in Hyderabad. She brings a great value with this panel discussion. She'll be moderating. And the chairpersons, Dr. Kishore Reddy sir, he's our endocrinologist. Krishna Reddy sir, he's an endocrinologist. Dr. Shavan sir will be our intensivist on the panel. Dr. Sham Sundar Reddy sir, very senior respected cardiologist. Thank you, sir. And I request Dr. Amit sir, our consultant neonatologist, to be lending in the perspective from the NICU as well when the decision is for the best outcome for the mother and the baby.
Thank you. Welcome you all. After that session on IVF, now egg freezing everything, we are seeing more pregnancies which are like, delayed. So after 35, after 36, we see more of them. So we better be prepared for more medical complications in pregnancies. So is this discussion today. So maternal morbidity and everything we have to reduce. So let us try and take through a couple of scenarios where we can see the inputs of the multi-specialty team that can improve the outcomes. So I welcome all the panelists. Thank you for being here. So let's start the first scenario. So this is a real scenario which we have delivered this patient 3 weeks ago. So 37-year-old primi gravida with a BMI of 44, and she has uncontrolled diabetes. She was not planning a pregnancy, but she came pregnant with a HbA1c now of 12.7 because she was not controlled. Now, immediately, the moment we see that HbA1c of 12.7, we get very alarmed. So the first phone goes to the endocrinologist. Dr. Krishna Reddy, can we now update us? What immediate management will you do to get that sugars under control?
Yeah, so very good morning, everyone. Hope that is a bouncer question.
So the 37-year-old lady with a BMI 44 booked with HbA1c of 12.7.
Yes.
She is now 7 weeks.
She is having multiple issues, like it's an elderly primi. She's having obesity, morbid obesity, probably type 2 diabetes, type 1 diabetes.
Type 2 diabetes.
She's type 2 diabetes with very, very uncontrolled hyperglycemia. So as per the guidelines, there is no indication for the termination. Okay. So because
that is the first question I wanted to see. Should all gynecologists counsel for termination the moment we see HbA1c of 12.7?
Right. Because elderly primi, we cannot risk for the, she may conceive, may not conceive. Diabetes itself is a major risk factor for infertility, but hopefully I don't know how she conceives.
So once the pregnancy is there, we better not terminate.
Yeah. Yes. Okay. So we can proceed. Our main goal is to normalize the sugars as early as possible, because hopefully she is in the organogenesis period, initial 3 to 8 weeks.
She's 7 weeks now, yes.
7 weeks, yeah. So this is a period where actually the organogenesis will be formed. Hyperglycemia is one of the biggest risk factors for the fetal anomalies, especially during the first trimester. Compared with the type 2 diabetes, type 1 diabetes, the gestational diabetes little bit better actually. It causes fetal macrosomia and this cardiomyopathies, but other than that, the serious congenital anomalies are lesser. So this is very challenging case. So we won't wait for any lifestyle measures to happen. We won't wait for the metformin to act. We'll directly go with the insulins. Okay. So in insulins also, unfortunately, if you're the physicians, they'll go with the mixed or this pre-mixed type of insulins. So that is not going to work better for the pregnant woman. So it's always the basal bolus insulin is the choice. So 3 times boluses, like short-acting insulins, 1 basal insulin, which is a long-acting insulin. So we need to properly control the sugars as early as possible and avoiding the hypoglycemia. And the targets is being, we all know that fasting sugars we need to bring below 92, 1 hour below 140, and second hour below 120. So that should be the goal.
Yes. Now, after your assessment, if she has a retinopathy of mild one,
Right.
and you are controlling rapidly, the sugar control, we told them, control the sugars rapidly, so organogenesis is a safer time. But rapid control of sugars, do you feel retinopathy will get aggravated?
Definitely, the risk of retinopathy will be increased if you rapidly control, if you bring to the normal levels.
Yes.
So you should actively board the ophthalmologist into the team. And also we need to screen for the proteinuria. So that is also underlying other complication of type 2 diabetes long standing. So we need to take the help of the specialist and we need to manage accordingly.
Definitely. I think this is what we have to keep in mind. So you should not just ask for a rapid control. You should have a balance of that rapid control to end organ damage. And that is why we are sending to the endocrinologist. Okay. So now she has managed the first trimester very well. NT scan was normal. She now came for TIFA scan. At TIFA scan, we all know that, diabetes in organogenesis period, increased risk of anomalies. Now we have noted her to have renal pelviectasis, but it was 5 mm and 5.6 mm in both the kidneys. Okay. Now we have neonatologist. Dr. Amit, can you update? I have sent for counseling from a pediatrician, neonatologist.
Yes, so good morning to all. So for any deliveries for a mother, always they want to have a good health for the mother and the baby. So seeing together in the mother with the background history of advanced maternal age, high BMI, uncontrolled diabetes, with the HB1AC is more than 10, almost 12. With the renal pelviectasis, although it is 5 to 5.5, so if you go to the SFU grading, it might be stage 1 to 2. So what we have to counsel beforehand to the parents. So since it is this of background, if you see this risk in the babies having obesity with the high insulin level or high HB1AC level, they have more chance of macrosomia, and then they have related to the birth complication as well the dystocia, fetal asphyxia, even the stillbirth and fetal mortality increased by 5 times. If you see the correlation of HB1AC and the congenital anomalies, when the HB1AC is more than 7, then the correlation of anomalies is 9 times. And when it goes to more than 10, it's 20 times. Even all the anomalies, either congenital cardiac problem, renal problem, and the effect of insulin leads to RDS and TDNB. So we have to counsel the parents that baby need an ICU admission for the respiratory problem, need of support of oxygen, might require surfactant. Now coming to the pelviectasis. So for this we have to do the USG KUB after 48 hours when they have production of urine to see that any obstruction is there or not, and then we can proceed further. For the long term, since the mother is having obesity and diabetes, this baby has more chance of having metabolic problem and obesity. So that has to be taken care on the long-term follow-up.
Thank you. Actually, she was only 20 weeks, so her main concern was the pelviectasis. So they have gone round, neonatologist, pediatric nephrologist, got the counseling. They were thinking of termination, but after all this counseling, because it was mild to moderate, they have decided to continue the pregnancy rightly. So then at 34 weeks, she has continued. Now she's better monitoring and control is good. But clinically, I felt it was large for gestational age. I sent for growth scan. Growth showed appropriately grown baby, but polyhydramnios, not too much, but AFI was in that upper normal range of 20. She slowly started to feel short of breath. So now she is complaining of shortness of breath, which is a very common finding for those who have polyhydramnios, for those who are obese, for those who are 34 weeks. Should we ignore this or should we ask a cardiologist right away?
Yeah, so we are dealing with a high-risk pregnancy. So she has a lot of things which are going against us. Ideally, probably considering the current scenario, I would always ask you people to get a basic ECG done when you are in the early part. So
baseline ECG done at booking was normal.
Yeah, normal. Yes. So now it comes, so there is always a confusion at 34 weeks, whether are we dealing with an peripartum cardiomyopathy, one thing. Even though it's a slightly early presentation, but still that is the one which is more alarming, comparing with the physiological changes of pregnancy. But again, third trimester is a phase which is not so likely to cause that. So our differentiation would be again peripartum cardiomyopathy. Second thing, pulmonary embolism still needs to be ruled out in this set of things. Third thing could be preeclampsia, heart failure. That could be one thing. Fourth could be diastolic heart failure because of the obesity, new onset diabetes, and the pregnancy-induced changes. And last, finally, because of the polyhydramnios, mild obesity, is that causing the symptoms, pressure symptoms. So we need to assess. So again, I would ask for a basic ECG, do an N2D echo. If needed, if any suspicion, go for NT-proBNP levels to assess for the fourth thing, diabetic and its anomalies, ketoacidosis and all those things needs to be addressed, because acidosis can also present that way. So these 4 or 5 things we need to look at it and probably sort one by one, and probably this she might land up with further problems which we have to wait and see.
She did have an ECG and 2D echo. Oxygen saturations were fine. They were normal. Our blood sugars were well controlled. So we felt okay. It's a physiological at this stage with the polyhydramnios. And she was also not getting worse. She was closely monitored almost every week at this time. But now she is at 36 weeks. Reasonably well controlled sugars so far with insulins. She is developing 1 or 2 episodes of hypoglycemia. We usually worry more about hypoglycemia than hyperglycemia at full term because of risk of stillbirth. So what will you do for her hypoglycemic episodes?
Yeah. So hypoglycemia, she is probably having a good control, and hypoglycemia is dangerous for both the baby as well as for the fetuses. And the cutoffs doesn't much difference from the adult cutoffs. It's below 70 we need to treat. And in pregnancy, especially in the midnight up to 63 also we'll allow sometimes if you want a tight control. Baby is completely dependent on the glucose. It cannot metabolize other metabolites. So mother can be having the ketosis and other things, but the baby cannot survive the hypoglycemias. So any glycemic levels below 70, so we need to have a good amount of simple sugars. That is in the form of Glucon-D or table sugars, 15 grams. If the patient is conscious, we need to give orally. Or if the patient is unconscious, we need to give IV dextrose. So go with the simple sugars, not the chocolate, biscuits. So they contain other fats and other things. They cannot raise the glucose levels immediately. So glucose is low, just simply replace with the glucose. Ideal is the Glucon-D or dextrose tablets are available. So that can be given 15 grams. After 15 minutes, again you recheck for the sugars. Still below 70, again you repeat the same thing.
By then.
And once the sugars are reached beyond 70, you need to add a small snack so that further hypoglycemia will be prevented. So that is the thing. 15 is the rule. So 15 grams of carbs, simple carbs, and 15 minutes you wait and then recheck.
Perfect. I think she had that and she definitely improved very well. I think she was having a long gap between her snacks. So after dietitian guidance, I think later she was okay. But that was only only 1 week. I think she had a risk assessment done by anesthetist. Though we don't have anesthetist in panel, we still got anesthetist to assess her BMI, airfare, cardiopulmonary status, all these things, and BMI is 44 definitely. So she did have anesthesia, but she came at 36 plus 5 weeks with preterm labor. Head was mobile, polyhydramnios was there, and so she underwent a cesarean section. Not like a crash category 1 emergency, but like a category 2 to 3. And as we understand that because of risk of anesthesia, we needed to give that time, NPO status, everything. And after 2-3 hours, we have taken her for a cesarean. And fortunately, she did not progress so rapidly, and baby was fine with the CTGs. And as obstetrician, we will be thinking more so of infection control, antibiotic use, everything because of BMI. We did use Alexis retractor. That is something that we use for a big BMI patients for retracting, so we can use less of occupational hazard, pulling tissues and everything. And neonatologist was there. And baby was 36 plus 5 weeks. No steroid cover because of her major diabetes. So what do you expect from neonatology, Dr. Amit?
So for the same, since it was not steroid covered and is already having high HB1AC, so there is a high chance of having RDS, TTNB, even though PPHN also, and they may require the oxygen support, surfactant need because he was born preterm, and the NICU stay. But the prognosis is good enough in these if it is controlled even in the last stage. So it is have a good NICU output.
Actually, baby came out fine. Baby cried at birth. Baby was behaving like a full term. So we fortunately did not have much problems for immediate postpartum. So, and 2 days the baby had glucose monitoring. They were perfectly fine. We almost discharged home on 3rd day. And with no antibiotics, she was absolutely okay. Now on day 5, she came to ER. She developed extreme tiredness, shortness of breath, and dry cough. She did complain of mild chest tightness and nocturia. Her examination, pulse revealed 110, BP 120/80, oxygen sats 94%. There was pedal edema noted. So, if there was no shortness of breath or chest tightness, are we worried about extreme tiredness with that pulse and BP? Obstetricians in the group, I don't think so. Because everyone will think, okay, she's tired because she's sleepless, 5 days postnatal. She is having pulse 110, which is almost always normal for us pregnancies, 100 to 110, not very high. Oxygen sats okay. Pedal edema, very, very common finding postnatal. Physiologically, postnatal pedal edema is very common. So what made us a little alarmed was, yes, her risk is there. She did receive TED stockings and she did receive low molecular weight heparin for thromboprophylaxis. She did still complain of shortness of breath, dry cough and chest tightness. So we got cardiologist in, we did the ECG. So, but we don't know how to interpret that ECG.
So, yeah.
Right.
So, when we look at the ECG, again, this is a very, very non-specific to say. So, we can't say, we can't rule in anything nor rule out anything. So, here we say a little bit of sinus tachycardia, LVH. Yeah, the V1, V2 a little bit alarming. You say biphasic T waves, you're worried about the Allens. You might look at any myocarditis or probably all those things.
Yes.
But first again, primarily again, fatigue, breathlessness, anemia. I would primarily rule out anemia. Hemoglobin.
She did not lose much blood.
Much blood,
Her
yeah,
blood
so
was, hemoglobin was 11.7 or something.
Okay. So the first thing I would rule out is anemia.
Yes.
Then again, the next things, again the differential diagnosis comes.
Yes.
Yeah, again, see, so you have a polyhydramnios heavy baby coming out, compression of the IVC might have gone, fluid might have come. But again, day 5 is again a delayed. I would have expected on day 1, day 2. So probably fluid overload secondary, these things. That would be the most benign thing which I would like. Then, but day 5, these symptoms, the first what should I rule out is a postpartum cardiomyopathy. That is the one thing which should I rule out, because this is the one thing which is probably missed and they present in a very dire situations. So urgent 2D echocardiogram to rule out. So ideally if the ejection fraction is normal, we're not worried, but anything, any ejection fraction of less than 45%, or I would say anything less than 50%, we need to look out for postpartum cardiomyopathy. The rest of things, pulmonary embolism, less likely, no S1Q3, T3, and not much of tachycardia. So, and patient, so might be less, but again, the echo would still rule out, echo would still rule out most of the things.
Yeah. Right. So I think you have covered it all. So this is mostly going with for a cardiomyopathy, very typical presentation of a cardiomyopathy, but luckily because she was covered with low molecular heparin, we were not thinking in terms more of a pulmonary edema and things, and embolism. So for her follow-up, now she's day 2, her postnatal, her fasting blood sugar was 77 and her post-lunch was 110. she was using metformin pre-pregnancy. For all those who diabetics, we go back to the pre-pregnancy dose.
Right.
So we kept just on that. Will you have any difference and what is the plan for her at 6 weeks?
Yeah, yeah. So once the fetus comes out, we'll be relaxed a little bit. And most of this insulin resistant mediated, we require almost 100, 200 times the higher doses of insulin, especially during the mid-trimester, later trimesters. So once the baby delivers, especially the placental hormones is gone, slowly the insulin resistance will come back to the lower levels. But the initial HbA1c itself is very high. So
she
I
will
don't
not
think,
stop metformin.
I don't think the metformin alone
Will not
will
enough. Okay.
So I think we should continue insulin, but at a lower doses.
Okay.
Slowly tracking down and coming down on the doses.
I think she got a good scare initially in her pregnancy. So she kept her weight gain to minimal. So lifestyle factors were on par with her diabetic management throughout pregnancy. And she looks fine now.
Okay.
I have to wait for 6 weeks. But thank you very much. This is the case scenario where we really needed not just 4 specialists. She was seeing a dietitian, she was seeing physiotherapist, she was seeing endocrinologist, she had a physician reviews, she had neonatologist reviews, pediatric nephrologist review, she had, except intensivist, I think she had everyone, cardiologist review. And so actually you can count, and obstetrician obviously. So 9 or 10 specialists were there to manage, and her outcome was excellent with that booking. And I'm sure her BMI also will improve with all that counseling she had. Thank you very much. And this is one example. One last scenario where we involve intensivist also. So now this is a 34-year-old primigravida. This was last year, so we had enough time. 36 weeks with a BMI of 34. Presented with high fever, weakness and back pain for 4 days. She managed at home. She's very well educated, so they always read chat GPTs and they manage themselves. So first 4 days she did not present. She came to emergency with symptoms of shortness of breath. On examination, heart rate was 128, BP was low at 90/50, 65, narrow pulse pressure, respiratory rate of 26, oxygen sats are 93%. So she was in ER, straight away we shifted to ICU. Labs were sent from ER, we are still waiting. So the question is now for intensivist. What do you do? How do you manage her resuscitation?
She being the pregnant lady, yes madam. So
she's full pregnant, 36 weeks.
That's what. So as of now, we are not going to evaluate radiologically. So in that scenario, we will be looking for the laboratory parameters. So from the BP, blood pressure is on the lower side, narrow pulse pressures are there. So it usually goes for the hypovolemic thing. So as of now, in the initial phase, we try to correct with the fluid management.
Fluid management.
So checking the IVC as well as the other thing.
So will you immediately place
immediately?
No. How do you do the fluid management? Because she is at risk of pulmonary edema also, if we give a little more.
But as of now, we'll be ruling out what is the cause for the back pain. So is it just a myalgia? Is it anything related to tropical fevers? And when she is complaining of some cough with breathlessness, so is it anything related to any PT? So any bronchitis? So is it anything related to viral pneumonia?
Yeah.
So all these things comes into the play. So based on that, we'll be addressing the things. So if her breathlessness is worsening more, if she's not able to maintain, we'll include the cardiologist into the scenario and we'll take the help of the cardiac component thing. So that's what.
Yeah, her investigations came as she was getting resuscitated. So after starting oxygen, her saturations have improved and fluid management has started in the ICU itself. But hematocrit came 46%. Platelet came 18,000. With this only we were so worried. Dengue NS1 is positive. AST, ALT came very, very high.
On the higher.
So she is now, what is the diagnosis?
So it's a tropical fever, dengue.
NS. So dengue. And now she is in the critical phase. Dengue will first have febrile phase, first 3 days or 4 days, and 4 to 7 days is the major critical phase. So we are now in critical phase. Anyone is thinking of delivery for resuscitation? Not really. First, resuscitate her, but this is a dangerous time to operate or do a normal delivery. Unless it's abruption or scar dehiscence, don't even go till delivery. Okay. So ICU management, she did have fluid management. Transfusions, will you, now her platelets are 18,000, but
So-
she's not in labor.
Yeah, but even then, the target is to keep at 20,000.
Yes.
So in this scenario, we'll go and transfuse one. So seeing,
SDP or RDP, sir?
yeah, mostly we'll go for the SDP, single
SDP.
donor platelet, which has
Yes.
less reactions compared to RDPs.
Yes.
And we will be checking for the APTT.
APTT.
The other parameter which is very predominant for the bleeding is the isolated APTT rise.
APTT.
So that has to be addressed in this scenario.
Thank you. So that is the main thing. You will aim for at least 20,000. If she is setting into labor, then we really
Then
need a
we'll
quick,
target around
yes,
50,000.
higher counts, because we cannot give spinal, we cannot operate. So ideally, because she did not have spontaneous bleed, so we did have time for the platelet transfusion. We got the STPs and we could do the STPs. And luckily she did not set into labor, so we could wait for, but if she requires, she was setting into preterm labor, will you stop her labor by tocolysis?
Will you?
Stop the labor by giving tocolysis.
Yeah.
We can consider that.
Yeah, even
Yes.
there's a high chance, madam.
Yes.
So there's a
Till
high.
she is stabilized, till her bloods are improved, we can consider tocolysis, even she is 36 weeks, to buy the time for stabilization. So obstetric management is try not to do much. Okay, only monitor the baby. So 4 days later, she was out of the critical phase, but she set into spontaneous labor. Platelet counts normally has improved to 60,000, but she did have a platelet transfusion because she was in labor. General anesthesia was given because it was a breech presentation at 36 weeks, not for any other reasons. So, and she did have a cesarean, and luckily no PPH. And neonatology also, she was fine because she was 36 plus 5 by then. So inputs again for 36 weeker, that's.
So what when the parents usually come with the mother having dengue positive, the first question from the parents is, what is the incidence of dengue in the baby? So if you see the literatures, it varies from 7% to 70%, but it depends upon when the mother is got infected. When she got infected in the last trimester, then it may raise to 60% also, but overall it will be 18% to 22%, and it depends upon the maternal viral load, placental integrity, and host immune factor. Now, what to do to confirm that? So we have to do RT-PCR both in the mother and the baby to confirm. And the second thing is that this neonatal dengue having co-infection with the other infection as bacteria and mycoplasma. Next one.
Sure. She did not actually. PCR came negative, so she did not have.
Okay.
So, thank you. I think baby did not have much symptoms, luckily, because she was out of that phase and there was no vertical transmission. So she did have a good recovery, and after 4 days we could discharge her. And this is a clear-cut example of multi-speciality inputs and collaborative care that is given customized to that particular patient will have much better improved obstetric outcomes. So thank you so much for all the panelists today. Thank you.
Thank you. Thank you.
Thank you so much, Vanita ma'am. Thank you so much, panelists. Just hold on to be on stage for a minute while we hand over the mementos, please. May I request Dr. Bhagya Lakshmi madam to please come on stage to honor the speakers and the moderators. Thank you, ma'am. Now invite Dr. B. Nishan Reddy along with the team vascular. Sir is part of a fantastic and very active vascular team. Dr. Venkana and Dr. Meena also are part. So sir will be taking us through the advances in the interventions for postpartum hemorrhage and uterotonics. It's a slight change in the schedule of the presentation. So the floor is all yours, sir. And may I invite Dr. Chandana ma'am to be on stage as a chairperson, ma'am.
Good afternoon, everyone. Myself, Dr. B. Nishan. I'm leading the team vascular in KIMS Kondapur. My topic for today is beyond uterotonics, how uterine artery embolization helps in treatment of PPH. The clinical dilemma when uterotonics fail. The golden hour. Uterine atony accounts for 70 to 80% of primary PPH, but refractory cases drive mortality. The limits of medical therapy, uterotonics rely on responsive myometrium, ischemia, exhaustion, or structural factors render them ineffective. The shift, moving rapidly from medical management to targeted vascular control, avoiding hysterectomy while preserving fertility and organ integrity. Time to intervention, delay in surgical or endovascular decision making is the single largest preventable factor in maternal morbidity. You can see the blood supply of uterus coming from the internal iliac artery, supplying the ovary, fallopian tubes, and uterus from the uterine artery and vaginal arteries. Why are we offering uterine artery embolization to a patient with abnormal uterine bleeding? What symptoms and where is the location? FIGO recommends uterine artery embolization for refractory bleeding uncontrolled by medical and non-surgical treatment modalities with the availability of trained personnel and necessary equipment for using this technology. It recommends internal iliac artery ligation as one of the options to rapidly control postpartum hemorrhage for the management of PPH where medical, non-surgical approaches and compression sutures fail. Recommends abdominal hysterectomy as a part of treatment when all medical, surgical modalities fail. Fertility, does it affect when uterine artery embolization is done for fibroids? Fertility is preserved in most of the studies. What are the embolic agents we use for uterine artery embolization? Few are temporary, which include gel foam, collagen, thrombin. Permanent ones are particulates, PVA particles, embospheres. We use coils, pushable, injectable, detachable, liquid agents, and others based on the need of the patient. This is a case which we have done recently in KIMS Kondapur. And happy to inform that this is the 100th case of uterine artery embolization we have done, where most of them were advised for hysterectomy. We actually cannulate the common femoral artery under ultrasound guidance. We take an angio. We selectively cannulate the branch supplying the bleeding branch to the uterus. You can see in the first. You can see the gush of blood where uterine AVM causing the bleeding. We selectively cannulate with the microcatheter. Later, using glue and lipid oil, we inject through the microcatheter. The lipid oil is a radio-opaque substance, so you can see the injection going into the bleeding branch. Once it's done, we check a check angiogram where you can see the complete AVM is blocked with the glue and the bleeding could be controlled. And most of the times, this AVMs will be bilateral. This is the right side, left side which we have done glue. And this is the right side. Most of the times we take only one side puncture. If cannulating is difficult, we take puncture on the other side also. But this case we have done only on one side. This is the right side. You can see the AVM which is causing the bleed. We injected similarly the glue with lipidol with the radio-opaque substance which you can see. Once it's done, the vessel is blocked. The impact of uterine artery embolization to reduce postpartum hysterectomy. There is a decrease in the incidence of postpartum hysterectomy since the introduction of uterine artery embolization for PPH was observed. Uterine artery embolization resulted in clinical success in 28 of 34 patients. None were re-embolized. High recurrence rate of PPH after previous UAE was observed. There is also improvement in menorrhagia, bulk-related symptoms, and lower urinary tract symptoms. Few patients suffer with post-embolization syndrome, which include pain, where we give superior hypogastric block or epidural. In studies, randomized controlled trials found a pregnancy rate of 50% after uterine artery embolization and 78% after myomectomy. Miscarriage rates were found to be 60% after uterine artery embolization and 20% after myomectomy. Cohort studies included 2 studies where pregnancy rates of respectively 51% and 69% after uterine artery embolization respectively. Miscarriage rates were found to be 56% and 45% after uterine artery embolization. Complications. In my case series, I just found only one complication where patient had a foot drop. Otherwise, the complications may be labial necrosis, full thickness buttock necrosis, and persistent discharge from the degenerated fibroid. There would be temporary anorgasmia, premature permanent amenorrhea, and very rare complications include uterine ischemia and necrosis, where we have to operate and remove the fibroid. Post procedure, we do a flush iodogram to check if there is any thrombus from renals to distal. The take-home message: individualization of cases and choice of therapy is required for the best outcome. Postpartum hemorrhage can be effectively and safely controlled by uterine artery embolization with success rates of 90 to 95%, with fertility maintained, low radiation dose, and fast and readily available. Balloon occlusion or uterine artery embolization can be considered for patients with invasive placenta to reduce blood loss. Subtotal or total hysterectomy may be required in cases of failure of uterine artery embolization. Thank you.
Thank you, sir, for that very informative and illustrative presentation. So, coming to this wonderful technology, I should say, we recently had 2 cases in my hospital where one patient had a primary PPH and we could actually avoid a hysterectomy because of uterine artery embolization. The second case was an instrumental delivery where the patient had secondary PPH. So primarily patient was managed with uterotonics and then she went home. After 2 weeks she came back with a very large arteriovenous malformation and there was a pulsatile flow in the anterior myometrium. So we shifted the patient for uterine artery embolization and it was managed very successfully. So this is a technology I think which we should consider where the uterus can be preserved and it's just not the options that we have to go for hysterectomy. One more thing I would like to ask you is there any chance of having deep vein thrombosis after this procedure, sir?
Basically here we puncture the artery, so probably there should not be any deep vein thrombosis because we do the puncture under ultrasound guidance. In my cases, I have not seen any patient suffering with deep vein. Maybe pregnancy related, they might develop a DVT, but not because of the procedure related.
Okay. So if the patient had any risk factor, like let's say she's obese and she had PPH, generally a obese patient, history of PPH, we do consider thromboprophylaxis. So in case she undergoes a uterine artery embolization, can we still offer a thromboprophylaxis for this kind of patient?
Once the bleeding is controlled, we can go for the prophylactic thrombolysis.
Yeah. So one more thing I would like to highlight is this particular patient who had secondary PPH for whom uterine artery embolization was done. After 3 weeks, she developed a DVT incidentally. So currently she is on thromboprophylaxis, but she is doing well. So that's my experience regarding this procedure and thank you so much.
And just
any questions in the audience?
Finally, I would like to tell from whom to do, when to do, now it has come, who should do. So these procedures can be done by any interventionist. Cardiologist can do it, intervention radiologist can do it, vascular surgeons can do it. But prevent hysterectomy is the only point of it. Anyone can do it. And regarding the cost, Most of the particles are very costly, but when we use a glue costs only 1500 rupees. So we can finish the procedure within cost limits.
Thank you. Any questions in the audience? Pregnancies following uterine artery embolization, do you have any experience?
No, most of the patients, they come with retained products of conception. Few come with bleeding. I mean, when we do D&C, they come with uncontrolled bleeding. In those cases, we do. But as I mentioned, next pregnancy, are you asking, ma'am? Next pregnancy, fertility is not going to get affected.
And how long should we wait before asking the patient to start planning again, generally after a UA procedure?
There is no time limit for it. Regularly, how can they follow the same thing?
Okay.
Because we are just selectively cannulating only the bleeding feeder. Okay. We are not doing anything to the rest of the vessels.
Okay. Thank you.
I request Chandana ma'am to please give away the memento to Dr. Nishan Reddy. Thank you, sir. Thank you, ma'am. I now invite Dr. Lakshmi Priyanka, medical oncologist, to share her insights in situations when oncology meets obstetrics, the risks, the long-term outcomes, and the outcomes for both the baby and the mother. All yours, ma'am.
A very good afternoon to everyone. So I'm Dr. Priyanka, consultant medical oncologist in KIMS Kondapur. So I won't be bothering you much. So I'll be going through how to manage cancers in pregnancy and what to do, what not to do, and how common it is. So what are the common misconceptions we have? So we'll go through that. So with the rising trend of delaying childbirth, as we all know, I think the previous speaker has discussed, so we cannot stop the biological clocks. So with the trend of delaying pregnancies, so nowadays everybody wants to have late pregnancies because of their own personal choices. So, and we all know with age, the risk of cancers increases with age. So given that the incidences of cancers in pregnancy, though used to be rare, it has becoming common, and it's estimated that 1 in every 1,000 pregnant women are diagnosing with cancers. And most common being the breast cancers, cervical cancers, melanoma, and low-grade lymphomas being the most common. And it's very important to have a very clinical suspicion. So whenever a patient complains of a breast lump or a typical vaginal discharge or a changing mole or an enlarging lymph node, rather than attributing it to just pregnancy symptoms, I think clinical suspicion should be there. They can be cancers and should be evaluated properly. So when indicated, pathological examination of the lesions and evaluation, just like for any normal woman. So this lesions in pregnancy should be evaluated following the standard protocols. And as most people do, FNACs are not at all recommended. So because they are not the standard, first point, and second thing is because of the pregnancy changes. So this proliferative changes can be, normal proliferative changes can be there. So in normal FNACs. So biopsy is the standard, and biopsy should be done because it helps both in the diagnosis and also for doing further IHC tests or any molecular testing. And as most people think, no, pregnancy doesn't cause cancer. So though the pregnancy might impact the prognosis of the cancer, because as I said, most of us tend to ignore the symptoms of pregnancy, symptoms of cancer, thinking they are pregnancy associated, leading to late diagnosis. And also most women are in their 20s and 30s, which usually have this genetical component. And also it's a dictum that the younger the cancer diagnosis, the worse they do, because the aggressiveness of the disease. So those all contribute to the poor prognosis, but cancer by itself is not a precancerous, or it doesn't increase the risk of malignancies. And usually the prognosis is comparable with age and stage matched non-pregnant patients. So as said, so most of the normal pregnancy symptoms, they overlap with these cancer symptoms like nausea, fatigue, and breast tenderness, which most of the times get ignored, and abdominal pain, so which usually gets to be thought as normal pregnancy pain, but it can be a pain because of colonic cancers. So it's very important to have a very high suspicion, and as we all know, early detection is very crucial in management of these patients. And to diagnose, so what to do, what not to do. So ultrasound is the safest modality for evaluating these patients. So either for both breast and abdomen or pelvis, ultrasound is the preferred modality because of the zero radiation. And if required, chest x-rays can be done, and even mammo can be safely done with adequate abdominal shielding. Usually double shielding is usually preferred, but even though MRI without gadolinium is contraindicated in pregnancy, but most of the time we prefer using ultrasound, because MRI again without gadolinium might not give us much information. So, and in early stages of malignancies, we usually don't need to have extensively worked up. So we usually stick it to ultrasounds, but if required, MRI without gadolinium can be done safely. But CT scans, PET scans have to be avoided. And one more important thing is serum markers. Serum markers, which usually everybody would recommend, like CA125 or CEA, CA15.3, they all will be erroneously raised. So they should not be the tests. They are not indicated. And one more point I want to reiterate is biopsy is not at all contraindicated, and it's absolutely safe during pregnancy. So I have come across some patients where they were advised termination before even they were subjected to biopsy. So please understand that it's absolutely safe. Ultrasound modalities and if required X-rays are also absolutely safe in these pregnancies. And while managing these cancers, what things should we be considering? So as we all know, it's always a balance, and balancing both maternal health and fetal safety is very critical. And treatments all should be multidisciplinary and should weigh both the benefits to the mother and also the fetal health. And it should include medical oncologist, maternal fetal medicine, neonatology, anesthesiology, and surgery, and also psychologists, because psychological support is very important for these women, because they are undergoing both the pregnancy and also the cancer diagnosis. They have a lot of stress, so we should be minding all that also. And personalized treatment, it's not a single size fits all, it's always a personalized treatment, individualized treatment, and it depends on patient, what the patient characteristics, and also how's the patient's overall health, and what's the cancer stage, what's the type, what's the gestational age, and most importantly, her preferences. So while treating, what are the modalities available? So we have different modalities for treating of cancer. We have surgery, we have radiation, we have chemotherapy, we have newer therapies like targeted therapies, immunotherapies, we have hormonal therapies, we have different therapies. But how safe are these procedures? What to use, what not to use? As we all know, surgery and chemotherapy are absolutely safe during pregnancy. So it's not like for every pregnant woman who were diagnosed with cancer, we just ask them to terminate the pregnancy. It's not. So surgery and chemotherapy are absolutely safe, particularly when the patient gets diagnosed in second trimester or third trimester, they're absolutely safe. Whereas radiation, immunotherapy, targeted or hormonal therapy, these are all contraindicated because of the fetal side effects. So surgery can be safely done at any time during the course of pregnancy. Particularly, second trimester is considered optimal because of the risk of miscarriages with the first trimester and also increased risk of preterm labor with third trimester. Second trimester is usually considered optimal, and post-operative monitoring with the fetal heart rate tracking and obstetric support is recommended. With tocolites may be considered if because uterine manipulation has occurred, and there is always risk of preterm delivery and must be thoroughly discussed with the patient. And venous thromboembolism prophylaxis with low molecular weight heparin is very critical because of the prothrombotic state of the pregnancy and prothrombotic state of the cancers, and also immobility after the surgery. And systemic therapy, chemotherapy should not be administered during first trimester because of the increased risk of fetal malformations as high as 20%, but they can be very safe during the second and third trimester. But not all chemos are equally safe, and it's always personalized medicine. So exposure during second and third trimester. So as most people think, no, they are not associated with genital malformations, or they're not associated with any gonadal dysfunctions. But of course, they have their own risks. Their risks of low birth weight and prematurity is present, and they need all these patients. They are considered high risk, and they need to be monitored very closely, particularly for the fetal growth, cardiac function, and hematological status. And it's a multidisciplinary care. So these are the common malformations or complications we usually see. So, and as most common breast cancer surgery is absolutely safe, particularly in second trimester, and chemotherapy should be the goal. And even in the hormone positive or HER2, I'll conclude. HER2 therapies or hormonal therapies are absolutely contraindicated, and even in cervical cancer, where radical hysterectomy or pelvic radiotherapy is the standard. So these patients can be safely managed with the chemotherapy till delivery, and then can be, at the time of cesarean sections, can be offered radical surgeries. And lymphomas, so this is one area where low-grade lymphomas, though are the more common, can be managed with observation, but high-grade lymphomas, because they have very much impact on the maternal health, so termination should be advised in these patients. And patients who were treated with the lymphoma in second or third trimester, so rituximab when given, particularly neonatologists should be aware that they impact fetal immunity.
Of time, Dr. Priyanka,
So, 2 minutes.
We can wrap up with your take-home messages.
Yeah. So should be aware that they impact fetal immunity because of, even though the B cells are recovered, they are still prone for infections. And timing of delivery, 37 weeks should be the target whenever it's feasible, because before that there's a subtle but significant cognitive impairment has been observed. And there is always a 3-week period should be allowed between the last chemotherapy and the expected date of delivery. And placenta should be sent for histological examination. So after a normal delivery or cesarean section, placenta should be sent for histological examination to look if there are any placental metastases. And normal delivery is absolutely safe, and breastfeeding can be safely given once the washout period has been there. So it usually is 14 days. It's absolutely safe. So take home messages, imaging is safe, and chemotherapies during second and third trimester are absolutely safe, but these fetuses exposed to during second trimester should be regarded as high risk, and full-term delivery should be targeted whenever possible, and placenta should be subjected to histological examination, and it's always multidisciplinary management. Thank you.
Thank you, Dr. Priyanka. I'm sorry we had to cut short because we have number of talks lined up. But I think gynec oncology is a very important and evolving area of interest now for all the obstetricians who have gathered today. So if we can quickly have just one question, and then I'll hand over back to Dr. Chandana to summarize with her closing points.
So this is about pregnancy and cancer management. It was a wonderful talk. You have comprehensively covered a lot of things. It's a very big topic actually. I would like to ask, after chemotherapy, how early can a patient get pregnant? I'm not talking about a patient who's already pregnant.
After chemotherapy, most of our patients, they wanted to have pregnancy, but usually, there is no safe period when they can get pregnant, but usually we consider 2 years. 2 years is the time where the risk of relapse usually would be very high. So after that period, we usually, if they wanted pregnancy, they can safely go for pregnancies, even in the patients who are on hormonal therapies, particularly. So breast cancer patients who are on hormonal therapy, usually put them on hormonal therapy for 5 years or 10 years. So even there is this new study called positive trial, where in breast cancer patients who wanted to have pregnancy after minimum of 2 years of adjuvant endocrine therapy, they can safely stop the endocrine therapy, have the pregnancy, and can restart the hormonal therapy. But we should point here is, at least 2 years of hormonal therapy is indicated, and when they resume hormonal therapy, breastfeeding is absolutely contraindicated. So it can be, usually 2 years is the period. Okay. And after stopping of the hormonal therapy, we usually ask them to wait for at least 3 to 6 months, so that the drug will wash out from the body.
Okay. And another interesting question I wanted to ask is how to follow up cancer survivors who have currently become pregnant. I think we'll reserve it later.
So cancer survivors who have become pregnant, it's just like any other pregnant lady.
So a multidisciplinary team.
It's all multidisciplinary, following up with the oncologist and gynecologist.
And
there is no data, most of the trial, there are many trials which, many studies which looked upon whether patients, cancer survivors, when become pregnant, is there any fetal side effects or is there any defects in the fetus? So there is absolutely no harm to the fetus, and even the maternal health is not affected.
Thank you. Thank you. Any questions in the audience?
I think we'll request them to discuss with the speaker in the lunchtime. Thank you so much, Dr. Priyanka and Dr. Chandana, for moderating this session. It was really interesting. And I'm going to request Dr. Chandana to kindly felicitate our speaker, Dr. Lakshmi Priyanka, for enlightening us on the gynecological conditions in pregnancy. And I'll request Dr. Ishita to kindly felicitate Dr. Chandana for chairing this session. So for the next bunch of sessions, which again are interesting and clinically very relevant for us, we have a talk by Dr. Ramya, our breast surgeon. Dr. Ankita is going to talk about immunizations in pregnancy, and we're going to discuss about a new kid in the block, which is RSV monoclonal antibody. So we're going to invite Dr. Vasunthara, gynecologist, senior obstetrician from KIMS Cuddles, Secunderabad. Dr. Vasunthara, I think, needs no introduction. She's someone who has extensively trained in obstetrics, high-risk pregnancy, and she has keen interest in laparoscopic gynec surgeries. She runs a teaching program for training a lot of young students and budding obstetricians in laparoscopy. I think that is her area of interest. So welcome, Dr. Vasunthara, and thank you for joining us today. I request you to kindly welcome the first speaker, Dr. Ramya Valiveru, to talk on breast conditions in pregnancy. Can we have the CV slides, please?
Hello. Now I request Dr. Ramya to take over the session.
Good afternoon, everyone. So can I have my slides? I'm Dr. Ramya. I'm a breast and endocrine surgeon. I work here at KIMS Kondapur. I closely work with KIMS Cuddles. So as we all know, obstetricians and gynecologists are the first point of contact for any lady with breast problems, isn't it? So it's very relevant to have this session today. So I'll be talking about breast conditions in pregnancy and lactation. So I can end the talk here by saying that anything that can affect the breast can affect the woman in her pregnancy and lactation, plus a little more. So we all know, I mean, you often see pregnant ladies with all these changes, darkening of areola, increase in areola diameter, enlargement of nipple, and prominence of Montgomery tubercles, increase in vascularity because of all the hormones. I need not tell you all those things. But one thing I want to highlight from this busy slide is that there is a junction between the stratified squamous epithelium of the nipple skin and the duct, lactiferous duct. So any intraductal pathology, as we can see here, can therefore present as a skin problem. So don't take any skin problems of the nipple easily during pregnancy also, like in any other time. So just to enumerate, we all know these things. There are inflammatory conditions like eczema, contact dermatitis, and infections. And benign tumors especially I want to highlight, I'll show in the coming slides. Nipple papillomas and adenomas are also very common during pregnancy and lactation. And there can be joggers nipple or inflammation and because of friction with the clothing, especially more so because the nipple becomes more prominent during pregnancy. And there can be malignant conditions of the nipple and areola like the Page's disease, I mean presenting as nipple areola conditions during pregnancy and lactation as well. So here in this particular slide, here is the nipple adenoma in a non-pregnant lady. How you can see it's clearly demarcated, and when we excise it will be a small round ball like this. But in the right side pictures I've shown nipple adenoma in a lady with pregnancy who is due for lactation, right? So due for delivery. So here you can see that I have highlighted how the skin is intact but it is soggy because there have been prominent lactiferous ducts that have been obstructed by this nipple adenoma which is sitting adjacent to these lactiferous ducts. So here when she came to me during lactation, I have excised her adenoma and put interrupted sutures because we don't want the lactation to get obstructed. I want to remove the obstruction but still keep the ducts open. So this is how we have to plan. Whereas we just remove the adenoma and close this in non-pregnant or non-lactating ladies. So this is a lady with nipple fibroma during pregnancy. It's a simple excision. It was done under short GA in second trimester, and this is a picture I taken from internet, but this is just a representative of how a Page's disease can present even during pregnancy. It's actually a disease of lactiferous ducts, but it travels along the ducts underneath the skin and erodes the skin. So difference is that the skin is not intact in these women. The nipple areola skin is desquamated. If we do CK7, it will be positive, saying that it is from the breast origin. Some rare diseases during pregnancy, like the cysts of Montgomery, because of accumulation of secretions of Montgomery glands, and hyperkeratosis of the nipple can also happen. But most commonly, we see galactoseals, lactational mastitis, and there is no need to explain why these happen. There is an obstruction to the outflow of milk that gets superadded infections. Granulomatous mastitis is rampant. We are seeing these very commonly these days. This happens because of secondary infection in the residual milk in paras women who have about 3 to 5-year-old children with immunological mediated exaggeration of this particular inflammation. So any proliferative lesion like fibroadenoma, lactating adenoma, Phyllodes tumor, we have seen even Dr. Shilpi's patient present with a huge breast lump during lactation. We have excised it because it was causing obstruction and infection. It turned out to be a Phyllodes tumor with milk production within it. And even breast cancer is very often seen during pregnancy and lactation. And there are multiple reasons why pregnancy, we keep saying that pregnancy is protective against breast cancer, but it is a little counterintuitive to understand how then breast cancer can happen during pregnancy, isn't it?
but it is a known entity. It's the most common cancer affecting women during pregnancy. And it is defined as breast cancer that is diagnosed either during pregnancy or in the first postpartum year or any time during lactation. Just last week, I have inserted a chemo port for a lady with lactational diagnosis of breast cancer. Here, the problem is the diagnosis becomes delayed because the engorgement of the breast because of milk versus tumor gets a little confusing, and ultrasound or MRI that we do is going to present a confusing picture. So guided biopsies are very, very important in this situation. Generally, they are the type of cancers are same as that of we see in non-pregnant ladies, but triple negatives and HER2 positive tend to be more. The one that I operated last week was a ER/PR positive. So any cancer can occur, any type of breast cancer, but it's almost similar to what we see in non-pregnant ladies. There are multiple theories. None of it is proven what could exactly be the reason in this particular lady. So, I mean, even if I talk half an hour about it, it's not going to really make an impact on the patient management. So, but they are a little bit more aggressive. One thing is we diagnose them late. They tend to be on the high histological grade, high proliferative index, larger tumors, more advanced stage, and tend to be more triple negative, as I said. So it's important for the obstetricians to have high index of suspicion and not to miss them on time. So it's a very common scenario where a gynecologist is presented with a radiology report saying a Biret's 3 lesion. And then later we see that in follow-up this has turned out to be a carcinoma. It has become, so the average age of breast cancer diagnosis has shifted now. We no longer say it is 45 or 55. It is 35. Trust me if I said, yesterday I have seen a 22-year-old with breast cancer who had gone to a gynecologist in Anantapur with a breast lump in May. Right now it has spread to lymph nodes. So so any Biret's 3 needs a biopsy. Don't think twice before doing a biopsy. So, I mean, failure of lactation is another challenge that we all face with, right? So, improper establishment of lactation is only rarely just because of the problem in the breast. It's multifactorial. So the traditional view is that if the infant suckles well and if mother is willing, then there is lactation. It's not like that. There are so many factors, even genetics that are involved, environmental exposures, patient psychology, endocrine physiology, the gland development itself, any previous breast surgeries, and lactation performance as well as milk composition all will be affected by these things. So we all should not just fanatically push into, encourage the baby, encourage the mother. No, there are so many factors which may prevent successful establishment of lactation, and then a timely initiation of supplemental feeds is very, very important. And giving psychological support to the mother at this point of time is very, very important. And we all commonly face with this inverted and flat nipple. A flat nipple can still be suctioned out, but a completely inverted nipple, there's no other way. Surgically, we may cosmetically correct the nipple, but we cannot establish the connections that have to be present between the glands, ducts, and the nipple. So it's a congenital condition. We really can't do much about this. So, but this can create more lactational mastitis if the lady has established lactational pathway. So a lot of active work is going on in genetics in lactational failure, both in terms of the composition of milk as well as how successfully the mother is able to feed. And I think in coming decade, we are going to have exciting outcomes of these studies. So certain environmental toxins are endocrine disruptors which are interfering in successful establishment of lactation. So, yeah, so I think we have 2 more minutes. Breast incisions surgery, it's important for the breast surgeon to remember where to place incisions. I preferably don't encourage peri-areolar incisions for cosmesis in nulliparous because we tend to cut the ducts also. Some of these ducts come superficially joining into the sinus and into the nipple. So better to place it directly on the lesion if the surgery is really needed. So that's one thing, and if it is not possible to preserve, then it's okay, the other area of the breast is going to take care. So just to conclude, I want to highlight a couple of factors. Don't ignore any Biret's 3 lesions. Just don't take the radiology report for granted because the scenario has changed. I myself keep seeing a lot of Biret's 3 lesions which turn out to be carcinomas. So high index of suspicion, whether a lady is pregnant or not, is very, very important because there are quite a few scenarios where the patient has gone to the doctor has believed the report, done everything correctly, but still patient ends up with advanced stages of cancer, which could have been prevented. And second point I want to highlight is that lactation failure should be taken a little more comprehensively, just not, and many of the times we really can't do anything about it. So women start crying that, I really want to feed the baby, what can I do, what can I do? So I think if everything is done well, only so much is in our control. So just giving her psychological support is also important sometimes. That brings to the end of my presentation, and I think we have few seconds for questions.
Thank you, Dr. Ramya, for a very good practical presentation. And you have given us so many spotters which, refreshed our memory. The thing is, one question I would like to ask here is, what is the common mistake what we do in evaluation of a breast lump in a pregnant and not lactating women? So many times we'll be missing the probable diagnosis, whether it is a mastitis from the lactation or any underlying malignancy condition. What is the key point you would
That's a great question, actually. So whether pregnant or non-pregnant, breast lump or lesion diagnosis has 3 very simple steps. One thing is a clinical history and examination thoroughly done by a trained breast specialist. Second assessment is a radiological assessment. Again, the person who's reporting, because we're trusting these reports, is very, very important. And third thing is a pathological assessment. If needed, then automatically we should not think twice in doing a biopsy. FNAC in breast lesions is long gone. We only do guided biopsies. It's pretty safe. It's available, and that clinches the diagnosis. So whether pregnant or not, this triple assessment must be followed. Then we won't miss anything. Thank you.
Thank you so much, Dr. Ramya.
Thank you.
May I invite Dr. Neha Reddy ma'am to come up on stage and give the memento to Ramya ma'am. I now invite Dr. Ankita Chauhan ma'am, our consultant obstetrician and gynecologist, to guide us through the journey of immunization from preconception to pregnancy. So maternal immunization, of course, has made great strides, and with increased awareness, mothers themselves are asking for any evaluation before becoming pregnant to again prevent a lot of communicable diseases which could be passed on to the neonate, and with the increasing advent of preterm births itself. So there are many vaccination options which could help both the mother and the baby. So Madam will guide us on that. All yours, ma'am.
So hello everyone, I'm Dr. Ankita Chauhan, obstetrician and gynecologist, minimal invasive surgeon, and part of robotic team. So when we are talking about immunization in pregnancy, we are not going to talk only about the vaccines which we give in pregnancy, but also the important ones which we should not miss before pregnancy. So when should we start thinking about our maternal immunization is not the pregnancy. So my answer for this question would be, as soon as a female enters a reproductive age, we should start thinking about all the immunization which are related to pregnancy and preconception period, rather than starting when she is planning pregnancy actually. So why does it matter to get hold of the reproductive window in women? Instead of thinking, okay, preconception period, pregnancy and the postpartum, we should start thinking about adolescent life or reproductive life, preconception, pregnancy, postpartum, whatever the vaccinations are involved, and when to plan the next pregnancy. Why it is important? Because we have certain limitations when we talk about vaccines, because there are certain vaccines which can be given only during pregnancy. There are certain vaccines which should be avoided during pregnancy, and there are certain vaccines which are best given during postpartum period and are contraindicated in the pregnancy. And why it is important? Because it also provides, during pregnancy, whatever we give, it also provides passive immunity to the fetus and avoid, I would say, severe newborn conditions. So this is about the checklist related to the preconception vaccine. So when a adolescent girl comes to our clinic, we have to make sure, adolescent girl or anybody in a reproductive age group comes to our clinic, we have to make sure to check their previous vaccination history, their any infection, the risk factor associated, their travel history, occupation, and immunity whenever we need to, whenever clinically indicated. Now we have to catch up whether she is vaccinated for rubella or MMR, varicella, HPV, hepatitis B, and other indicated vaccines which can be like according to the local guidelines. If she is not vaccinated, even if she is vaccinated for some, we have to make sure that we are counseling her about the vaccines which are safe during pregnancy and what are the vaccines which we should complete before she becomes pregnant, and what are the vaccines attempted when a pregnancy can be planned after giving a live vaccine. So there's a list of must not miss before pregnancy. These are the vaccines which we should make sure that she is getting before she gets pregnant. First is MMR or rubella. If she is not immune, vaccinate before pregnancy. Varicella, if not immune, give 2-dose vaccination before pregnancy. HPV, according to her eligibility age criteria, finish it off before pregnancy if possible. Same goes for hepatitis B. Tdab and TD is also important. And FOXI and ICOG recommend that MMR and varicella vaccination in susceptible women during preconception period and advises them during pregnancy and avoid pregnancy at least after 1 month of the vaccination. Why rubella is important? Rubella should be given in the preconception period. Why it is important? Because if mother catches rubella during pregnancy, it can lead to miscarriage, fetal death, and congenital rubella syndrome. So it is important to identify whoever is not vaccinated for rubella, vaccinate them, wait for that window and let her get pregnant and let her plan the pregnancy. The important counseling point is if a woman discovers that she is pregnant shortly after MMR or a rubella vaccine, that is not an indication for termination or an MTP. The vaccine is contraindicated in pregnancy, yes, but that does not mean that if by chance she became pregnant after the vaccination, then we have to terminate the pregnancy. Next is varicella. It is another vaccine which has to be finished before during a preconception period before pregnancy. So ask her if she had a chicken pox in her childhood or has she received her 2 doses of vaccine. If not, give those vaccines around 4 to 8 weeks apart and tell her to avoid pregnancy at least 1 month after the vaccination is completed. Again, why it is important? Because it can lead to severe maternal disease during pregnancy, pneumonia, fetal complications, and a congenital varicella syndrome. FOXI and ICOG again specifically recommend that these vaccines should be given during a preconception period. Once she is pregnant, now we have to make our approach we have to counsel differently. Now don't ask what vaccines are allowed. Ask her which vaccine does this pregnancy need. So according to the current ACOG guidelines, we need to give influenza, COVID-19, Tdab or TD, and RSV vaccines. Other vaccines which are considered according to medical indication, exposure, travel, and risk factors, we can plan. Now the flu vaccine or the influenza vaccine, the one which we give during pregnancy has to be inactivated or a recombinant vaccine. It can be given in any trimester, but we usually prefer during a second trimester. Every influenza, it has to be repeated after every influenza season, and it can be co-administered with any other vaccine. Why it is important? Because during pregnancy, we have a high risk of severe influenza and its related complication. And again, anything which we administer to the mother, the antibodies are going to cross the placenta and the immunity is transferred to the baby. So we are protecting both mother and the child. According to WHO, pregnant women are an important priority group for flu vaccine. Now comes the Tdab. The vaccine protects again the baby and the child both, and the Tdap has to be given in every pregnancy. According to current ACOG guidelines, it has to be given between 27 to 36 weeks and preferably early in this window. The purpose isn't only the maternal protection. Again, maternal antibodies crossing the placenta and protecting the newborn in the first few months of the life. WHO again recognizes that maternal pertussis vaccine helps in protecting the baby in the initial neonatal life when the baby is too young to be vaccinated. Now RSV, this is the newest member of the vaccine list. Certain countries like US have already included this in their vaccination schedule, and in India we are also coming and joining the team. So WHO recommends that maternal RSV pre-F vaccine in the 3rd trimester. The main goal of this vaccine is to provide passive immunity to the baby. And according to the ACOG 2026 guidelines, it has to be given in between 32 to 37 weeks, preferably again as early as possible after 32 weeks. Why it is important? Because RSV is a virus which can cause severe lower respiratory tract infection in the babies at a very young age, before the baby's immunity is ready or before the baby is ready to receive the vaccine. So vaccine is again important example of maternal immunization is equals to neonatal prevention or the safety. Now COVID-19. According to current guidelines, it can be given in any trimester pregnancy, because in pregnancy we have a high risk of COVID-19, and it has been shown that COVID-19 vaccination is not associated with any risk factors in the pregnancy. What not to give? MMR, varicella, and any live attenuated vaccine like influenza vaccine. But these vaccines are not a contraindication. They are contraindication in the pregnancy, but they are not an indication for termination if given by chance or if the patient is pregnant immediately after the vaccination. If you come to know or the patient comes to know that she is pregnant after these vaccination, don't panic, just counsel her. Make sure that you're observing her and monitoring the baby closely. So there are, I would say, during preconception, MMR, rubella or varicella, HPV, hepatitis B, pneumococcal, meningococcal, hepatitis A and HPV vaccine are the main ones which we give during preconception, during pregnancy, flu vaccine, COVID, Tdap, RSV, and postpartum. If not given, then MMR, varicella and HPV. Why it is important? Because don't forget, the next pregnancy care starts from now, that is postpartum window. So let's take a home message. Don't wait for pregnancy. Don't miss the maternal window, that is a reproductive age. And when you are thinking about vaccine, just don't think about the mother. It is mother plus baby. That's it. Thank you.
Thank you, Dr. Ankita. You have nicely elaborated the most important part of the preventive medicine, that is the preconception and conception and post-conception vaccination. And here I would like to ask you a question. If in any case, unfortunately, if you get a patient visit, a preconceptional visit for a single time, which vaccines would you recommend to be covered? Unfortunately, if your patient comes to you for one time in the preconceptional period, which vaccines you make sure that are addressed? Okay. So what time would you recommend a gap of pregnancy?
Any audience questions? Thank you, Ankita ma'am. May I request Dr. Shilpi ma'am to give the moment to Dr. Ankita, please? I now invite Dr. Aparna ma'am for the talk on RSV Decode Blue. To complete the spectrum of immunization across the perinatology spectrum, Madam will be sharing insights on the urgency and the importance of protecting vulnerable babies against RSV.
Thank you, Dr. Ishita. And with the permission of the chairperson, can I begin? So today we're going to discuss in this session, and I promise not to take more than 5 minutes. This is kind of an introduction to a new novel immunization that has excited a lot of us as neonatologists, as pediatricians, and we wanted to discuss this in this conclave of obstetricians, of perinatologists, because we all jointly are stakeholders in the care of high-risk babies. So this is Decode Blue, the India RSV Pneumonia Forum. So to introduce RSV, this is respiratory syncytial virus, which is one of the commonest viral infections accounting for pneumonias, lower respiratory tract infections, and pneumonias requiring hospitalization, especially in infants less than 1 year. So if you look at global data, this is post-neonatal child mortality. So after 28 days and until 365 days, what is the biggest contributor of post-neonatal infant mortality? And when we look at this data, almost 20% is because of lower respiratory tract infections. And again, when we look at the breakup of various contributing viruses, bacteria responsible for lower respiratory tract infection, almost all studies across the globe usually agree that RSV is much more commoner or is the most important cause of respiratory infections and respiratory infections causing death among infants, and that way much more commoner than the combined incidence of streptococcus pneumonia as well as rotavirus. So these are some other vaccine preventable infections that we regularly cater to in our vaccine practice. Now, not only is RSV common among children less than 1 year, and not only is it a common cause of respiratory infections related mortality in infants, but it is also something that is exceedingly common in the first 6 months. So if you see the most vulnerable period for the infection, it is seen that 2/3 of the hospitalizations and 50% of all the deaths due to RSV in infants occurs in the first 5 months. So we really have no time to protect our infants. You know, we may have very little opportunities to actually offer protective strategies because the highest risk period seems to lie within the first 5 months of birth. So this is more data coming from various other studies that RSV is contributing to almost 63% of the acute respiratory tract infections in children. Not only is it a common cause for viral bronchiolitis, it is also one of the common causes for bronchiolitis associated with secondary bacterial infections. So if we can some way prevent RSV infections, we can also prevent these secondary bacterial infections, which in turn would require antimicrobial, antibacterial therapy. So if you see in terms of its transmissibility, it is almost 1.6 times more transmissible than COVID infection, 3 times more than streptococcus pneumoniae or pneumococcus infections, and more than 70% infants infected before they turn 1. So the next question is, we know RSV is a common cause of bronchiolitis in the Western literature and across the globe. Is this also true in the Indian context? The answer is again a big yes. So we can see that India is contributing to almost 20% of the total RSV related LRTI burden across the world. So yes, it is a very, very common problem even in India. And again, as we saw in the global trend, the RSV infections tend to occur early in infancy, usually less than 3 months, and it's a major burden experienced by children who do not have other comorbid conditions. Now, we may often believe that, okay, this infection is common among preterm babies, among NICU graduates, babies who are getting discharged from our NICUs, but because of the much more larger proportion of so-called well infants, term infants who never pass via NICU, this chunk of population actually contributes to a larger number of RSV-related hospitalizations and pneumonia, and this is seen in a lot of studies published in the Indian context as well. So do we have Indian large-scale data to substantiate this? Yes. So this study, ANISA, was a large community-acquired serious bacterial infection surveillance among young children in Southeast Asia. They scanned almost 63,000 babies. And true to all the other evidence that we saw so far, almost 6.5% of all the isolates were respiratory syncytial virus. Again, even in the ANISA study, RSV was found to be the biggest single most important contributor for bronchiolitis and pneumonia. And this has also been seen from tertiary care NICU-driven studies from the Indian subcontinent. So we are convinced that this is one of the commonest infections both in the global and in the Indian perspective. And preventive strategies. So RSV being something which is not easily amenable for treatment, we do have treatment in the form of ribavirin, which is offered for immunocompromised infants with RSV infection, but this is not usually offered for immunocompetent children. So what else can be done has always been the question. But it has taken almost 70 years from the time that the RSV virus was first isolated in labs. It has taken almost 70 years today as we stand in 2026 for us to actually understand the most ideal monoclonal antibody designed to protect infants against RSV. So earlier we used to have this molecule called palivizumab. So this was being offered as 5 doses given at a gap of 1 month. So it used to be given over a period of 5 months during the peak RSV season. So this had its own feasibility problems. There were complaints issues. Parents would come for the first and second dose. They may miss the subsequent 3 doses. It came with a cost of almost 20,000 per vial. So the cumulative cost to the family was almost rupees 1 lakh to prevent this infection. Although we all believe it is important, this was becoming a feasibility and a compliance issue, and also the associated huge cost. And finally, it took some more time for us to be able to identify this molecule, nirsevimab, which is available as Befortis. And there is enormous volume of evidence from systematic reviews to show that the use of a single dose of nirsevimab reduces the need for RSV-related infections, hospitalization, and severe episodes of RSV-related LRTI by almost 70 to 80%. And these results are again substantiated in the low middle income countries. So now let us come to the final part. Is this monoclonal antibody being currently recommended for use across guidelines? Again, the answer is yes. The first body to actually come up strongly in favor of RSV monoclonal antibody preventive measure was the World Health Organization. They came up with this guideline because of the large volume of body of evidence that RSV is a leading contributor of viral pneumonias and pneumonia-associated deaths. And this was closely followed by numerous other bodies, including the CDC, the European medical agencies, and more recently by Indian Academy of Pediatrics and the NNF in support of a preventive strategy, especially for the high-risk infants, preterm infants entering their first RSV season, and wherever feasible, this is to be offered for even full-term, so-called normal risk infants. Now, I think there is a lot of evidence, and this is all available from the online literature, and this is all freely downloadable now. Now, the next question that I'm sure all of you would have in your mind is this really cost effective? So we discussed about the effectiveness, we discussed about the efficacy, we saw that it reduces the risk of RSV-related hospitalization by almost 76%, so very, very convincing evidence that we have. But before we translate any kind of evidence to practice, we also need to look at the cost-benefit analysis. So let me just look at that slide for all of us. So when we look at the cost effectiveness data, we all understand that a single episode of RSV pneumonia requiring a pediatric ICU admission can be enormously expensive to the family. So when you look at the cost analysis, so this is the data for most of the other vaccines. So influenza, pneumococcal vaccination, rotavirus vaccination. So the number of infants that need to be immunized to prevent a single episode of these infections is as high as this. But with RSV monoclonal antibody, because of the high incidence of the infection, you need to only vaccinate 25 infants to prevent 1 episode of serious infection. And when you look at the overall cost to prevent hospitalization, it doesn't seem to be a bad bet at all. So I would just like to conclude by summarizing that RSV is one of the commonest viral infections in infants and in children. It tends to be extremely common in the first few months after birth. It has been found to be the single most common factor for post-neonatal infant deaths, that is deaths occurring between 28 days to 365 days of the baby's life. And the single most effective preventive strategy for preventing this infection has been found to be this molecule nirsevimab. This is offered as a single dose intramuscular injection at a dose of 50 milligram for babies weighing below 5 kg and a dose of 100 milligrams for infants weighing more than 5 kg. It can be co-administered with most of the other commonly available vaccinations, either the birth vaccination or the 6 weeks vaccination, and it is not associated with any significant adverse effects. So India has been the leader in the burden of not only in number of neonatal births and deaths, but in the burden of most of the infectious morbidity as well. So let's now make it the leader in the preventive strategy against RSV. So thank you all for your patient listening, and thanks to the Mr. Govardhan who has come from Sanofi, and he has been a major pillar for supporting this event. But these slides are not just because of his support to the event, but because we are truly convinced of the scientific rigor and the volume of evidence behind the strong practice. Thank you all for your patient listening.
Thank you, Dr. Aparna. You have nicely charged up the glycemic index, especially during the lunch session. You have nicely pulled up. I would like to ask a question here. You have represented the evidence-based medicine cost factors and everything here. So how should we decide between the RSV vaccination and the monoclonal antibodies, because both being available at the same platform?
Which
RSV vaccination and the monoclonal antibodies.
No, we were discussing about the monoclonal antibody only. So the vaccination itself is a monoclonal antibody, madam.
Yes, ma'am. If it comes to the maternal vaccination and this thing.
Right. So, okay, I think ma'am's question is maternal versus neonatal vaccination. Yeah, that's a very interesting thought. Yes, maternal vaccination is also being strongly recommended by the World Health Organization, and it has the benefit of preventing very early perinatal transmission as well, because we all know that there are practical feasibility concerns when it comes to the postnatal acceptance of vaccination. Some parents may decide that they will come back and take it later, and even in those first few days the babies may be vulnerable. So it actually makes a lot of sense to offer maternal vaccination. So we would be very happy if you actually take it up from the obstetric side, and the WHO and other IAP position papers also talk about maternal vaccination. So either maternal vaccination, and whenever the mothers are not protected, the postnatal neonatal vaccination can be offered. Thank you.
Thank you so much, ma'am. May I request Aparna ma'am to hand over the memento to Chairperson Dr. Vasundhara ma'am. So with this, we come to the next module of our sessions today, the modern labor room. For chairpersons, I would like to invite Dr. Shilpi Reddy ma'am to take up the dais, please. Madam is our in-house director of obstetrics and gynecology. Madam is an entrepreneur. She has foundations, and she is actively involved across all spectrum of OBGYN. I also like to invite Dr. Bhagi Lakshmi madam. Madam is a senior OBGYN practicing as the HOD of Yashoda Secunderabad. We are thankful for your presence today, madam. As the first talk, I invite Dr. Sahitya. Madam will be enlightening us on the very pertinent topic of quality improvement in obstetrics. As we all know, India's MMR still stands way beyond the ideal target. And I think quality improvement projects are the way for the future. So over to you, ma'am.
So good afternoon, everyone. And let me start with a simple question, asking you all, how many of us have had a patient where we thought if only we had tried for 10 more minutes, like if we had 10 more minutes earlier, the outcome could have been better? I think in obstetrics, the 10 more minutes is very important, where we can change the thing saying that the women going home with a mother with her baby and a maternal near miss, a hysterectomy, or even a maternal death. So we have protocols and we have guidelines, we have trained people, we have ICUs, we have blood banks, and also the emergency drugs. But adverse maternal outcomes still occur. So the question is not simply, do we know what to do? The real question is, can our system reliably deliver the right care at the right time to every woman every time? And that is where the quality improvement comes in. Today, I want to talk about quality improvement initiatives in obstetrics, the way forward to improve the maternal outcomes, not as a theoretical concept, but as a practical way of changing the maternal outcomes. So here you could see the system where the different systems are there, same clinical knowledge, but the outcomes are very different. So here the contrast is here, the one hospital delayed the recognition of deterioration. There is no quantified blood loss measurement, late escalation to the senior clinician, and unclear roles among the team members, which resulted in a maternal near miss. Whereas the other hospital, which had a quantified blood loss from the outset and immediate protocol activation and simultaneous team activation and also the team response, defined the roles and clear communication, where the result was a stabilization. So here we see the same clinical knowledge, different systems, but there are two different outcomes. So this demonstrates not just the individual skill is very important for the quality improvement, it determines whether a woman lives or suffers a near miss. So here we all know like over 700 women died from the preventable causes, whereas Indian MMR, maternal mortality rate is 97, where we are still far behind the SDG goal, which is around 70 per 1 lakh live births by 2030. And every 2 minutes, one death from the preventable causes happening globally. So what we don't see, so for every maternal death, many more women suffer from the near misses. But what we are actually measuring is the tip of the iceberg, that is none other than the maternal mortality. So maternal death is counted, reported and investigated. But that is the very, very smallest layer which is very visible. But there are other more bigger layers under the surface where the near miss events are there, and also the foundation where we are following the unsafe processes, delays and poor communication, and also where we are missing the early warnings. So these are the underlying factors where we have to know that studying the near misses gives us the opportunity to learn before actual maternal mortality occurs. So where the quality breaks, whether it is a missed or delayed recognition, whether there is a weak pre-referral sterilization or there is an inconsistent protocol use. So we have to understand that complications such as PPH, eclampsia and sepsis are not identified in time, leading to the avoidable deterioration. There can be a weak pre-referral stabilization and also the inconsistent protocol use. So we all know this, where the leading causes of maternal deaths in India, the most common cause is the obstetric hemorrhage, and next comes the hypertensive disorders, sepsis and also the anemia. So understanding the primary reason for the maternal mortality is the first step towards the targeted evidence-based quality improvement techniques. So what is quality initiative, what is audit and what is a research? So audit, we cannot get confused with an audit and a quality improvement. Audit is something where we do a retrospective analysis or retrospective review of the cases to identify the deviation from the expected scale. So what actually happened is what we are actually doing it in the audit. Whereas in the quality improvement, we make the right care, which is whether it is happening reliably or not. So it is a prospective thing within our own system, whether the improvement is happening or not, and whether it is consistent or not is something what we are actually seeing in the quality improvement. So whereas the research comes with the evidence, and how do we improve the maternal outcomes? There is a model called as Donabedian model, where they have 3 intercommunicated domains where it contains a structure, process and an outcome. So, maternal outcomes are not determined by the complications alone, they are determined by the healthcare systems. So, this Donabedian model proposed 3 interconnected domains where it includes the structure, process and the outcome. So, here the structure is something which refers to everything which is available before the patient arrives to the hospital. So, do we have the capacity to provide the quality care like infrastructure, blood bank, ICUs, operative theatres, skilled obstetricians, nursing staff, drugs and equipment, ambulance and referral thing. All these comes under the structure which happens a lot prior to the patient arrives. So, next comes the process, and this is where the quality improvement, this is the most modifiable component of the quality improvement, and this is where the scope of improvement happens in the whole process of the quality indicators. So, are we providing the right care at the right time? So, how we can provide? Whether we are doing the early recognition of PPH, whether the timely escalation of the events are happening or not, if the mother is having a pre-eclampsia or an imminent signs of eclampsia, are we administering the magnesium sulfate at the right time? Antibiotics are we giving within 1 hour of the surgery, and decision to the delivery time, effective communication, that is nothing but a consent and a counseling, proper referral and documentation. So, this all comes under the process where the quality improvement plays a major role here in the model. And next comes the outcome. So, did our patient benefited with all this structure and the process is something what the outcome determines. Outcome can vary from the maternal mortality to severe maternal morbidity, ICU admissions, whether the mother is undergoing a hysterectomy and whether the mother is whether we are giving a healthy baby and a mother. So, if we don't measure it, you don't know whether to improve it or not. So, WHO 2025 practical guide specifically focuses on the selecting, tracking and analyzing the quality of care indicators and using the data to drive improvement. And this is something what we do for a PPH, where we have to understand if any event occurs, structure, process and outcome. So, if something called a PPH had occurred, what is the structure? Structure is nothing but whether we are arranging the PPH trolley, whether the PPH trolley is available or not, blood bank is ready or not, and trained obstetricians and nursing staff are available or not. And next comes the process where the PPH is recognized early with the early warning sign, and oxytocin whether it has been administered within 1 minute, and whether if there is a quantitative estimated blood loss if it happened, whether the massive transmission has been activated or not, and whether the senior consultant have been informed or not. And next comes the outcome, whether the bleeding has been controlled, no hysterectomy and no ICU admission, and the mother survives. So, any event if it occurs, it has to go in a Donabedian model, that is nothing but a structure, process and outcome, where these are very interconnected domains. So, we have 2 programs, Lakshya and Manyata. Lakshya is something which is for the public sector, and Manyata is something for a private sector this thing. And Lakshya is almost equivalent to the WHO, where it was launched in 2017, and the core objective is to reduce the preventable maternal and newborn morbidity and mortality, and the respectful maternity care, upholding the dignity, autonomy and the rights of every woman throughout the intrapartum period. So, as of 2023, over 2,600 facilities have been assessed under Lakshya, and audit-driven improvement also have been seen in this. So, quality improvement strategy comes with a PDCA practice or PDSA practice, which contains a plan, do, study and a act. So, whether you are planning the thing very well, whether you are analyzing the root cause analysis, whether the intervention is happening in a right time, and whether you are remeasuring it, and whether that sustainability of the thing is still maintaining or not. So, that comes with a PDCA strategy or a PDSA strategy, where we include the plan where the triage allocation happens, and do, checklist or a study, and also the acting. So, rapid 2-month improvement. So, here the whole thing what we have to understand is, after implementing this quality improvement indicators, the 2 month or 4 month, 4 weeks of whether we were doing it or right or wrong, and whether the improvement has happened or not is something, and whether if the improvement had happened, whether that was sustaining or not is something what we have to look into it in this PDCA practice. So PDSA cycle at work. So there is one example which was studied in the district hospital in Rajasthan. So before the PDCA practice, there was only 25% of laboring women who had a partograph on record. But after implementing this PDCA cycle or PDSA cycle, there was what they have identified is there was a staff shortage, printer malfunction and lack of supervision as a root cause analysis. And what they have done is pre-printed partograph bundles they have implemented, and weekly spot audits were done. And after some monthly review when they have done it, 58% improvement of partograph recording has been done at 8 weeks and 79% at 16 weeks. So what we could understand with this is protocol standardized facility which had improved the wide partograph compliance, which is around 92% in 6 months. So 25% to 92% is a quite improvement in this through a PDCA cycle. So the most maternal deaths are preventable with existing knowledge, and the gap is not just the knowledge, it is the system reliability. So documentation is very important, and respectful care as a clinical quality metric, and from guidelines to daily practice. So the goal is not one-time compliance but a sustained measurable reliability at every delivery point. So Manyata is something for a FOGSI-led quality certification program for private nursing homes and hospitals, which applied 16 clinical standards. So there can be 3 delays which can have a delay in the community. Next comes in the transport and hospital system. And from knowledge to action, protocols and bundles have to be in place, simulation and drills, and early warning scores and near miss this thing. So the take home message is maternal deaths are rarely due to a single person's error. They result from the failures within the healthcare system. Quality improvement focuses on the improving the systems rather than the blaming the individuals. Strong structure enables efficient processes which lead to better maternal and neonatal outcomes, where there is a continuous measurement, teamwork, simulation training, and learning from the maternal near misses are essential for the sustained improvement. Every obstetric unit can implement a quality indicator project. Start very small, measure the outcomes and sustain the change. Thank you. I know it is a very dry topic.
Thank you so much,
I
ma'am.
hope
Comments? Sorry for the time delay. We're really running short on time. Quick comments from the chairpersons, please.
I wouldn't say it's a dry topic. It's the need of the hour, because we have to bring down the maternal mortality as much as we have to bring down the infant mortality. And audit is very important, and it is a post-mortem of what we have done for the past 1 or 2 months. Audit will bring about a change. Simple partograph and Muse chart in the post-op period or post-delivery period will alert the nurses and escalate it to the next person involved, and these things really will bring about a change. And when a patient is being shifted from a smaller center to a tertiary care center, they should do it early. The golden hour is important. And is the patient reaching on time, and is the treatment started on time? Yeah. So these are the important bundles that we need to follow, and this will really help us to bring down the maternal mortality.
Whether there is a delay in the community or in the transport or at the healthcare system. So there can be 3 delays which can happen where we have to look into it.
It was a good talk.
Thank you, madam.
We have time, just like one audience question, if there is. Thank you, Sahitya ma'am. I think everybody's a bit hypoglycemic. I request Dr. Amit sir, our neonatologist, to please come on stage and hand over the memento to Dr. Sahitya, please.
It's our great honor now to invite our Clinical Director of Obstetric Gynecology, Dr. K. Shilpi Reddy, to deliver her much-awaited talk on the difficult labor room, and she is going to, I'm sure, take us through some interesting case scenarios spanning her vast experience in handling high-risk pregnancies. I know that we are just nearing lunchtime. I know some of you must be developing hypoglycemia. Please bear with us. I'm sure this talk will keep you interested and invested before we break for lunch, because we have a few interesting sessions post-lunch as well. So we are trying to kind of balance so that, we finish some of the important sessions pre-lunch. Thank you all for your patience.
Hello all. Welcome to this very, I should say very practical tips that we are getting on a regular basis in this perinatal CME. And today's topic is about a complete brush on what obstetrics is about. And nobody would want to talk about something that is so common, but we are actually encountering so many uncommon scenarios on a regular basis. Thanks to the ignorance of obstetrician that somehow some things are getting managed. But one take-home message that I would really want to give everybody out there is, individual practice in obstetrics is not recommended, because there are so many practical scenarios that every obstetrician can encounter, especially in the era of medico-legal problems and also high-risk pregnancies everywhere. We have a rampant diabetes that is happening as in the form of gestational diabetes. So every pregnant woman can have any of these scenarios that I'm going to discuss, and let's take one by one. So the agenda today is about labor dystocia, shoulder dystocia, abruptio, postpartum hemorrhage, maternal shock, malpositions, cord prolapse, eclampsia, VBAC, and uterine rupture. All of these scenarios give that threat to you as an obstetrician, because they are so overwhelming and they're so difficult to manage individually. That's why I always prefer a group practice and team. Even though it is a very simple, normal vaginal delivery that has progressed without any medication or support, still she can land into a PPH just in case if, the baby is little bigger. In a similar way, dystocias are becoming very common these days, because there can be slow labor, there can be problems in power, passenger, passage, and psych. And instead of, categorizing how do we diagnose slow labor and labor dystocia are very common in slow labors. No cervical changes post 4 hours for adequate contractions, and no cervical changes despite 4 hours for oxytocin with inadequate contractions. And this can lead to several problems in future. And managing labor dystocia, again, you can have augmentation, you can have continuous monitoring. Obviously take the help of people around you. Sometimes you can have a thought block. People around you are not in that stressful situation, they'll help you out. And there are limits. You can understand the second stage limit for a nulliparous with no epidural is 3 hours, and with epidural is 4 hours. That 1 hour because of the epidural. And multiparous, it's 2 hours and 3 hours. Now, there can be malpositions every place. Nowadays, we are seeing so many malpositions because of the lack of forces and pressure, because of gestational diabetes, bigger mothers, obesity, and bigger babies also. Now, occipito-posterior malposition is one of the most commonest these days, and there can be persistent occipito-posterior or transverse arrest. Again, management options, you should have patience with reassuring maternal and fetal status, and you should encourage mobility, encourage lunges, encourage getting her out of bed so that the rotation happens. Manual or instrumental rotation by experienced clinicians is always recommended. Epidural analgesia does not preclude rotation attempts. So reassess for CPD if arrest persists. Now, In shoulder dystocia, this is one of the major thing that everybody should understand, that the third scenario that we are discussing is shoulder dystocia. One thing that you can easily figure out shoulder dystocia is the head comes out and retracts back. That's the turtle sign. And you should be quick. There is no much time there. That's why anybody in labor, even I am rushing out to get the labor patient delivered, I have people behind me also coming immediately behind me. So that we are 2-3 people out there helping a mother to deliver her baby safely. So always shout for help. The risk factors can be macrosomia, diabetes, dystocia, prolonged second stage, operative vaginal delivery, and the sequence is very clear. The helper sequence is very clear. Call for help, evaluate episiotomy. Again, you can give a little bigger episiotomy, legs, macrobots as soon as possible. You need to shout macrobots, and everybody in the labor room should understand what macrobots is. Suprapubic pressure, then enter maneuvers you can do, and remove posterior arm first so that it loosens. Roll the patient, all 4 position is also a very good position. Again, it is very important for everybody in the labor room to understand there is shoulder dystocia and what has to be done on the spot. And the 4th scenario is cord prolapse. You have to recognize cord prolapse. That's very important. There is a rising incidence of cord prolapse these days because of polyhydramnios. You don't have to neglect polyhydramnios and unengaged heads, unengaged breech. It's a threat and cord prolapse can happen anytime. I definitely say nobody should do the ARM other than the person who is experienced to diagnose such problems. So it is very important that you should have this in mind if you have clinical scenarios that are very much inclined towards this. How it presents: sudden fetal bradycardia, variable decelerations, pulsating cord visible or palpable with your fingers. Again, risk factors, malpresentations are there, polyhydramnios, prematurity, multiparity, ARM with high presenting part. So somebody has to fix one hand fixing the baby position and then only do the ARM so that it is sustained. And slow release of amniotic fluid is very important, because if it is a gush, again with the gush anything can happen. So think cord in cord prolapse. It's consider, organize, relieve pressure and decision for birth as soon as possible. It's very important to be present and to have help at the moment. Abruptio placenta, you can have mild, moderate, severe, and it's premature separation of normally implanted placenta before birth. These scenarios are also increasing on a regular basis because of polyhydramnios, multiple pregnancies, and also hypertensive disorders in pregnancy. Now, in abruptio placenta, you should stabilize the patient first. That's very important. Call for help. Call the intensivist. Call additional help. Watch for coagulopathy. Individualized mode of delivery is important, and anticipate hemorrhage, because if there is an abruptio, you should understand that you can have a PPH at a later date, and you can also anticipate the covular uterus because of abruptio. The sequence of counseling the patient should be very important, and every counseling for all these scenarios should be audio video, so that you have told some scenarios and they can't escape saying that you have not clearly explained. Especially in abruptio placenta, if there is a huge covular, there is a chance of obstetric hysterectomies also. So you have to communicate very clearly. 6th scenario is eclampsia. Recognition and risk factors are to be told to the patient if the patient is having hypertension in pregnancy or preeclampsia. Headache, visual disturbances, epigastric pain, hyperreflexia, and severe hypertension has to be monitored. Who is at risk? All those risk factors have to be in your mind. And there's acute management of eclampsia, magnesium sulfate. If IV access is difficult, then pitchard regime you can use. Watch for toxicity, control severe BP, and deliver as soon as possible. So first is stabilize, then is deliver. 7 scenarios, postpartum hemorrhage. The 4 T's have to be, by-hearted: the tone, trauma, tissue, and thrombin. These are the guiding factors, and PPH management algorithm is very specific. In labor room, we make sure that all these algorithms are pasted and very clear so that you will know and any new person coming in also can understand. Always call for help, massage and uterotonics together, tranexamic acid and escalate. That's very important. The eighth scenario is VBAC. Who is a good candidate for VBAC? The good candidates have these criteria and the bad criteria have these criteria. Never attempt TOLAC or VBAC with a T-shape incision, prior uterine rupture, placenta previous, facility without an emergency section and protocols which support this kind of problems. And always the obstetrician and her capacity, her team capacity, the hospital capacity and the capacity of the labor room decides who is going to go forward for a VBAC. And the intrapartum vigilance should be close monitoring, any abnormal heart rate, any sudden abdominal pain or scar pain or vaginal bleeding or maternal tachycardia, fetal tachycardia, hypertension, loss of uterine tone has to be monitored. These are the symptoms of scar rupture. And ninth scenario is maternal shock, class 1, class 2, class 3 and class 4. The maternal shock resuscitation protocol has to be again very clear. It should be pasted onto the labor room walls where the ABC, access, IV fluids, blood reserving and issuing of blood, treat and cause in the parallel it should go on, call for help and monitor and escalate. The 10th scenario is uterine rupture. The risk factors and signs are very clear. The risk factors are prior cesarean, prior uterine surgery, whether it is VBAC, TOLAC, grand multiplicity, obstructed labor, uterine overdistension, prior rupture, and warning signs. There is abdominal heart rate, sudden severe abdominal pain, vaginal bleeding, loss of contractions, tone, and maternal tachycardia, shock and loss of station. This is an emergency condition. The intensivist has to be in loop and call for help. Additional obstetricians is mandatory. Make sure that you resuscitate. Emergency laparotomy has to be done in less than 10 minutes. So that's what we maintain. And repair or hysterectomy. In this scenario also there is a chance of hysterectomy. The counseling should be done prior to doing any step forward. So at a glance again, labor dystocia, the hallmark signs and first action, malpositions, shoulder dystocia, cord prolapse, abruptio placenta, eclampsia, PPH, VBAC, scar rupture, maternal shock and uterine rupture. So this is one slide that will give you an overall look into every scenario that you can have in terms of challenge. One, the most important thing I'm telling you, please practice in a team. I practice in a team. The entire team that I have one sync, one motto and one kind of training. And we make sure that anybody who is not in sync with this is not there in the team. Because obstetricians cannot have two, aspects of the same scenario. You should be in sync and everybody should work towards the well-being of the patient at all given points of time. So key takeaways are warning signs, overlap, call for help, know the mnemonics, helper, think cord, the 4 T's, muscle memory saves minutes and brief and drill regularly. So obstetricians should be vocal both towards the team and vocal while expressing the findings to the patient and the attenders. Never think that you will tell later, you will communicate later, you will train later, or we will have some day for training. No, absolutely not. And when you are doing delivery, you try to tell and express things on a regular basis so that people who around you are vigilant, people around you are, thinking in the same terms that what you are thinking. Because if you don't talk and you don't express, they will not even know the warning signs. If you are expressing, then definitely everybody will be in sync. Thank you.
Very, very well spoken, Dr. Shilpi. You have covered A to Z of obstetrics. I would just like to add one more. Uterine inversion is one more obstetric emergency that we have, not so very common. And the way to grow is learn, unlearn, relearn. And teamwork means more. As Shilpi has already very clearly said, teamwork is the thing, and it is no more individual practice. You're only going to have nightmare. and one bad case ages us by almost 10 years. So we don't want to age and then go for rehabs and other procedures. So it's good to do a team practice and live happily and also reduce the maternal mortality, morbidity, and all of us can be happy. Thank you.
Thank you so much, Dr. Shilpi ma'am and Dr. Bhagyalakshmi ma'am, for wonderfully summarizing the key concepts for guiding all of us on high-risk obstetric management. I think it was really enlightening. Thank you, Dr. Sahitya, as well. We now request Dr. Bhagya ma'am to kindly give away a memento to Dr. Shilpi ma'am for her session. And we also request Dr. Shilpi ma'am to likewise felicitate Dr. Bhagya ma'am for being our chairperson. So I thank you all for bearing with us for the delay. We are now splitting for lunch. We know we are skipping a couple of sessions pre-lunch, but we'll compensate for these sessions post-lunch. So lunch is being organized in 2 concurrent venues for all the participants. Our volunteers will guide you. There is one lunch hall on the left side, as I look at it, left side, or on your right, as some of them are entering. Since we have almost 140, 150 participants, we have another lunch hall here on the back side of this hall, behind the stage. So this is actually spacious, and you can actually split yourself so that all of you have adequate time for lunch. For all the faculty and speakers, there is another hall. You will walk towards the right side on the back of the hall. Again, our academic team and BD team will guide you. Now, as we finish the pre-lunch session, the time is 1:45. I request you all to kindly reassemble in the hall by 2:15 p.m. And please don't leave, because there are a lot of exciting sessions. There is a panel on correctable fetal anomalies by Dr. Manjula Anagani ma'am. There are wonderful talks on pediatric surgery. Dr. V.V.S. Chandrasekharam sir is here. There is a beautiful talk on moving towards single-digit NMR by our neonatal team. So please do stay back with us for the rest of the sessions. Thank you, and hoping to see you at 2:15. There are washrooms adjacent to the lunch halls, and please feel free to ask our team for any guidance. Thank you all for joining us post-lunch. We are resuming our session on the last segment that we could not cover pre-lunch, which is something which is very close to our hearts as neonatologists. So we are going to discuss, Dr. Ishita is going to discuss some strategies, some evidence-proven interventions that are going to guide us in our journey towards single-digit NMR, and very relevant for us in the Indian setup today, where we are still dealing with NMR of around 20, and the government envisages that it drops down to a single-digit number by 2030. Over to you, Dr. Ishita, and we invite Dr. Veeraraghavan, consultant neonatologist, Fernandez Hospital, to chair this session. Dr. Veeraraghavan is a neonatologist, I think, who needs no introduction to all of us. He's a great clinician, researcher. He has numerous publications to his credit. His areas of interest is doing systematic reviews on various areas within neonatology, ranging from respiratory support to nutrition to delivery room interventions. And he is one of the core members in the ILCOR group that frames recommendations that guide us on neonatal resuscitation. A huge pride for us as a country that delivers the maximum number of newborns, and he is representing our country's sentiments in the ILCOR recommendation. Thank you for being with us today, for chairing this session. Over to you, Dr. Ishita. Can we have the slides?
Good afternoon all. I'm Dr. Ishita Singh, consultant neonatologist, KIMS Cuddles, Kondapur. It's been our pleasure having such a varied attendance of delegates engaging with us in this enriching program from the morning. So thank you all for your patience. Hope the lunch was good and we are energized for the next even more interesting couple of sessions lined up. So the topic for me is single-digit NMR, but I think as viewers will agree with me, it is a massive topic, probably spanning what spans our whole careers as neonatologists. To compress it in 10 minutes time would be a mammoth task. So allow me to be a bit fast, but do follow along. So we'll be going through the definitions, understanding some numbers, and looking at the evidence-based sciences, the public health interventions, and the very key pertinent bottlenecks, and some solutions along with them. So neonatal mortality rate is defined as the number of death of newborns aged in 0 to 28 per 1,000 live births in a given year or a region. They can be further divided into early versus late. Along with NMR is a very important marker which comes along, but often sometimes poorly understood, which is a perinatal mortality rate. So PNMR actually comprises of deaths, including the stillbirths, up to the early neonatal deaths. So looking at the global statistics, the global average of NMR sits somewhere around 17.2. That leads to almost 2.3 million neonatal deaths a year. So looking at the contribution of neonatal mortality into the ultimate under 5 mortality is almost a staggering 50%, something which is, has been referred to as a neonatalization of the child mortality. So from now till 5 years, probably 1 in every 2 deaths is occurring in the neonatal period, hence making this the most critical period, and that is what we have been discussing from the morning, from the placenta's inception onwards, the various conditions which plague the pregnant uterus. Ultimate concerns are a healthy baby and a healthy mother. So now is the time to understand few factors by which we can improve. So looking at the evolution number of deaths by region globally, of course, the developed nations have always enjoyed a different level of resource replete setting. So the fall in NMR has been quite different for them. The journey has been very different for us being part of South Asia, but we have made stupendous progress. So currently India stands at the NMR of 18 over 1,000 live births, according to SRS 2024, and the lowest being seen in the state of Kerala, Tamil Nadu. Many other states have made great progresses and they have achieved almost single-digit NMR status already, leading the way like Delhi, Puducherry. Highest still seems to be around 26 in Madhya Pradesh, Chhattisgarh, and Telangana sits around 13, and as per NFHS, 16 points. The estimates vary as per some different statistics, but overall, we are still losing 18 newborns per 1,000 live births, and the goal is to achieve single digit. So coming back to PMR, it is a very unique marker in which it actually spans over the spectrum from fetal life to the first week of life. So having a stillbirth rate is also, having a single digit stillbirth rate is also a goal which we are striving towards. But the progress achieved in decreasing SBR is often slower than the progress achieved in NMR. For example, if in hospital A is having, let's say, 10 stillbirths and early neonatal deaths are just 5, their PMR would be 15. But similarly, another hospital having 4 stillbirths and more of early neonatal deaths, PMR is still 15. Do we compare both hospitals as the same? A higher stillbirth rate actually signifies possibly poorer antenatal surveillance. And that's what we have been talking over multiple sessions from morning, that more surveillance of the high-risk mothers. We want to decrease both stillbirth rate as well as decrease the early neonatal rate. So the various definitions are in use for PMR, and that leads to a bit of variability. But as per India, we are following the WHO definition. However, there are countries which are even using definitions as early as 20 weeks or more. So the PNMR for India around sits at 20, and with Odisha and Uttar Pradesh having one of the highest PNMRs, and Delhi having one of the lowest PNMRs. So coming to what's really killing our newborns on the global stage is no prizes for guessing. Prematurity still leads to be the highest, most common cause for neonatal mortality, followed closely by birth asphyxia. And similar things are experienced in Indian studies as well. Prematurity, birth asphyxia, and infection-related deaths lead to the most common mortalities. And this study, which I'll be referencing again in the presentation, is the 4 decades worth of data concluded by AIIMS New Delhi, again, which has covered the various causes of mortality and morbidity of our preterm and newborn infants, spanning across from 1960s till now. That also confirms the same, the critical 3 trio of prematurity, sepsis, and asphyxia. So some of the evidence-based interventions, I will just run through them because these have been discussed from morning itself, coming in from the antenatal interventions, the care programs, having a proper care package, having the mother registered at least a minimum of 8 times she is seeking antenatal care, along with nutritional and micronutrient supplementations. Then the correct and timely management of maternal infections, which will ultimately could decrease the causes or the incidence of FGR, low birth weight and premature deliveries. The treatment of comorbidity conditions was discussed in detail in our panel discussion. Then IUGR or FGR, as the latest terminology is, of course, seems to be a very, very prevalent problem, particularly in the South Asian continent and India, where malnutrition and underdiagnosis is rampant. Antenatal corticosteroids, of course, now all our obstetric colleagues and all our departments are on the same page with this. The correct, timely introduction of antenatal corticosteroids and the correct, timely repeat course given in the few indicated cases, of course, has led to decrease in neonatal mortality, incidence of RDS, and so many other comorbidities which plague our small vulnerable newborns. Correct timely antibiotics for the mother in the cases of PPROM, of course, also lead to decreased risk of early onset sepsis and chorioamnionitis, which translate to long-term improved outcomes. And intrapartum interventions, as has been so detailedly discussed by Dr. Shilpi Reddy ma'am, and the interventions intrapartum, which of course lead to decreased incidence of asphyxia. So medical attention at delivery, ultimately we want maximum deliveries to be conducted in a safe, controlled environment, and it's heartening to see that as per the latest SRS data, almost all the states are achieving more than 90% of delivery status being conducted in a healthcare institution, and the largest share is of course held by the government hospitals, 71%, and 23% in the private institutes. After delivery, having essential newborn care, which includes immediate cleaning, drying, and warming the infant, and initiating exclusive breastfeeding and cord care in the eligible newborns, followed by the home visits as practiced by the ASHA workers. So all of these interventions are very, very important, and they're non-negotiables. And these are the interventions which have been the heart of the public health programs which are at play. So the RMNCH plus A is the mother umbrella part of the National Health Mission, which overlooks all these programs, spanning from the facility-based newborn care to the Indian Newborn Action Plan and multiple programs which they have. So what are they all ultimately working towards? They are ultimately working towards achieving the single-digit NMR and single-digit SBR as part of the India Newborn Action Plan. However, the data is showing that there is some plateauing in the fall of the NMR. So to actually reach the single-digit NMR, we need to continue, consolidate, and again accelerate the fall of NMR and strengthen our combined efforts. So although many targets have been achieved, as our national coverage still lags a bit behind for the antenatal care visits. The skilled birth attendant target has almost been achieved, and all the districts which are having SNCUs increases day by day. So many progresses are doing well on track, but still the fall of the NMR currently is in phase 4 of the projected 5-phase model, which states that again to reach single-digit NMR we have to double our efforts. So what is preventing this from happening, and why we are facing these possible bottlenecks? So limited availability of resources and low quality of training, and lack of adequate quality improvement initiatives, and literacy divide. Like 50% of the districts of the country still need a much faster rate of the improvement, because India is a heterogeneous population, and the government political will and equity is very variable. So many states and many districts are able to push forth much faster than many other larger states with much sparse coverage. So what could be the way forward? Strengthening some clinical drivers, again focusing on prematurity, asphyxia, low birth weight, and preventing newborn infections. So prematurity, low birth weight, one of the most important interventions that should be reiterated again and again, and this is one of the things neonatologists will probably, a hill that we can die on, trying to reiterate IKMC, not even just KMC, yes, IKMC, by which I mean immediate KMC to even the small preterm vulnerable newborns who are even on respiratory support, who are low birth weight, who are very low birth weight, who are even very preterm or even extreme preterm. So this is the landmark study which is published in NEGM, and this of course centered under the aegis of WHO. So this study clear-cut shows that there is improvement of newborn outcomes in the form of decreased suspected sepsis episodes, decreased neonatal infections, decreased hypothermia, earlier discharge, and better weight gain and better breastfeeding in the mother. So this can be easily replicated by a concept of the MNICU, which many of us, if we are practicing also independently, we could try to replicate in our centers, just keeping the mother and the baby close. It's not just the private sector which could take this forward. Even many recent NHM initiatives and steps do promote that mother newborn care units be set up wherein mothers are housed with the babies. St. John's Medical College in Bangalore, AIMS in a small city like Gorakhpur, UP, KJMC, UP have been leading the way, but government institutions are making the way for a combined mother and child ICU. Coming to neonatal infections, having standardized interpartum practices, the timely referral and identification by the ASHA health workers and giving the pre-referral antibiotic dose can go a long way in decreasing the sepsis episodes and improving the outcomes. So this leads to us to now relook at our preterm population as a small and vulnerable newborn. So courtesy V. Raghavan sir, who enlightened with this discussion a few hours ago. So we should change our approach from the low birth weight baby just to a small vulnerable newborn. Having a just low birth weight approach, we miss the importance of gestation, maturity, and other comorbidities. So any baby who is preterm, AGA, any baby who is term, but SGA, and any baby who is both preterm and SGA should be considered under this umbrella term of the small vulnerable newborns, because that gets them the true attention that they deserve. That is specialized NICU care, with which is probably aligned on these 8 action pillars. So again, preconception care and family planning. Infection prevention treatment, I can't reiterate this enough. Of course, progesterone supplementation and prevention as managed by the OBGYNs, KMC, mother's nutrition, and intrapartum newborn care. Birth asphyxia is almost what should be called as a never event. That is the goal. Having zero preventer, having zero deaths because of asphyxia is the goal, and government has made a lot of strides, and they have NSSK program in which they are imparting free training across all levels of healthcare. So despite, if you would have noticed that we are having almost more than 95% deliveries in institutions, yet our NMR is plateauing. So what could be the reasons for this? Probably because the level of care we are providing still has a gap which could be covered. And as has been covered by Dr. Sahitya in a very detailed talk on the importance of QI, so Dakshata and Lakshya QI are at play to improve maternal outcomes. Along with that, many postnatal QI programs are also at play, including the Suman, Muskan, MAA and RBSK as an add-on for early detection and early referral of the defect or malformed fetuses or malformed newborns. Then the gender paradox cannot be ignored, because yes, we see a very drastic shift in the mortality gender patterns in the late and the post-neonatal phases, as the female infants tend to suffer lack of care and delay in care seeking, which again leads to an unfair disadvantage. Coming to the last pillar of the possible ways forward, strengthening our existing public health policy and system recommendations. So SNCUs are the pillar of our government health program into fighting neonatal mortality. So yes, we have a large SNCU network, but now the next step is to improve the quality of care. So a lot of gaps have been identified with the bed capacity, resources and the respiratory care available. So the challenges are floated across FBNC despite having almost 900 SNCUs in the country now. So again, quality initiative improvements could be the way forward. Empowering ASHA health workers who are facing issues at the ground level while working, that also is a perpetual concern, because they are the ground soldiers and they face a lot of resource limitations to get the medicine to babies. And I would like to just sum it up here with a very fascinating, all-encompassing study looking at the trends in the neonatal mortality and morbidity in India for the past 4 decades, helmed by AIMS. So they have described four crucial times where they have achieved a decrease in NMR across the spectrum of the study by very simple measures, by very simple interventions, of course starting with decongesting our NICUs, preventing unnecessary admissions post-LSCS, improving antenatal steroids coverage, and timely indicator surfactant therapy, and upgrading of NICU services and antenatal malformation surveillance programs, and of course deferred cord clamping, which is again an undeniable and undeniably beneficial intervention. So small, 1 minute of your time, but it decreases need for blood transfusion, decreases anemia, decreases shock, decreases NEC, decreases IVH in those small vulnerable newborns. There was a blip of an increased NMR around the COVID pandemic, but it has been reassuringly coming down. So yes, I'm talking all about prematurity asphyxia, but we cannot ignore the threat of sepsis. As more and more NICUs are coming up and more districts are also empowered with handling these small vulnerable newborns, but also our sepsis surveillance and our sepsis approach needs to update with correct antibiotic stewardship to prevent resistance of these very virulent bugs, which will again come back and hurt our babies only in the future. So to summarize, prematurity will remain a major challenge, but it's only through coordinated multidisciplinary approaches by which we can achieve single-digit NMR, and public institutions must be applauded for the major contribution they're doing in the country's progress. Evidence-based outcomes are the ones that always work, and that is what we want to reiterate through multiple academic discussions and multiple repetitions, that the correct time steroids, correctly timed magnesium sulfate, correctly timed in utero referrals, or correct time deliveries in the high-risk mothers, sepsis surveillance and antibiotic stewardship all forward to make the journey post-birth easy so they go home without catching any hospital-acquired infections. And quality improvement should be a culture, not just something we should do for once a year or for a publication. It should be something which we inculcate on day-to-day basis. Just asking ourselves 5 whys for every newborn who we lost will itself lead us to the answer, and which most of the times is quite preventable. Thank you so much.
think we are running short of time. So Dr. Ishita had covered most of the aspects related to NMR and how to bring it down, how to reach the SDG goal and all. If you see the overall picture, if you see from the country's perspective, we have brought the NMR to single digits in many states, right? That decades back. So the main thing that the government of India is now focusing is on something called progressive universalism. So you concentrate on states such as Madhya Pradesh, Bihar, Rajasthan, where the NMR is quite high. You implement, scale up these strategies, make sure the no-do gap is bridged. You know that these practices work, but on the ground it is not implemented. That's where Lakshya, Muskan and all those things come in implementation science. Scale up those things. These are not what I am suggesting to the government. There are other better people sitting in the government making policy decisions. That's what the government of India is concentrating on. Take up the models from few states, such as the Kerala model. The Kerala model is not implementable over a period of few years. It means bettering female literacy, women empowerment, and you have to go a bit into the communistic way of dealing with stuff. So that is not practical. In this present day world, it is difficult. Now you take the Tamil Nadu model. Tamil Nadu has a very strong B.O.N.D and IMPONG system. The obstetric and neonatology networks. That could be scaled up quite rapidly. I couldn't see the NMR of Goa. Goa spends the highest proportion of its budget, the state to spend the highest proportion of its budget on maternal and child health, right? Goa. So implement these models into the other states with the help of Lakshya and Muskan, make sure that they are practiced on ground, and we would definitely reach the single digit NMR. It is not something that we have not done before, because we are I think we are the most diverse country in the universe. And adding up all this and telling that our NMR is 18 is not justified. You have to take it state by state, and that's how our government is moving forwards. Thank you for your wonderful presentation. Any questions? I think all of you are bored. We are just going round and round.
Thank you, Dr. Ishita and Dr. Veera Raghavan, for that very enlightening session, covering a very important aspect as India evolves from one phase of its neonatal care to probably another phase where more and more preterm babies, babies with treatable surgical defects are now getting salvaged. I now request Dr. Vishwanath and Dr. Amit to kindly, felicitate our chairperson, Dr. Veera Raghavan. Thank you so much. And let me request Dr. Shilpi Reddy ma'am to please felicitate Dr. Ishita for her excellent talk on NMR reduction. And I'll request you ma'am to please stay back to chair the next session, a debate on delayed cord clamping versus cord banking. So we move on to another interesting session, and both our speakers have promised to keep their debates very brief, 5 minutes each. So I request Dr. Amit, consultant neonatologist, and Dr. Deepa Ingade, consultant obstetrician, to please join us for the debate. I think both of you can also be seated on the dais, and one by one you can go ahead with your presentations. I think we'll begin with Amit, followed by Dr. Deepa. delayed cord clamping versus cord banking. So this is again a very interesting debate that we often encounter in our clinical practice. So Shilpi ma'am can introduce the speakers while Amit, you can get ready with your, who's going to speak first? Dr. Deepa?
I will.
Okay, Dr. Amit will do the talk. I think you can come to the podium.
So, good afternoon to all. Today my talk is to either go for the DCC or to the cord banking. So, if you see the importance of DCC, delayed cord clamping, either in the term or preterm babies. So in the term babies, it is defined as more than 60 seconds by the new NRP guideline that leads to good transition and help in increase in the hemoglobin level with increased birth weight, decrease risk of transfusion, decrease the risk of iron deficiency even at 3 to 6 months. But there is no much significant difference either in the Apgar score or neonatal mortality. There is just some more chance of jaundice, but that can be treated with the phototherapy only. Doesn't need to be any exchange transfusion. Now coming to the preterm babies, if they go for the delayed cord clamping, then you see the risk of death is decreased by almost 27%. All grade IVH decreased by almost 17%, and also decreased by the risk of PVL. There is no any change in the maternal significant blood loss. So what the benefits as a whole, if you see that they have good physiological stability, either in the term or preterms, good outcome as a whole that we have discussed, and there is a less chance of transfusion mainly in the preterm babies. Now coming to the umbilical cord banking, so I'm not going detail in the umbilical cord banking. I was just telling the salient features of umbilical cord banking. So till now, these are the two datas where they have used the umbilical cord banking. So according to the IJP India data, till now, only 0.1% to 0.002% of the reserved blood has been used, whereas from the world data, only 8% was used. So what is the disadvantage? So it take increased time of engraftment. They have limited cell count and a small volume, so they may require 2 times of transfusion also. The autologous transplant have limited benefits due to some inherited defects in itself, the umbilical cord blood. And also there is an inconsistency in the storage, either in the public-private partnership bank. So there is a contraindication in the preterm birth, twin gestations, and serious maternal complication as in the maternal bleeding, cardiac arrest, and also in the cases of prenatal asphyxias. Whereas the factors that decreases the umbilical cord bank volume is maternal hypertension, smoking, and other maternal complications. So these are some myths. So what myth is there? So the private cord milk banking have some emotional marketing that this cord blood has enough to deal with all type of diseases, but it is not that fact. Second thing, the autologous cord transplantation is not feasible for maximum of the diseases because it contains the same genetic factors whatever the baby have. When to do that? So when the existing family members or sibling having some conditions that can be treated by this the autologous, then only it can be stored. So I told in the next slide also, the autologous cannot be used in maximum of the cases due to the genetic defect already it harbors. Only the allogenic transplant can be done in some of the hematological malignancies. These are the AAP and the ACOG guideline in that also told the same thing. If there's an emergency, no need to go for the umbilical cord banking. So this only should be done in the public banks. That is not too much evident in our India. And always we have to take care of the mother and newborn care. On WHO, the 1 to 3 minute delayed cord clamping should be must done. There is no any guideline for doing umbilical cord banking in the WHO guideline. Same for the ICMR guideline. So my take-home message is DCC improve the neonatal blood volume and good transition, and not should be done in the preterm babies. There is a dissemination of knowledge should be given to all the stakeholders, parents. Private banking is only recommended in the condition when the existing family members suffering from the condition that can be treated by the allogenic transplant. Neonatal care should not be compromised by doing early cord clamping and banking. Thank you. Next.
Next, we have Dr. Deepa. She's our consultant, and she's going to talk about the same topic. Thank you.
So my topic will basically be on cord banking, whether it is a missed opportunity for DCC or a necessary investment. So I'd like to start by saying that at birth we have a resource that is collected once, non-invasively, and then it disappears forever. The question is not whether we should choose between delayed cord clamping and cord banking. The question is whether our systems are sophisticated enough to achieve both wherever clinically feasible. Hence, all we can say is DCC, it provides immediate benefit to the newborn, but cord banking, it has potential future benefit for the child or the family. So what are we actually choosing? So delayed cord clamping, it has immediate benefit. It allows placental transfusion. There is increased neonatal blood volume, particularly important in preterms, and it gives a good standard of care. But cord blood banking, it has a potential future benefit. It is a cellular resource of hematopoietic stem cells or progenitor cells, and it has an established role in transplantation. And it is a very selective and strategic investment. Hence, DCC gives benefit today, but cord banking gives us an option for tomorrow. What DCC has already won is that ACOG recommends DCC for at least 30 to 60 seconds in vigorous term and preterm infants. And in preterm infants, it is associated with increased transitional circulation, higher RBC volume, and reduction in transfusion, NEC, and IVH. And the newest RCOG evidence shown in 2026 reinforces that immediate clamping should not be routine, and that waiting before clamping improves outcomes, particularly in premature babies. Hence, the argument here isn't against DCC, but it is against a false dichotomy between DCC and cord banking. How DCC changes the banking equation. ACOG says that DCC reduces the cord blood collection volume and total nucleated cell counts. In one public bank, if you do immediate clamping, 39% units met the initial screening criteria. And after a 60-second delay in clamping, only 70% met the initial screening criteria. Hence, we can say that DCC can reduce the probability of obtaining a bankable unit, but that does not mean that it should be abandoned. So the question we should ask, instead of DCC or cord banking, we should actually be asking, can we redesign cord blood collection around DCC? So the potential approaches can be collect after adequate placental transfusion, optimize collection techniques, select appropriate candidates, prioritize directed donation, improve the processing and cell recovery, develop higher yield expansion technologies, and create coordinated obstetric, neonatal, and blood bank protocols. So why cord blood still matters? Because it is playing an essential role in conditions like cancers, blood disorders, metabolic disorders, and immunodeficiencies that are stated here. FDA recognizes cord blood as a source of hematopoietic cell transplantation for selected blood-forming system disorders. And this is no longer a hypothetical stem cell technology. Cord blood transplantation is an established medicine. So why cord blood banking is becoming more usable? because like sir mentioned, there is a traditional limitation of cord blood. Cord blood contains fewer stem cells than an adult donor, so cell dose has always been a major limitation, especially in larger patients. But what has changed here is scientists can now multiply or expand these stem cells in laboratories before giving them to the patient. So one of the biggest problems with cord blood, like sir mentioned, has always been that there is simply enough, there's no enough stem cells in one unit. There's something that has come up known as OMI-surge, which represents an important step forward because we can now expand these cells in the laboratory before transplantation. Hence the argument that cord blood has very few cell units to be useful is no longer an absolute as it was before. A little bit about OMI-surge. It contains omiducible only. It is made from donated umbilical cord blood. The stem cells are expanded in the laboratory, and this gives larger number of cells from a relatively small cord collection. It can help the patient's bone marrow recover faster after transplantation. And in a randomized phase 3 study, OMI-surge has shown that the neutrophil recovery was noted in about 12 days, whereas in the standard cord blood, it is noted in 22 days, so that has evidently reduced. It was also associated with fewer serious infections in the first 100 days. So FDA expanded its indication in 2025 to include severe aplastic anemia patients in more than 6 years when a compatible donor is available. Hence, we can say that the technology is evolving, and when technology is evolving, the answer is not to discard the biological resource, it is to invest in better ways of using it. So unique advantages of cord blood include its rapid availability, no donor mobilization, no second procedure for donor, and lower GVHD risk compared to some other graft sources. And stored units can be rapidly searched through registries. Why this matters even more in India? Because India has an enormous genetic and HLA diversity. So a cord bank is not simply a collection of stem cells, it is an HLA diverse resource. So a 2025 analysis of Indian umbilical cord blood samples demonstrated a difference in HLA, allele and haplotype distribution. Hence, if we do not bank units that are representing India's genetic diversity, the patients who need transplantation may be the very patients least likely to find a sustainable unit. So this is particularly very compelling for India. The difference between public banking and private banking. Public banking is available to anyone who needs a match unit. It has a strong societal value. It is recommended by ACOG. It helps in the HLA diversity, and there is no guarantee of personal use. Private banking is reserved for family, and it has a significant cost. And it is basically recommended and individually or family recommended. ACOG states that routine private banking is not supported by available evidence, while private banking may be considered when a family member has a disease potentially treatable by cord blood transplantation. Hence, I'm not advocating commercial banking as a biological insurance. I'm just advocating investment in the scientifically regulated cord blood ecosystem. The future is bigger than transplantation. Cord blood and cord tissue derived cells are being investigated for neonatal brain injury, cerebral palsy, bronchopulmonary dysplasia and immune modulation. The current evidence, it remains largely early phase, and regenerative applications should not be presented as established clinical indications. Hence, cord-derived cells are a promising but evolving therapeutic platform. Again, I'm not asking you to bank cord blood because it will cure cerebral palsy tomorrow, but I'm asking whether we want to preserve a biological resource while the science is moving rapidly towards new applications. So what would make a modern cord blood banking model look like in the future? It involves antenatal counseling, risk and indication assessment, cord management plan, DCC whenever clinically appropriate, neonatal stabilization, optimized cord collection, quality control processing, cryopreservation with HLA typing, national international registry, and one delivery which will show that there are multiple opportunities like DCC, cord blood for clinical testing, public banking, directed donation, research and future cellular therapies. So when there is a obstetric neonatal dialogue happening, before delivery we should discuss, is DCC appropriate, is it directed donation indicated, is neonatal resuscitation anticipated, what samples are required, who collects this and when the collection should be performed. And at delivery we should look at the baby first and do DCC when appropriate. Resuscitation should be, it takes priority, and collection should never compromise maternal or neonatal care. So ACOG states that cord blood collection should not compromise obstetric or neonatal care or alter routine DCC except in rare directed donation situations. So my rebuttal to the opposition about cord blanking versus DCC would be, cord banking, they say that cord banking compromises DCC, but it will only compromise it if the system is poorly designed. Another statement is most privately banked units are never used. Yes, that is correct, which is why I support public banking or appropriated directed banking and not indiscriminate private banking. Another statement is DCC provides proven benefit today. Absolutely, we should protect it. But they also say that future regenerative uses are unproven. That is correct, but there are research opportunities which are not current indications. Cord blood transplantation is becoming obsolete because of haploidentical transplantation. To that, my answer would be, it is not necessarily so. Recent pediatric AML data shows that comparable outcomes between haploidentical and cord transplantation, meaning cord blood remains a relevant alternative donor source rather than simply obsolete technology. So the final take-home message would be, DCC is not the enemy of cord banking. Poorly designed cord banking is. We should protect DCC as standard newborn care, prioritize public and medically indicated directed banking, invest in better collection and processing, expand India's HLA diverse inventory, invest in cellular expansion and translation research, build obstetric neonatal blood bank protocols. And I would like to end by saying that the cord is not a choice between blood for today and cells for tomorrow. With the right system, it can be an investment for both. Thank you very much.
Thank you so much, Dr. Deepa and Dr. Amit, for diversely opposite takes on a very pertinent issue. So comments from Chairperson Ma'am, Shilpi Ma'am.
We are right now in a state where every patient is empowered with more knowledge than the doctors, especially when they are having limited number of kids, 1 or 2 kids. Everybody has an opinion of their own. Since we actually come forward with educated couples, they have a set opinion about the delayed cord clamping and also a set opinion about the umbilical cord blood stem cells. And what I feel is, counseling is our part. Decision making is their part. Whatever they want to choose, it's their conscious choice that they make. And their decision is going to be the future of what they have decided. And delayed cord clamping, when we try to counsel at times, some couples have come up objectifying, saying that it can cause jaundice. God knows where they got the information from. And we tell them, yes, pros, cons, everything will be there. You take a call. And 20 years back, who wondered that there would be something called a video calling and these kind of gadgets there. Technology is increasing day by day, spreading its wings day by day. In the same way, there is no hard and fast rule that it would be cord blood that we have to collect. You do delayed cord clamping, even cord tissue has stem cells, placenta has stem cells, amniotic membranes have stem cells. Stem cells can be got from any source. And we have, in fact, more stem cells in the placenta according to them. So we can alter methods and get stem cells for the future. Because whatever I see, that any stem cell, if given a right capacity and right research, can tomorrow form any organ of the body. You don't have an organ or an organ has damaged, they'll form from stem cells and implant. So we will reach a point where we'll have very less population in future, where they are going to do all these things and save humanity. So it's all about your thought process, it's all about what you have in your brain. And what you have in your brain will be obviously transferred to the patients. And it's their purview to accept things. Thank you.
From audiences?
Thank you so much, ma'am. I request you to please felicitate Dr. Deepa and Dr. Amit. moving on to the next topic. Ma'am, please request you to be on stage and enlighten us with your points for the next talk. That is peri-viability, glimmers of hope and survival in the current era for these very, very small or the small vulnerable newborns born at the border of viability, 22 to 24 weeks. And now as we push the borders of neonatal medicine, what is justified and how can we justify it? How can we still move forward with the resources and when to take a decision? Madam will be guiding us.
Can we request Dr. Chandrasekhar sir, senior pediatrician, to also join us as a chairperson? So, a very emotionally linked topic to us as neonatologists, peri-viable births. So when we talk of peri-viable births, we are referring to babies who are born right at the borders of viability, which itself is a very controversial definition depending upon the country, the kind of quality of neonatal care that it offers. But we are talking about births somewhere between 22 plus 0 to something like 25 weeks of gestational age based on the location in the globe. And in this session, we are going to discuss what is the burden of such births globally and why this is considered as a gray zone. And how are we going to scientifically take decisions and not purely based on emotion, because there is a lot of emotion involved in these decisions, both from the parents and from the medical team. On the one hand, we as neonatologists do believe that the quality of neonatal care has improved tremendously and we are able to make some of these babies survive. But are we paying a cost? Is the family paying a cost? Is this something that is also going to increase their financial and their intellectual burden in future? Is something that we have to constantly consider while taking decisions. And there is also the consideration that the limit or zone of viability is constantly evolving. And we'll also briefly look into the practice shifts or the kind of evidence-based interventions that have changed outcomes in this peri-viable zone. So let me begin with two case scenarios in front of you. The first case scenarios, and both these, believe me, are real life case scenarios. So the first one is this. This is a 38-year-old Gravida 5 mother. She is coming to you at 24 plus 1 weeks of gestational age. She has had previous 3 miscarriages and 1 intrauterine fetal death at 28 weeks of gestation. She does not have any living issues. She has been diagnosed with SLE and she is having autoimmune anemia, serum creatinine of 1.7 and a platelet count of 30,000. So this is actually a case whom ma'am delivered yesterday. And she has been on intensive rheumatological management, rituximab and Maxelf. She was admitted, given a blood transfusion for anemia, given 1 STP transfusion for thrombocytopenia, monitored closely for fetal heart rate. The team was preparing the family constantly for a possible delivery for potential fetal distress because of high-risk pregnancy and underlying lupus. The only option was a cesarean section. So you have this family, a mother who is 5th gravida, no living issues, and a family which says they are desperate to have both the mother and the baby safe and healthy. This is another case scenario which we also dealt with recently. This is a 26-year-old lady, Gravida 4, Para 2, 2 living issues, and 1 abortion, no maternal co-morbs, with spontaneous MCDA twinning, and she has gone into stage 2 twin-to-twin transfusion syndrome with poly-oligo sequence, identified at 23 weeks of gestational age. So this family is having 2 previous healthy issues. They come to you for antenatal counseling. One of these MCDA twins also has isolated severe ventriculomegaly with lateral ventricular dimensions of 17 and 18 mm. She is now coming to you with full-fledged preterm labor, cervical funneling with cervical length of just 4 mm. So decision-making process, although both these babies are 24 weeks of gestational age, you know that there are multiple considerations which are going to guide your decision-making process. On the one hand, you have a relatively elderly Gravida 5 mother with no living issues. She has lupus and she may not have the chance to have another healthy pregnancy. And on the other hand, you have a 26-year-old Gravida 4 mother, 2 living issues, MCDA twins, with 1 twin having a structural abnormality and coming to you with a preterm labor. So decision-making at limits of peri-viability are not simply based on gestational age. We all know that there are inaccuracies in gestational age assessment also, based on the assessment in ultrasound, how early the scan was done. And there are multiple other factors that also determine the baby's chances of intact survival, including the gender, presence or absence of multiple gestational age, whether the baby was appropriately grown for gestational age or small for gestational age, lack of exposure or exposure to prenatal, complete course of steroids and perinatal complications like chorioamnionitis, where the delivery was conducted, whether this was an in utero transfer to a tertiary or a quaternary care facility versus ex utero transfer. And this is always a shared decision process. This is always going to involve the clinician, the family, the obstetrician, and the neonatologist, and it cannot be taken in by a single individual. Most countries have their own protocols. Less than 23 weeks or below 500 gram babies usually get comfort care. Babies between 24 plus 0 weeks and 24 plus 6 weeks are considered to be in the gray zone, where a shared parental decision making is considered. And when they are more than 25 weeks or more than equal to 500 grams, at least in our country, full-blown resuscitation is usually advised as a dictum. So now, when we look at the incidence, we all know that India has the highest number of preterm births. So globally, we are looking at a number of around 13.4 million total preterm births, in which almost 20% premature births happen only in India, which is 1 in 5, translating into a number of around 3.2 million. Now, although the number of this extreme preterm cohort that we are discussing today, that is the periviable zone between 22 to around 26 weeks, or babies below 28 weeks, overall if you take as a cohort, it represents not more than 4%. It still translates into something like 1.2 lakh infants every year for a large country like ours, and these are the numbers that we are discussing, are the numbers that are at stake, who will benefit from a very closed and shared decision-making process. So this is the zone that we are talking about, from 20 plus 0 to around 28 weeks. And as we discussed, various countries have their own kind of global and national standards for resuscitation or zones for resuscitation versus comfort care, depending upon their capability of providing care and depending upon average survival rates at various gestational ages in their countries. And most countries would consider a gestational age more than equal to 24 weeks as babies suitable to receive full-fledged resuscitation. Now, when we look at global survival data, overall, the survival stands at around 61%, but this may range from something like 32% in low-income countries to up to 69% in high-income countries, and hence it's a very skewed data. So it is actually difficult to generalize one particular proportion for survival when you look at this across countries, because it strongly is determined by the quality of care. So what may be the level of viability in a low-resource environment, let's say at around 28 or 29 weeks, which is what you say beyond this gestational age, most babies survive in a certain setup, may not be the same in a high-resource setting, wherein this threshold may equate to something like 23 to 24 weeks. This represents a resource shift. So we understand that it is not merely the gestational age as a number that determines the chances of survival or the cutoff of viability, but it depends upon infrastructural conditions, whether or not the unit has advanced neonatal intensive care, whether there is utilization of antenatal corticosteroids, early surfactant therapy, whether the unit uses gentle respiratory support, whether they have continuous appropriate neuromonitoring strategies, and whether they have mandatory active protocols about resuscitation for babies born at periviable gestational age. So these are cutoffs across various countries, and you can also see here that the approach to these babies ranges from a conservative approach, shielding parents from premature burden, to a very interventionist or aggressive approach in countries like Japan, where babies right from 22 weeks are provided active support and where the outcomes are also reasonably good starting from 22 weeks. So when we look at survival rates gestation-wise, you can see that there is a stark increase in survival to discharge. The survival to discharge is represented by the purple color bar. You can see that as the gestational age progresses from 22 to 23, 24 and 25 weeks, more and more proportion of babies are surviving up to discharge. So this is also represented here. And the other important question is, what is their intact survival? So when we say intact survival, we are talking about survival without disability. So for a family, for taking an informed decision, it is not just survival that matters, but also intact survival, whether the baby is going to have neurosensory problems, whether the baby can have gross motor disabilities and other significant disabilities requiring intervention. So when you look at the overall proportion of babies that surveyed with no or mild NDA, it is around 50%, which is overall seemingly a reassuring figure. But when you look at severe neurodevelopment disability, overall it's around 20%. So when we are dealing with this periviable group, we must also anticipate that up to 1 out of 5 survivors can develop severe disability, but almost 1/2 is going to survey with mild or no disability. This is data from various cohort studies. And we have various calculators to help us to understand this risk assessment from the time the baby is born, and then we have various other variables incorporated time to time, starting from the gestational age, the birth weight, whether the baby was exposed to a complete course of antenatal steroids, whether it was inborn versus outborn, etc., which determine this particular risk assessment. So we have already discussed this gray zone, and we'll quickly discuss the clinical challenges. So the survival in this precarious zone actually depends upon a combination of antenatal care. We have discussed antenatal steroids, Maxilf, intrapartum care, and of course postnatal care. So we are running out of time. I'll just touch upon some important domains. Domain 1 is of course hypothermia or thermal bundle. We know that 1 degree centigrade fall in the core temperature of a preterm baby can increase the baby's risk of dying or developing morbidities by 28%. So this requires a whole bundle of interventions, starting from a warm labor room, polythene wrap for receiving the baby, transporting the baby in a transport incubator, receiving the baby in a pre-warm linen. So this is a brief video of a preemie who was delivered in our own center. This baby was transported from the OT to the NICU, covered in a polythene wrap. And this is used right before the baby is even dried to prevent the insensible water losses. So you can see the baby is transported right onto the NICU bed with the polythene wrap intact, and the admission temperature is checked. So this completes the thermal bundle, which is the first step to give a warm welcome to the baby, literally a warm welcome. The second domain being gentle respiratory support. So we are talking about the era of delivery room CPAP, early CPAP. So for doing this, we need blenders in the labor room, we need air points, we need CPAP machines, and very, very importantly, we need to be aware of the oxygen saturations that we are giving to the baby by monitoring the preductal pulse oximetry. Not to forget delayed cord clamping. We have already had a wonderful debate on it. Preterm infants benefits much more from deferred cord clamping when compared to term infants. Now coming to the next domain, which is the NICU care, where babies need gentle respiratory support. We talk about surfactant. Surfactant has been one of the golden silver bullets, we should say, in neonatology, which has significantly improved survival. So earlier we used to do Ensure, where we were intubating and giving surfactant. But these days we are resorting to more gentler modalities of delivering surfactant, and this baby is getting surfactant with a less invasive surfactant administration technique with a LISA catheter, which is a flexible catheter. People use feeding tube also as a via media for giving this surfactant, and this is given even while the baby is on CPAP. On your left, you can see a baby receiving surfactant through the Ensure technique. Domain 4 is providing early aggressive enteral and parenteral nutrition, and to do this, we of course need to have a standardized feeding regimen, and we need to have a dedicated unit for preparing total parenteral nutrition in a sterile fashion, and this is the human milk bank from KIMS unit, and of course following asepsis protocols, preventing infections, appropriate dressings for central lines, and very, very importantly, developmentally supportive care, where we facilitate the baby's neurodevelopment as well as it would have happened in utero, safeguarding sleep, providing kangaroo mother care, preventing infections, and preventing painful stimuli being some of the components. So this is an example of a baby being gently lifted, swaddled and being lifted. This is our early stimulation therapist, Juhita, assisting a mother and teaching her how to hold the baby with the least possible stimulation. So all this is a continuous shift in our paradigm of viability, even in a country like India, where there is tremendous diversity of care that is being provided across centers. So on the one hand, we have centers where there is limited access to quality care, but with more and more infrastructural expansion, we are now having more and more well-established level 3, level 3B centers, early availability of surfactant, better protocols, standardized feeding regimens, more and more human milk banks opening across, wherein we are able to establish enteral feeding quickly, prevent infections, provide advanced neuromonitoring for our extreme preemies, and all this is pushing the limits of survival possible from as early as 23 to 24 weeks in multiple centers. This is a publication of data from our center where we reported the short-term outcomes of babies born between 23 plus 0 to 27 plus 6 weeks of gestational age, and we reported a mortality of 33%, but this slightly maybe underestimates the mortality because we had 2-3 babies who had left Dama and we are not really sure whether they survived. But when we look at the overall survival rates, it's probably comparable with other institutes from the country, including from the PGI, Chandigarh and AIMS, which report a survival rate of around 50% in this period of periviable births. So this was one 550 grammer born to a deaf-mute couple who went home, and this baby actually taught all our nurses to actually learn the sign language as well. So some other babies discharged from our center, 26-week, 660 grammer. This was another baby who came in utero, 25-week twins whom we discharged around 6 months ago. And this on the right, you see another 25-weeker, 690 grammer going home. And our journey doesn't stop with sending these babies home. It doesn't stop with survival, but it really means intact survival, because that is what gives families and medical teams real meaning and emotional weight in terms of the quality of work that we do. And I would like to end my presentation with this baby whom we delivered yesterday, who are 24 plus 4 weeks, 350 grammer boy. Let's see how he does. But he's all set to begin his life with a strong start. So this is our core neonatology team, without whose support we wouldn't be, all this work wouldn't be possible. So I would like to conclude with the message that the limits of viability are not just defined by the number, by the gestational age, but depending on the interaction of the maturity of the baby's status at birth, whether this baby was an in utero transfer or an outborn baby who was transferred postnatally, the quality of antenatal care, including steroids, the early neonatal care, neonatal expertise, and the wishes of the family. The last point being one of the most important aspects, outcomes for extremely preterm infants have improved substantially in the last few years, but the survival without significant morbidity still remains a central core challenge that we all face as neonatologists, as clinicians, as obstetricians. Every week of life gained in utero matters, but every decision after birth matters as well, and this requires a close balance between medical expertise and the emotional considerations of the family, with the core objective being providing the best possible care to provide intact survival of as many babies as possible. Thank you for this opportunity.
Thank you so much, ma'am. Chairperson comments, sir. Ma'am.
So every baby has the right to survive, and wherever possible, we should have positive counseling. And it's the baby's fight that the baby will choose what will happen to it. And then with so much of advances in NICU care, obstetric care, timing of delivery is so appropriately done these days with the help of fetal medicine team. The trained obstetricians under their guidance will be able to deliver the baby at the right time with the right phase and momentum, so that the neonatologist also will be able to take care of the baby, which has been handled very effectively during the pregnancy. And preterm incidence is going to rise, there is no doubt about it. The more we are trying to give chances for infertile couples to have pregnancy, there will be an incidence of preterm deliveries, and we have a lot of challenges these days with autoimmune conditions coming in, with periviable babies, and critical decisions on our heads out there, because we have currently 2 pregnant women in the hospital with 22 to 23 weeks with absent and diastolic flow, 350 to 400 grams babies. It's so difficult to, cross every single day in such conditions. But yes, we stand there with the help of our fetal medicine colleagues and our neonatologists to take care of such children. And we can give that hope to every couple who is wanting to have a biological child. Someday it will be much more comfortable and much more better scenarios. Thank you.
wonderfully delivered a talk. Really appreciate your talk. Now the neonatologists are extending their horizons. Earlier, when we were doing our residency, it is 26 weeks like that. Now you people have chosen to work on the babies from 22 weeks onwards. That's a pretty good thing you people are doing. And it all depends on, Aparna has strongly stressed on one fact, hypothermia. Hypothermia is the key. If you can manage the hypothermia, the survival rate obviously goes up. Though it looks very simple thing, hypothermia is the key for the management, and the lungs, you take care of the lungs and the brain. What are the outcomes of this periviable period like 22, 23 weeks? You have been working on that. Right now you have the baby. What is the long-term outcome of, neurological outcome of these kind of babies?
Sir, unfortunately, I think in this group, there is still very limited data from India. But from our own experience, I can say starting from 25 weeks onwards, we could say that 60 to 70% of babies that are surviving and going home have normal or very mild disability, which is generally manageable with the mild therapy or mild forms of early stimulation. The more commoner forms of disability, even in the remaining 30%, remain restricted to cognitive problems or behavioral conditions, including ADHD. And fortunately, not more than 5 to 10% of babies are developing the classical severe forms of spastic cerebral palsy or severe motor dysfunction that we are most worried about. But I would say that in 2 out of 3 babies that go home, around 25 to 26 weeks, we are able to give actually near normal neurological outcome. In fact, 26 weeks and upwards, 90% of the babies have normal neurological outcomes when compared to their term peers.
You people are doing a pretty good job. You know, hopefully that baby will also survive what you have shown, 350 grams baby which was intubated. And you have all the setup, right? That is making the difference. Bhaskara Gara has provided all the setup. That is making the difference. We are at par with the best centers in the world.
Absolutely.
What about the cardiac surgeries, neonatal cardiac surgeries, be a cardiac or whatever? The best people are here. One of the best neonatal NICUs we can get in Hyderabad itself. Congratulations for doing pretty good job. And the mother's own milk is also plays a very important. The earlier you start the baby on mother's own milk, okay, we have to give TPN for some time. Earlier shift to the mom's milk is the key. And always in utero transfer is the best. The more you delay, by delaying every day, it will definitely improves the survival.
Absolutely.
As far as possible. Sometimes it may not be possible. You will be the better judge to talk about it. So these kind of, what are the ethical issues we come across when we are working on 22-weeker?
The biggest challenge in a very versatile country like India is the understanding of the families. Financial constraints become a very important deciding factor. And when it comes to the gestational age, like perhaps at 22 or 23 weeks, when survival with disability, we are looking at a proportion of around 40–50%, then that is also something that we need to sit and talk with every individual family, whether they are capable of taking care of such babies. So what we do in our center is 24+0 to 24+6 weeks, where it's a gray zone. We discuss with families. We take a shared informed decision based on what has been told to them in terms of survival statistics and what is the decision that comes from them. 25+0 onwards and a baby weighing more than 400 grams, we are providing active resuscitation. If there is a family that does not wish that we resuscitate or that does not wish that we give full-fledged support to the baby, we discuss options where cost may not be a factor. But if it is a baby less than 24 weeks, upfront we are not pushing them for active resuscitation. But if it is a 22 or a 23 weeker, the family is aware of the challenges, the cost, and they are willfully ready for full-fledged care for the baby. We do not deprive them of the care as well.
And the most important thing is the ball is always in the obstetrician's court. The obstetricians should not have a thought block. Most of the time, the obstetricians defer resuscitating babies and taking care of those babies all by themselves. But I always tell that obstetricians should send for counseling of such babies to the neonatologist who is competent enough to show the numbers. It's all about numbers. It's all about balancing and providing the right information transparently. Then the decision making is non-biased. So a non-biased decision making should be the core of treatment plan of such peri-viable pregnancies.
Thank you so much, chairpersons. May I request Shilpi Reddy ma'am to give the memento to Dr. Chandrasekhar sir.
We welcome our Chairman and Managing Director, Dr. Bhaskar Rao, sir, the legend behind the KIMS family, the KIMS group, and also the person who has given actionable translation to all our dreams, all our objectives as clinicians to run a high-quality center. Thank you, sir. Welcome you onto the dais. We request you to inaugurate our program with a formal lamp lighting, and please bless us with your message. This is the inauguration of our fetal clinic. Thank you for coming, sir. इनॉग्रेट करने के बाद सर का स्पीच ना Yeah. We also welcome onto the dais Sir Dr. Ramesh Dampuri sir, President of the IAP Twin Cities branch. Please join us on the dais. Dr. Shilpi Reddy ma'am, Clinical Director Obstetrics and Gynec. We request Dr. Manjula Anagani ma'am, Clinical Director Obstetrics, KIMS Arit Hospital, Gachibowli. Please join us on stage. Dr. Anil Dharmopuram sir, Senior Cardiothoracic Surgeon. Please join us sir on the stage. We request all the consultants from KIMS Cuddles family to please join us for the inauguration. Dr. Vishwanath, Ishita, Amit, all our fetal medicine consultants. Dr. Yoga Nagender sir, Dr. Manisha, Dr. Sudeep,
I'll call Dr. VVS sir on the stage. Sir, please.
today also marks the occasion of the inauguration of KIMS Cuddles Antenatal Fetal Counselling Clinic. So Cuddles Neonatal Excellence for Fetal and Neonatal Therapy, or Cuddles Nest as we have named it, is an initiative where we envisage that mothers with antenatally diagnosed anomalies or other risk factors in scans such as abnormal Dopplers qualifying for a high-risk pregnancy would be jointly seen by a team of doctors including an obstetrician, a neonatologist, a fetal medicine expert, and a relevant specialist like a pediatric surgeon or urologist for a genitourinary anomaly, a cardiologist, cardiac surgeon if it's a cardiac anomaly, or a neurosurgeon if it's a antenatally diagnosed neurosurgical anomaly, etc., in order to give the best possible outcome prognostication for the family and help them take an informed decision. So this is an initiative that we are launching today, sir. So we would request you all to please join us for the inauguration on this side.
Good evening, all of you. It's a great pleasure for me to hear, and a pride also. B.O.N.D and Nest and KIMS. And many of you, all of us, the challenge in front of us is we need to see that infant mortality, maternal mortality needs to make it zero. Today, everybody thinks Hyderabad is the medical hub of Asia, not in India. But when we are keeping that word, we need to see that in every field, we need to make it center of excellence. The things that center of excellence will come when all the like-minded people who understand the value of each and every item and how, at what stage we need to be able to communicate better, and then we will be able to see that we will be able to yield a good end result. The entire process, what we do is, when myself and Dr. Chandrasekhar, in 1990, we have a dream of making this excellent in pediatrics and neonatal care. We worked together in Nellore. That was my first hospital. So Chandrasekhar came and he was so enthusiastic, young and energetic. But at that time, we don't have all this technology available and everything. Then he was looking for all these things and ultimately come and joined. My entire thing is, wherever, if the consultant doesn't come, I will go there, so that I acquire that hospital, so that they will be there with us. That's how we have been moving around. So we tried our level best to get the entire thing, why we are doing all those things. If all the like-minded, similar thinking of building healthcare in a better way, then we will get a good name and fame for the institute and the consultants, and as well as to the city and the nation. That is the entire exercise we are planning to do, and that responsibility lies on all of us. With all these exercises, what I am trying to tell is, I keep on telling the only one, if we keep it everything, the word I for illness, we for wellness. If we want to grow, I only should grow, that may not able to achieve this type of excellency, whether it may be an obstetrician, whether it may be the parents and the patients and the neonatologist and the pediatricians, every one of us, even including the administration, the way we can able to counsel them, talk to them, get together all of us and convey to that, then the patient also get lot of confidence. At that confidence, we can able to zero down the infant mortality and maternal mortality. Even all of you know, Kerala is the top in the infant mortality, and when Kerala can able to do, the only thing why Kerala can able to do, when we see that most of the people are educated people. They understand the value of what the doctor says, the patient follows, the society follows, the in-laws follows, every one of them able to understand. That much of awareness we should be able to create, and not only the awareness, we need to be able to give that much of knowledge and each and every one. Even the hospitals like high-end hospitals in Telangana, we could be able to zero down, but ultimately if we want to achieve, we need to be able to spread this message according to amongst all the obstetricians, pediatricians, not only them, general practitioners, even the people are ASHA workers and all, at what time they should be able to send the patients, right place, right time, then we can able to zero down. All these things will come when we keep on communicating to each and every one, not only our well-learned people in the city, we need to be able to distribute to that even into the villages. The day when we are able to communicate this message to all of them, we can able to achieve what we want of making infant mortality and maternal mortality zero. Once again, thank you very much for all of you come here and deliberate and discuss and get the innovative ideas out of it, how to move forward. I congratulate for the Aparna and the entire pediatric and neonatal and obstetrics teams who conducted all these things. Thank you very much.
Thank you so much, sir, for your encouragement and your presence. We are honored to have you amongst us. So now, as at the right auspicious time, we have inaugurated the clinic and we have seen the specialist's name. Let's have the whole team on board for the panel to exactly talk about the kind of conditions which we want to be dealing and giving the best outcomes possible. So let's have the fetal medicine specialist panel. Chairperson, Dr. Manjula Madam, would you please join us as a chair moderator? I invite Dr. Anil sir, our Chief Pediatric Cardiac Surgeon, sir, please join us on the stage. I invite Dr. Sudeep Verma sir, our powerful pediatric cardiologist who has led us and guided us across so many challenging cases. Thank you for joining us, sir. I invite Dr. Manisha Madam, our pediatric surgeon. I invite Dr. Kirti Somu ma'am, our fetal medicine specialist. I invite Dr. Vishwanath to be on board as a neonatologist perspective. I invite Dr. Yoga Nagendra sir and Dr. VVS Chandrasekharam sir as co-chairpersons for this panel. And the one person without whom nothing is possible, the obstetrician who links us throughout the journey, Dr. Ankita Chauhan as well. Please. It's a full stage, but that's what it takes to achieve good outcomes in these vulnerable newborns.
Thank you, Ishita, for giving us the bondage and the nest which we are trying to do. We wanted a smaller nest. We are making it into a bigger nest now. No problem. We'll add 2 more chairs. Chandrasekharam, come. Yoganaginder. Come. We have fantastic cases. You know, I had a question. Why I'm giving so many cases to the pediatric, regular pediatric surgeon and not to the CT surgeon? Dr. Anil was asking. I said, we have more panelists in the form of pediatric surgeons. So now we know the answer about what we are going to do. Where is Yoganaginder? I'm not seeing him. Call him. So I think we had a fantastic panel here. Panelists are good, then we better be good in our way we do. So this is my panel, which is there. I need to add 2 more names there. And anyway, so treatable, the thing, Dr. Aparna wanted me, can you take this away? Aparna wanted me to talk as about what are the treatable things which we can treat. So I basically divided them into 4 things. One, where we can do a fetal surgery. This has been my dream. So maybe in the future in KIMS, we'll be doing a fetotherapy, not just for the things like TTS. We were planning to do something which we can do a psychoamniotic connections, and even the spina bifida fetotherapy is what me and Chandrasekharam were discussing about it. So maybe future we will be do. Where second thing would be fetal therapy which modifies the risk. Second is definitely where we look at the neonatologists and who are going to come up with the neonatic surgeons. Fourth, which are not correctable. So I am going to take you all around in 5 sittings. One, the window. The patient comes, the 24-week scan is done, then comes the reality that there is something wrong. From there, what are we going to do? So this is the slide, one slide where I want all of you to tell, I want my panelists to be crisp, short answers. How do you take it from here? Once the first would be definitely you are the first one, Ankita, because the patient is with you. Suddenly you have come with whatever diagnosis. It can be viable, it might not be viable. So how do you take it from there?
So first of all, we have to understand and diagnose what is the problem with the fetus, and we have to make sure that we are involving the neonatologist and the concerned department, which can include a pediatric surgeon or a neonatologist, urologist, depending upon the concerned problem.
Okay.
Lesion.
Right. So anybody else want to add something from the diagnosis to the, Dr. Yogananda, please join the panel on the thing. We want an impromptu answers and short and crisp. I think you can get the chair and sit here. Here. Get the chair. Self-service is what we are looking at in KIMS. Yeah, come. So, yes. So the question is, once the diagnosis of a child at 24, 23 weeks has happened in the diagnosis, and what is the planning and implementations you look at as a path forward? So you will be saying, kuch nahi hota, we are there to take care. So continue. Is that the way you're going to look at? Any anomalies. It can be anything.
Actually, just now we were discussing, actually, for any counseling, this fetal diagnosis is very important. The moment the fetal diagnosis is done, actually so much of mental trauma will be there for the parents. And that is when actually, as pediatric surgeon, actually we'll be taking the parents into confidence. Actually, the mother is the first one and the second one is the father.
Short responses.
Yes. So it makes a huge difference in the planning and preparation of the baby. So it is very, very, very important actually that we all should be involved as a team. Just now we were discussing, or else actually everyone will be telling different stories.
My next question will be to Kirti. What is the importance of imaging? You think one diagnosis, patient is going to ask for a second opinion, second thing. So how do you deal with it, and what is the importance of the serial imaging, and what do you look at it?
Yeah, so first we have to diagnose whether it is a correctable anomaly or a non-correctable anomaly, and also we have to look forward whether there is any genetic association, provide an invasive testing for them, and based on the invasive testing whether any genetics are involved or not, by that the prognosis changes and the counseling also changes according to that.
So Kirti, what you say is depending on the lesion, she will decide whether it is the genomics has to be done or not. So just because the patient has an anomaly, we don't have to suggest to them genomics. So where, Dr. Vishwanath, do you think the genomics play a role? When do you say, after you are called upon and you said this is the anomaly which is there, it can be syndromic, it might not be syndromic. So where do you think, Dr. Vishwanath, you suggest that amniocentesis and syndromic diagnosis is important?
For major congenital malformations, definitely genomics helps, and we should counsel the parents to go ahead with invasive testings like amniocentesis and get a sampling, and on that we can perform the genomics. It will help us to prognosticate and further continuation of the pregnancy or not. That decision has to be very clearly led to them. Yeah.
So organ diagnosis is already made, but with genomics we will actually know the genetic abnormalities so that we can prognosticate for that particular pregnancy and the next pregnancy also. So in the team, do you think every time everybody should be present to discuss with the patient, or do you want to have a behind the room, behind the wall, behind the curtain discussion with all of you, and then one person talking to the team, to the patient?
As an obstetrician, I would say I would like to lead the team and make a combined discussion with all of my team members and present just one statement to the patient and the attenders, so they will have their informed decision making.
Yeah. So I think to put it like whatever it is in today's times, first discussion, because TIFA scan they would be doing at 2022. So the first discussion between the whole team should be at the day of the diagnosis or within 2 to 3 days. Yes? Agreed? And whatever decision to continue or not to should be over between 2 weeks. Yes? Because 24 is the cutoff according legally that we have to do termination if it is not. Because in today's time, people want a perfect child, designer babies, designer that. They are not ready to take anything. So it is their choice. So I think 24 beyond we cannot do termination. So that's a very important point. And targeted imaging of every MRI if necessary and serial measurements, reporting is important. And if we are going for genomic, it is a microarray and WAS. That is what we are looking at. But turnaround time. FISH is very important because within 24 hours we'll get. If we are waiting for 3 weeks and the 24 weeks is over, that's it, gone. So please remember about all that. And who are at the table? Maternal fetal medicine doctor, fetal therapist, neonatology, pediatric surgery, cardiology, and the coordinator. And the 4 points which I think all of you should agree upon is the counseling. 1 point, like Dr. Ankita said, she wants to be the lead. It is about what is the diagnosis as of that day, what is offered, discussing with all of you, what it costs, and what is decided. And the practical rooms should be written. And second meeting around 30 weeks because viability has crossed. Now this is the most important segment where I want all of you to be more active, and I'm waiting for answers from all of you because the clinical scenarios, which are real life scenarios, which are operated some of the cases by the team is here. So we had a 28-year-old primey. Routine scan showed congenital diaphragmatic hernia, and there's a mediastinal shift, and everything is normal. So this is something the girl was very, very skeptical about, and they were like, reading everywhere, and the counseling was done, and the option of pathway of termination was also given. So what do you think you would suggest at 24? She's 24. She's still not crossed the thing.
So if at 24 weeks gestation, we can offer both termination as well as continuation. It depends on them what they choose. If they want a termination, it has to be started on that particular day. Our day crossed after 24 weeks, we will not be able to do anything for them in part as termination.
Yeah. As a neonatologist, what would you say? Because most of the patients are worried about pulmonary aplasia, hypoplasia. So what
Since it is a left-sided lesion and the contents are just being intestine and you know the stomach,
is there.
Even then, unless the liver is protruding into the chest, the risk of pulmonary hypoplasia is very low, and we have a clear prognostic markers like observed by expected ratios. Based on that, we have percentage, survival and mortality rates. And
so
I feel this is like mild CDH, so this pregnancy can be continued and ideally should be delivered near term. And the best possible option would be to do in utero, where the level 3 care and the neonatologist and the pediatric surgeons who can immediately, stabilize and intervene.
Okay. So any other thing about this particular case in this doubts? So in utero, everybody agrees. And definitely needs a surgery after that. That is going to be explained, right?
Yes.
Cost is going to be explained. So at this point, would you send the patient apart from the neonatologist to go and talk to the neonatal surgeon also?
Yes, pediatric surgeon, they have to meet and they have to counsel the prognosis, get counseled regarding the cost, everything.
So neonatologist said that he's very confident that everything is going to be good. So is that going to be the take with the surgery, or you would be little answering 50-50 and all that?
As he suggested, actually there are many prognostic factors, but irrespective of the factors, actually a diaphragmatic hernia is a correctable malformation.
Yes.
We should differentiate whether it is correctable or non-correctable. Whenever it is correctable malformation, that baby should be given a chance. That's what is comes under fetal rights.
This was the postnatal X-ray.
Yeah, that's what. Even if it is irrespective of this, actually this picture looks very scary.
Yeah.
Even then, there is a fair chance of this baby surviving.
Yeah.
So in the best of the best centers,
So you would be giving a positive approach.
we should give a positive approach,
Anybody
even
else
if
telling
whatever might be
anything else?
I would definitely offer an invasive testing also because I want to reload the genetics. So
because she's 24,
24 weeks, even
you
though
will
it is
continue with the routine
genetic
scans,
testing.
seeing if the other organs are getting affected.
Yeah.
So the serial thing is done and everything. So this patient continued with the thing. She discussed. She wanted to continue, and she continued. Serial scans were normal. Tertiary, we delivered her at care, and elective LSCS at 38 weeks. And surgeon operated, surgical repair, and the child is 4 and is doing well. So I think we took the right decision and we did it correctly. In utero fetal therapy is what we are looking at, but I think this is not done in India, so we don't look at. Coming to the next case, we had this case, this first patient I had delivered and absolutely normal, second patient, everything fine. Fetal echo normality for normal, at 30 weeks growth scan, duodenal atresia. Now very well-to-do family, very rich, very well learned, they're very good. But the question asked to me was, so many scans were done before, how did they miss it? So Kirti, how do you answer that question?
So there are something called as late trimester anomaly. So duodenal atresia is one of the anomaly which manifests usually after around 28 to 30 weeks. So that obviously we can't see the first trimester or the second trimester. As the baby grows, then when the gut develops, then only we can see. So that we can't diagnose in the first or second. That is the third trimester anomaly usually which is detected.
So you mean to say that when 21st scan is done and you say everything is fine with the baby, we should be telling that there are certain things which will be diagnosed after 28, 30 weeks?
Yeah, ma'am. Late trimester, there are few anomalies which will be identified later on.
So all of us should be little wary about telling that point because bowel, GI tract is something which will come later. How much ever educated they are, they'll be waiting for the blame game, especially if the family is ready to put the blame on the daughter-in-law saying that abnormality is because of you, they will be ready to put a blame on the doctor. So dealing with such a question is very, very, very difficult. So again, the lead is going to be?
Then we have to make sure that they are meeting the pediatric surgeon. And as she has already crossed 30 weeks, there is no discussion about the termination. We just have to continue the pregnancy, and I would like to continue the pregnancy till term in this kind of situation. And the mode of delivery will not vary other than because of this anomaly.
Yeah. So I think she had a planned delivery elective LSCS because previous cesarean and the baby was given. This is the post-op X-ray. Now, what is the surgery options you would be giving, Dr. Chandrasekharan? At this picture, are that options or anything? Manisha, next I want you to.
Seems to be a classic duodenal atresia. So we are now doing all these procedures by laparoscopy.
So laparoscopic duodenal?
Yes. Duodenostomy.
Duodenostomy.
Yes.
Okay, fine. Any other things? I just wanted, my question this is, there are times when you people, this is complete atresia, so duodenostomy. When do you actually, Manisha, I think you can answer that, do a myotomy if it's only something, any particular times when you do myotomies?
You mean, ma'am, if there is a membrane, probably give an incision in the
only
membrane,
thing and then leave it and leave the release and you don't go for a, see, okay, now he's at lap, I'm happy. But this baby underwent an open surgery. This was around 10 years ago, okay, like I said in Medicover times, okay. So nobody wants a open surgery.
10 years also we were doing lap.
That's where I did the case also. And you should understand, okay? So that's what it was. So open surgery and all those things. So when do you think a simple myotomies, they were very, very easy doing laparoscopy than the open surgery. So is there a role or no role?
Not really, ma'am. It's better to go ahead, do a lap and, do an anastomosis wherein it's better to establish a proper patency. If we do a myotomy and if it is not, adequate size enough and we might have to go and redo a little later, it's unnecessary surgery for the baby. It's better to go ahead and do
My
initially.
question to you, Vishwanath, would be, what will you be ready with whenever there is a GI anomaly with so much of distended abdomen and all, a baby is ready to be delivered? What is one thing you will be ready with at the time of delivery?
A few things we keep a checklist like we would try to avoid bag and mask ventilation.
So no barrier mask ventilation.
And we would, if baby has severe respiratory distress, we would intubate and decompress the stomach as
So how
soon
do
as
you
possible.
decompress the stomach? You put a nasogastric tube immediately or?
We put a nasogastric tube and
so intubate is not necessary, but
only if baby
nasogastric
has,
tube is
yes.
necessary. So I think no bag and decompression is the way to go, then look at other things, right? Okay, the child is good, everything is fine. And the next case, similar on the same line, but this was only an anorectal malformation. And then the serial scans. What do you expect when there is anorectal malformation?
So usually we expect a polyhydramnios in
Yes,
these cases.
it was there.
And also the ball will be dilated, large ball. And also something which I call as PAMC, that is a perianal muscular complex, which we can see on the scan whether it is present or absent. And based on that, we can counsel the patient.
This was the picture. Satisfactory fetal growth.
Dilated bowel
good.
loops are present here in this picture.
So this is what. So what are the possibilities when there is an anorectal anomaly? What do you anticipate, Vishwanath? pediatrician. So it's just a thing they have given that there are distended bowel loops, so we are suspecting some anorectal. So DDs, what do you think of?
We try to look for if it is an isolated anorectal malformation or if there is any systemic involvement like other cardiovascular,
They're all
vertebral,
ruled
renal.
out, they're all normal.
So isolated anorectal malformations is very much correctable based on the level of the malformations, high or low, and then we take pediatric surgery involved, and then based on the level of malformation, later on we can plan anorectal pull-through surgeries. Yeah.
So what
its
all the
prognosis
surgeries,
is very
Manisha,
good.
you look at? Because we still don't know. Antenatally, you're going to tell the patient post-surgery it will be an open with colostomy or with this. So what are all the things you're going to counsel the mother with?
If the child post-delivery also does not have any anomalies, we'll counsel for both single-stage and multiple-stage surgeries, because depending on the anomaly which can be identified once the baby is born, after an X-ray itself, maybe probably after 18 hours or so, depending on if it's a low anomaly, maybe a single-stage procedure can be advocated, or if it's a high anomaly, the baby might require 2 or 3 stages, again depending on the whether it's an intermediate or a high anomaly.
So colostomy, how do you tell them? Any one of you, both of you? Counseling for colostomy is not an easy job for a
It's not an
neonate.
easy job. Actually, in our consultation room, actually what we have is we have PPTs for all the anomalies. So I'll open one anorectal malformation, I'll show them previous patients. So
How the
only by
outcomes.
seeing a previous child having, and recently we started a colostomy support group in our KIMS Cuddles. So we'll ask the parents to talk to those parents. Then only they'll get the confidence. So after talking that, and how to take care of that, actually after the operation we'll tell them how to take care of the colostomy, whether to use a bag, whether to do it at home, and whether they can afford or not. We have to take the financial status also into consideration, and we'll tell the timelines actually when we are going to do the next stage of operation,
closure.
when we are going to do the colostomy closure. Till that time, how to take care of the
Manage.
rash. And we have colostomy support group actually which will be taking
Let
care
me tell
of
you
all
one
this.
more factor in India. If it's a boy baby, they're all very happy to do all these things. If it's a female baby, that's come. Amai andi. Are maku telusandi when చూస్తున్నాం అది అమ్మాయి మరి operations on the abdomen and everything. That's a common point which we are going to see. So counseling becomes a biggest headache.
Very, very big headache, especially for the girls
Yeah,
as you
child.
said. But even for boy also, for a family, handling a colostomy, seeing a colostomy is very difficult. So confidence can be given by another co-parent. So that's why we have a list of some co-parents.
Who have
Actually,
done
they'll be
well and
talking to
then-
them.
yes.
Actually, that is the best way of handling these babies.
So this patient underwent a posterior-sagittal anorectal plasty and everything went on well. Now this is the similar case what I keep sending you, Dr. Chandrasekhar. This is a case done by you only. At 28 weeks we had bilateral hydronephrosis, pylectasis, and it is there. Now the point is 28 weeks, Ankita, I agree, we cannot terminate. But the point again comes the same thing, why it was not diagnosed before. The second thing is, is there something we can do to prevent the back pressure and damage to the kidneys?
There are procedures, ma'am, like shunts, but right now we are not doing any shunts in India. So, and also according to Pluto trial, that is not it has not done, it has said that it is not a good thing to do shunts. So usually we follow up these cases, how is it progressing, whether it is stage 1 or stage 2, we'll check for the amniotic fluid, what is the bladder wall thickness and the cortex and medulla of the kidneys, and then usually we send to sir only regarding the counsel.
My question definitely to Vishwanath would be, most of the time whenever we talk to Mehul or anybody, or Chandrasekhar or anybody, all the nephrotic, majority, unless there is a renal agenesis, are recoverable. How true is this sentence?
Nephrotic syndrome is, especially congenital nephrotic syndrome, it is.
No, my question was different. You didn't listen. You only remember what I told you that time. I said, usually anything to do with renal anomalies, whenever we talk to any pediatric surgeon or a nephrologist, they say that they're usually recoverable over time in a child. How true is that sentence? Because that gives us a lot of confidence to the gynecologists.
No, isolated hydronephrosis without any other major issues needs a long-term follow-up in the sense
But
they are recoverable. I mean, they will have a morbidity, you can say, but not mortality. Few of them end up in having chronic, kidney disease, may require transplant also.
So
But
when you're counseling, you are going to talk in a case like this only. This case is very simple, urethral valves. So are you going to talk about CKD to them?
no.
Yes. That is what I want, the difference of opinion. That is what is important. See, in a case where we are telling everything is going to recover, post-op they are going to do well, and you have a urethral valves which can be corrected after that. So are we going to talk about the incidence
So
of
let me give some good news first.
It's going to be a boy
So
baby.
the good news is majority of congenital renal anomalies are not pathological.
Yes.
They are, I mean, so-called hydronephrosis, they are not pathological. Majority are supposed to be physiological.
Treatable
And
also.
they're physiological.
I know,
You probably
over
need
weeks
not
it
do
will come
anything.
down. Yeah, over weeks it will come down.
Of the hydronephrosis that are due to some obstructive uropathy, the commonest is again PUJ obstruction, which has an excellent prognosis. Even if it's a bilateral PUJ, it's an excellent prognosis. So PUV, the case which you have shown here, forms only 5% of the obstructive uropathies that we see in practice. So yes, but when you see bilateral hydronephrosis, when you see a thickened bladder wall, poor bladder cycling during pregnancy, and a dilated posterior urethra, like the so-called keyhole sign, whatever, then we have to talk to them about what can happen to this child. So
monitor and take care of diet and everything. Be under the supervision.
Yes, yes.
That other question which I was asking is, if by chance, this was another case where NT was 2.8, then genetic analysis was done where there was a gene malformation which said nephrotic syndrome for the baby. Then the family was detected that there was a carrier gene in the mother's father about it, and fetal medicine doctor wanted to terminate the pregnancy. They refused and continued. That is when I asked Vishwanath, what is your take about congenital fetal nephrotic syndrome? How is it going to be?
Congenital nephrotic syndrome may have, varied presentation. It is autosomal dominant and also few.
So what do you do? My question is very clear. After it comes on, are you going to do a renal biopsy?
Yeah, yes, it will.
So you would look at it whether it is IgA or what it is?
Yes, congenital nephrotic, it's very much treatable.
Mostly
they will have
treatable,
ascites,
yeah.
and then we can do renal biopsy, confirm it, and then we can start some
accordingly.
steroids. The prognosis is good.
It's going to be good. Okay, thank you. And luto, like she said, it's not being done, but I am looking at doing fetoscopically the vesico-amniotic shunting, which is going to be easy. Future, we will be doing it. So 5 is having an ultrasound shows there, multicystic intrathoracic lesion. This is how it is after delivery. How do you do? What are you going to do? One of the pediatric surgeon, Manisha, and then the seniors. She was the original panelist. Huh? I'm being partial towards her.
When you see a multicystic lesion post-delivery or prenatally, we counsel them that probably there is a intrathoracic lung lesion, probably a CPAM, and this might need a post-natal follow-up. If the lesion is big enough to cause any respiratory compromise, we might need to intervene immediately. But if the lesion is small enough, we ask the child to tide over the neonatal period, and during infancy, it might still need
My
some
question was
lobectomy.
actually to Dr. Anil. I was asking, usually in adults, the CT surgeons always keep fighting that lung is also my domain. We will do the thing. We will do VATS and all. How come in pediatrics cardiosurgery that lungs is not your domain and it is these people's domain?
No, pediatric cardiac surgery has always been separate. We don't.
You're contented and happy.
We have been always doing only heart surgery.
Only heart.
Yeah. And
Heart is the essence of life, we
The only
agree.
time we open the chest is for a coax repair or PDA ligation.
So only that. Lung is not, definitely not yours. But सांस लिए तो उसके बाद ही दिल का धड़कना होता है. So सांस भी बहुत ही important है. So this is what has surgical lobectomy was the one which was done from here. So next 2 cases I'm going to give it to the cardiologist. Please pass on the mic to those both of them. So this is the case, extreme preemie. We have heard Dr. Aparna talking about extreme preemies coming out and all. We can have 50-50%. If they have a significant PDA which can respond to medical management, some do not respond. Suddenly they'll just collapse. Within 5-6 minutes, they look as if they're recovering. So how do you do? How do you manage? What do you do?
Hemodynamic, it depends on prematurity.
Yes.
More premature, more even the small PDA can cause a problem. But still, the concept is you have to try, smaller the baby, try medical management as early as possible. If it's not closed, then you have to decide for the surgical or device.
The whole lead is going to be the neonatologist with you coming and telling, "A karo, wo karo," right?
Yes.
So Vishnath,
They will ask whether it's a hemodynamic significant or not. The hemodynamic significant decide by 4 or 5 things: ventilator, oxygen requirement, bed X-ray, bounding pulses, and IVH or NEC or murmur. If these are findings are there which shows it's a significant PDA, they have to first treat with the medicine. If it's a
It's
failed,
not responding. Next.
then you have to do, is it 2 or 3 times you have to do. If it's still not respond, then you have to decide. Usually the indication for doing the PDA closure is after 1 or 2 therapy failed, then only you have to do for the PDA.
They have tried indomethacin, they have tried everything, it is failed. So
Then we
what
have
are
to
you going to do? In the surgical, are you going to look at the device closure or open surgery?
Now with the advent, even 600 gram or 550 baby can be closed with the device. We close even as low as 600 gram. But the duct should be less than 3.5 to 4 mm. Any duct which is more than 4 mm, as per the criteria, it's not amenable for device closure.
Then it has
so
to be
then
open.
you have to take for the surgeon. Surgeon can do the bedside very well.
Yeah, so just to substantiate what Dr. Sudeep said, with the advent of the Picola device, they're able to close even 600 grams. Otherwise, they used to call us for surgical closure. But with large PDA, where surgeons, we do a small thoracotomy, so that the bedside, we do it bedside many a time, because the baby is so small, fragile, temperature cannot drifts when the baby is taken to the operation theater. So most of them, less than 1 gram, we do on the bedside, clipping of the PDA from the thoracotomy.
Now
So
even the device evolved. Now in the US, now the one group, they started doing bedside PDA device.
That's what I was about to ask, because NICU is very sterile. It is like a hybrid OR only. Nothing is this thing, right? So you can as well do it bedside.
But that's what they
Cath lab, but fluoroscopy is something which you need.
Fluoroscopy instrument, they will keep over them do the bedside.
So that is the only thing like CM you would need.
But we started doing in OT, but over the period probably we'll able to
You
do
should be
bedside.
getting a CM sort of a thing aake udhar kar lena padta, because that is as good as OT, the NICU. So this is what has happened. My 4 one-pointer questions to both of you. With critical aortic stenosis, what would you do?
See, one thing what the first question is related, if
You
any
did
disease,
something.
we have to tell the natural history. That
Yeah.
is very important. Any disease, what if not going to treat, what will be the outcome and what is the prognosis? Treatable, curable, and not at all treatable or curable.
True,
This divides
perfect.
into 3 groups. So critical aortic stenosis is a treatable, but it comes with more limitation, but they may need multiple interventions in the future. Even you try to tide over the fetal or neonate, but they need to go 1 or 2 times, or if the wall got damaged, you have to do the balloon, you have to do surgery also. So the first and foremost for any lesion, tell the natural history. कि if what is going to be
नहीं
done.
करे तो क्या होता? तो इसीलिए करना जरूरी है, नहीं तो बस
And
0%
if after
outcome.
that also, what will be the future? You need multiple intervention there, because many patient and they ask only this thing. If you do one time, whether they need again or not, but you have to be very fair. कि critical aortic stenosis may need 3 or 4
You can try in
interventions.
utero if it fails, after delivery. Anything else you would do for the critical aortic stenosis?
No, mostly
Replacement sorts?
Critical aortic stenosis mostly is balloon dilatation. Because surgical carries high mortality. So if the balloon dilatation is not working, sometimes they may, very rarely, we may have to repair the aortic valve post balloon dilatation if a significant AR comes.
Usually, sir repaired what we did balloon. After few years, he repaired those balls. But the initial fetal, now started doing fetal also. Fetal balloon we did, neonatal balloon we did, and if they required again over the once the baby grow, then probably
that's
the
what my
surgery-
point was. As the baby grows, you cannot do replacement, because as it goes, it becomes difficult with artificial valve.
No.
So it has to be native, or it has to be valvuloplasty as we go.
No, we always repair the aortic valve. We cannot replace in a small baby.
Even multiple repair are possible till the time we can replace safely wide
After 18 years.
Yes.
Restrictive atrial septum.
Restrictive atrial septum is not a diagnosis. It's like hypoplastic left heart is the where the atrial septum
diagnosis
is
will come.
restrictive.
So you
So
put
you
a-
need to dilate and puncture. Like you did a TJ come in a night where the surgeon is still take 4-5 hours to come. Then you
You
do the
will do
balloon
it.
septostomy.
Yeah.
So these are the places where you need the good mixing so that the baby survive, tide over the crisis, and later you can do the surgery.
Tachyarrhythmias.
Tachyarrhythmia, 2 things. Fetal tachyarrhythmia is 99% treatable and curable.
Medicine.
We did so many fetal tachyarrhythmia with 1:1, 3:1, flutter.
In utero, there is tachyarrhythmia. What is the medicine you want mother to take?
3 medicines, digoxin, sotalol, flecainide. These are the 3 standard. If not,
This
then
is what
last
I
is
want all of you
amidrol.
to understand. Okay.
Digoxin, sotalol, flecainide.
After ruling out
99%
sepsis,
will be
after ruling out infection of the mother, these are things you have to give. Okay.
If the more
Yeah.
severe hydrops, you have to do combination, otherwise single drug is okay.
One more case and then we'll stop. Anti-row associated heart block.
There are two things. One is heart block, second is dysfunction. So whenever it's come, you have to ready with the pacemaker. First what we started doing, first we did the transumbilical TPI for 10 days, whether baby is able to sustain pacemaker or not. Directly we cannot put directly pacemaker in. Once baby sustain, shift to the ward, 10, 12 days, baby let the weight gain, and after 2 weeks do the permanent pacemaker by the surgeon.
Okay.
We are creating pocket in chest or abdomen.
Right. This is a case which was treated here in this hospital. So fetal anomaly done a scan and fetal echo was normal. And so everything good. So gynecologist बोल दिए कि बहुत अच्छा है, everything is good. But a routine scan done at 30 weeks growth scan, 2 minutes, showed this. So that's when the neonatologist was called and Dr. Sudhir was called. So what is your diagnosis? How do you want to go about
See, there one thing we have to, the first thing is naturalist, second thing, we have to tell that fetus is evolving. So some disease, even whenever you tell 10 times also normal, they can come later in life. So we, whenever even the normal fetal echo coming 20-22 weeks, in our disclaimer it will be there, coarctation, PAP, we see coronary anomaly, AP window. VSD you cannot do by 100% surety, and some lesion like wall stenosis and coarctation may evolve, or cardiomyopathy can evolve in the later third trimester. So you have to tell very clearly, even if it's a normal at 20-22 weeks.
Fetal echo normal does not mean that these things cannot be detected later. So what did you people do, Dr. Anil?
So the coarctation of aorta, in our primary, in the KIMS group, we always see, we don't do balloon dilatation or coarctation. We do primary repair even on day 2 of life. We do a thoracotomy approach and go and repair the coarctation of aorta. It's a closed hospital.
So surgical closed.
Surgical closed.
To the thing.
Balloon is reserved only when in emergency we not have, because
Tied over crisis.
it's a elastic recoil is very high. So even if you do 10 times, it will again come back. Elastic recoil is very high for the 6 months initial. So that's why surgery is the treatment of choice anywhere.
I think we have to finish because time is over, but one last question to Dr. Kirti about fetal intervention. Where do you do the fetal interventions in today's time, if this is the case like this?
So,
you have a triplets
multifetal pregnancy.
reduction.
Yeah.
Then there is something else which is being done there in the last, that's the laser.
Photocoagulation.
Yeah.
Usually in TTTS, in twins, we do laser photocoagulation. In that, we dichoronize the monochorionic placenta so that 2 fetuses will have their own
So what
blood
do you
supply.
counsel? The survival rate and the follow-up.
So once we have diagnosed it and we have done a surgery, we'll follow up every weekly to see whether any complications are there, whether they're going to TAPS or not. And then usually if the surgery is, if there is no progression, then the success rate is usually good.
So survival rate would be 76%. That is something which we have to be clear. So what is important is detect the problem for anything, treat and hand over to the neonatologist. That's where they are going to take. So this, I think, these are the things, one slide, I will leave it and then I'll stop. When it is going to be a routine care, do you want the pediatrician with you? And which cases of anomalies you would look at it? Take the mic.
For routine care,
Last slide, I'm finishing.
for routine care where we are not anticipating any major anomalies or major problems,
Like
yes.
cleft lip.
Yeah, for cleft lip, cleft palate and small VSD like mild pyelolysis. So routine care is required, but it does not need any major intervention.
So when do you think pediatric team is a must to be there inside the delivery room? Not the junior most, a senior neonatologist needs to be there.
For the defects what we discussed, like congenital diaphragmatic hernia,
Congenital diaphragmatic hernia, anorectal,
and tracheoesophageal fistulas.
tracheoesophageal fistulas, right. And when do you think immediate stabilization is needed before even jumping to anywhere? Taking the baby to NICU ke tak bhi time nahi hai.
No, that it means like immediate stabilization is needed for this congenital diaphragmatic hernia and tracheoesophageal fistula, and some airway anomalies like cystic hygromas.
Cystic hygromas.
Yeah, so
severe hydrops.
Hydrops where we will need
And
immediate
where do you think
stabilization.
delivery room interventions are needed?
See, in pediatric cardiac usually there is nothing like you need immediately. Delivery intervention is not until there is a arrhythmia. Arrhythmia with hydronephrosis is one, or when the dysfunction is present, like in the antibody mediated with the severe, they will come with the severe dysfunction. At that point you have to be ready with
There
your
in the room.
TPI.
So why I ask this particular question is most of the time parents ask, because they met you before. once in 30 weeks, then they met at 24 weeks. They said, cardiologist is going to be there in the delivery room, no, as if we have now other work, but thing. We have a pediatrician, we have a thing, but they still want a cardiologist.
Then TGA, that congenital antibody-mediated heart block dysfunction and arrhythmia.
These are
the
things when we need a super specialist.
Most common thing where we need, because TGA, even in 2 hours, they can deteriorate very fast. So you have to be there at that point.
Thank you. Anything else anybody wants to add? I'm finishing the panel.
And last thing,
long-term
TAPVC. TAPVC now we started doing once you the TAPVC diagnosed, you can use the same placental blood for the bypass and you can repair as early as in 1 hour after delivery also.
Wonderful.
Obstructed TAPVC. So that is also one of the obstructed TAPVC.
Final take home about the long-term outcome.
Yeah, so
Last word is always the pediatrician's word with the baby.
Most of the conditions what we discussed like CDH, TEF, urogenitally anomalies, they have good prognosis, and if it is antenatally detected, it's always good to deliver in a center where the team of neonatologists
So center
and
is a tertiary care where everybody is
yeah.
there. Long term, are you looking at neurological outcomes?
Yes, most of them do
Long
really
term,
good. Yes.
are you looking at the next pregnancy outcomes?
Yeah, if there is some genetic association, we would do
You have to
genetic
look at it.
counseling. And
There are so many times we know that 3% is the risk of congenital heart disease with every pregnancy, and once there is a congenital heart disease, next pregnancy is 6%. So are you going to tell that to the thing?
we would, yeah, in counseling we would mention all the
But you
risk
can
of.
tell in a better way what we are telling. That if next pregnancy is 6%, it's still 94% chance the baby is normal. So don't get scared. That doesn't mean 6% will come, but you may come into that.
Yeah.
And it depends on the recurrence risk. Suppose
Depends
if
on
critical
how
is
early you're coming for and will you have a high degree of suspicion to look out for the abnormality. Anyway, thank you, Dr. Aparna, for giving this opportunity, and thank you the fantastic panel who are here who have answered perfectly.
Thank you, Manjula,
Thank
for
you.
excellent moderation.
Thank you.
Thank you.
Thank you so much, panelists. Please just stay for one group photo. One group photo of the fantastic panel, please. And Ramesh Dampuri sir, kindly please honor the speakers and chairpersons.
We are going to wind up with the last talk session. Very briefly on antenatal hydronephrosis, Dr. VVS Chandrasekharam sir is going to do this session. Chief Pediatric Surgeon at Ankura Hospital, pediatric urologist, renowned across the globe, I should say, with number of publications and on his series on laparoscopic pyeloplasties and vesico-ureteric reimplants. Huge amount of work that has been done. Over to you, sir, to share your experience on the postnatal management of antenatal hydronephrosis.
While that is getting set up, I just request Ramesh sir to hand over the mementos to Manisha ma'am. Would you please just come?
ఛార్జ్ ఉందా లేదా ఉందిలే ఛార్జ్ ఉందిలే అప్పుడే కనెక్ట్ చేయొద్దు నేను ఓపెన్ చేశాక ఓపెన్ చేస్తాను ఓపెన్ చేసి కనెక్ట్ చేస్తే బెటర్ కదా
Dr. Vishwanath. Sudeep sir. Dr. Kirti ma'am, please.
Let them complete all that. It's okay.
Anil sir.
Let them finish first.
Yoga sir. Thank you so much, Ramesh sir. Thank you, sir.
It's working. A very good evening. So I'll just be very brief on this topic. Aparna, shall we start? I always pay my respects to Maharishi Sushruta, who is the greatest surgeon in history, undoubtedly. Unfortunately, in our curriculum, we are not taught about this great person. So basically, surgery is ours. It's not something we should learn from outside. We should probably be teaching the world. I think that's going to happen now in future. So what we will discuss, I have spent about now over 25, 26 or maybe 28 years researching on this one topic of antenatal hydronephrosis. And we'll just discuss what we have learned over many years. It's a very common anomaly, 1 in 200 or 1 in 100 pregnancies show some hydronephrosis. But as I was stating in the previous panel discussion, majority of these cases are self-limiting and most of them do not require any active management. So, of course, PUJ obstruction, so-called PUJ obstruction forms the commonest of the pathological conditions. So antenatally, we typically don't do anything unless it's a bad post-urethral valves with oligohydramnias, where we might consider doing some antenatal intervention. Otherwise, we just wait and watch and then treat the baby only after delivery. So our aim is to prevent renal damage in all these anomalies, but avoid unnecessary surgery. Although I'm a surgeon and probably we have done the world's largest lap pyeloplasties numbers, but still we manage the majority of our babies conservatively. So what are the problems in decision making? So basically, PUJ obstruction, to define obstruction, so every hydronephrosis is not obstruction. So to define obstruction and to define significant obstruction is the biggest problem. So ultrasound is the most important postnatal assessment, of course prenatal also. The problem with ultrasound is there are so many classifications, there are so many grading systems of antenatal hydronephrosis that even an expert is confused. So we have to pick and choose. We use a combination of 2 grading systems in our practice. So there's so many systems of grading. Everybody, it seems that only I am not written my own grading system. I can actually write it and then get it published and then we'll have our own grading system. So there are so many systems now, but we basically use, a combination of 2 systems. So what are the pitfalls? The problem is ultrasound cannot quantify obstruction or even qualify obstruction because every hydronephrosis is not obstruction. It is operator dependent. So the sonologist has to know what to look for. So many times we speak to our sonologist and we specifically tell them what we exactly want. So our practical approach for antenatal hydronephrosis looks like PUJ obstruction is basically that we do an ultrasound. Typically, the first ultrasound is done a few days after birth, but then the best ultrasound is at 1 month of life. And then once we do the ultrasound, if the AP diameter is more than 20 millimeter, if it is either grade 3 or 4 hydronephrosis, then we do a diuretic renogram and then take a call. If it is less than 15 mm APD, SFU grade 1, grade 2, we typically wait and watch and just repeat ultrasound every 3 monthly. So MCUG, there are specific indications when you are suspecting post-rectal valves or reflux as a dilated ureter is seen on the ultrasound. So the problem with, again, diuretic renogram is a very good tool to define obstruction, but there are a lot of pitfalls even in a diuretic renogram. And in my personal view, the baby should be at least 4 weeks old before we do a diuretic renogram. I have not found an indication to do a pyeloplasty in less than 1 month babies. It's extremely rare. So a lot of information can be got from the diuretic renogram. The problem is we should know how to read the renogram ourselves. And please don't depend on the nuclear medicine specialist's interpretation, because many times they do not know the clinical picture. It's the surgeon who knows the clinical picture, so we can interpret the diuretic renogram better. A lot of pitfalls, we need to know the pitfalls also when we interpret these. So the critical questions: does dilatation always imply obstruction? Does obstruction always imply operation? The answer to both these is no. So what is obstruction and what is significant obstruction? That's what we need to define. So, very interesting example. A few years ago, this patient walked into my clinic. This boy was about 1 year old, antenatal hydronephrosis, asymptomatic. Somehow ultrasound was done, then a CT scan was done by an adult urologist at 1 year. We never do CT scans in hydronephrosis. So, but anyway, a CT scan, you can see a significant hydronephrosis, hydrocalysis, and then the pelvis projecting beyond the parenchyma. That's a significant that's a grade 3 hydronephrosis, SFU you may call. So he was advised pyeloplasty. Now they came to me because they thought I will do a good pyeloplasty. Then I said, I don't do a pyeloplasty without a renogram. And when we actually got the renogram on the same baby, there is no obstruction. It's a non-obstructive hydronephrosis. This so-called gross hydronephrosis is non-obstructive hydronephrosis. So what do I do when there is no obstruction? I can't fix it. So we just left him alone, and he actually did well. So even if you find this kind of dilatation, please don't assume that it is because of an obstruction. So it can be a non-obstructive dilatation. So we are very careful before picking our patients for surgery. So what is significant obstruction? So what is the question? So when I actually gave this talk to a group of urologists, they said, boss, you are saying don't operate anything. What do we do? I mean, how do we earn our bread and butter? I said, no, in India you have so many patients. Even if you don't operate many of them, you can still get enough patients. So what is significant obstruction? Any obstruction compromising renal function, or obstruction causing cortical thinning or grade 4 hydronephrosis, or obstruction causing symptoms. The child has recurrent febrile UTIs, or older children present with pain abdomen. That's where you need to intervene. So significant obstruction requires surgery to relieve the obstruction. So conservative management, as I said, we just follow them up with it's an aggressive observation. So you have to tie your hands behind your back and observe the child and don't do anything. So what is the rationale? We all know this. So indications for surgery, as a surgeon, we are more interested in this. Any function less than 40%. Again, please don't believe the function given by the nuclear medicine specialist. They are usually wrong. You have to know how to interpret the scan yourself. You should know which image you should actually calculate the function. But when the function is less than 40 degree, or there is cortical thinning or symptoms, or if there is a single functioning kidney with significant obstruction, you don't want to wait till the function deteriorates. That is when you go ahead and fix it. So this is, as I said, we have been following these patients for more than 20, 25 years now. So this is again bilateral hydronephrosis. So the surgical decision in poorly functioning kidneys, many poorly functioning kidneys can also be preserved, but you have to be careful that this child does not end up with a hypertension tomorrow. So we need to be careful about that. This is a very recent publication that we made in a top journal. So the typical case for surgery, 2-month-old infant, very gross hydronephrosis, 32 mm pelvis, cortical thinning. EC showed left PUJ obstruction, reduced function of 25%, lap pyeloplasty. You can see this picture and this picture, significant reduction. Some degree of hydronephrosis can persist for many. I now have 15-year follow-up of my lap pyeloplasty patients. Some hydronephrosis still persists. So hydronephrosis, again, as I said, doesn't mean obstruction. So lap pyeloplasty, this is open pyeloplasty. You can see the bad scars. Lap pyeloplasty is, although technically difficult, we started in 2006, one of the first in the country. I have a database now from 2009 onwards. So interestingly, pyeloplasty was a surgery which I declined to do when my boss asked me to do as a resident, because the child had a solitary kidney. So I said, I'm not going to do my first operation on a child with a solitary kidney. If I screw up the operation, the child is going to lose their life. My boss was very mad. He said, you idiots, you can't operate. You ask us for surgery. When we give you surgery, you don't do it. Go to Hyderabad and open a pawn shop. This is what he used to say. I mean, typically. But then it so happened later that that operation I've done in the maximum numbers. So patient position for an infant, and for an older child, the ports are slightly closer to the kidney. In an infant, we go a little far because we want space. All these things, we made our own modifications. This is an infant lap pyeloplasty. Thankfully, the video is not playing. So lap pyeloplasty in an older child with PUJ. Video doesn't play again, no problem. See, in an older child who presents with pain abdomen, typically they have an extrinsic obstruction. You can clearly see this is the lower pole renal artery and vein. This is the pelvis, that is the ureter. The PUJ, the vessels are crossing over the PUJ, and they are actually like a hammock. They are causing the vascular PUJ obstruction. This we typically see in older children. Here you have to disconnect the PUJ and make your anastomosis anterior to the vessels. So this is a vascular PUJ, typically seen in older child. We have done a large number of redo lap pyeloplasties after previous failed open pyeloplasties. I think one of these cases had 2 or 3 failed open pyeloplasties before we did a lap. So even in the best countries in the world, so-called best hospitals in the world, we have done a lot of meta-analysis on this. The success of a pyeloplasty, whether open, lap, robotic, is between 95 to 98%. So anywhere between 3 to 5% of children require a reoperation in anybody's hands. So if you're having success less than 95%, then you should actually think about your technique. But any success more than 95% is good enough. So cosmetic results, that's a birthmark. That's not my scar, but otherwise it's typically scarless. So this is the number that we have done, 959 cases and counting till now. So this is the number, average of 55 cases per year, starting with 2009. So we did a lot of academic work. People think I publish so much, they think I don't have clinical work, unfortunately. So now we have follow-up of these patients after 10 years. We have renograms and ultrasounds in many of them after 10 years. And whatever operation you do in childhood seems to be working even when the child is older by 10 or 15 years. So that's the good news. So we have described our own techniques of pyeloplasty, published enormous number of papers. So the consensus now is selective conservative management is safe. In fact, many patients who come to me for pyeloplasty, I refuse surgery because they don't fit into the indications for surgery. So manage them conservatively. But still, there are a large group of patients who require surgery ultimately. So we need to have a thorough understanding of what is obstruction, what is significant obstruction. Don't start operating on every hydronephrosis. So VUR, I'll be very brief again. We do a lot of surgery on VUR. Again, VUR is significant number of VUR is managed conservatively, but a small percentage requires surgery. And I don't want to go there again. I think it's the last talk, so let me stop here. So we have done about 600 and now it's about 625 or some ureters. This is older data. So we have actually one of the largest numbers in the world of vesicoscopic ureteral reimplantation. We have also published extensively. PUV, I want to say this, you have to always challenge the established dogma. Now the anatomy of post-urethral valves, what we have been using to do our surgical resection of post-urethral valves was given by a guy called Young in US about more than 100 years ago. So we have recently challenged this anatomy, and we have actually managed to publish this paper in a top journal saying that the anatomy that we think is post-urethral valves is actually not the correct anatomy. So this way we are able to resect the valve without producing urethral strictures in these small babies. So, struggling scientist, please cite my papers. So we have written 3 books. So I will stop here, I think. Thank you.
Thank you so much, Chandrasekharam sir. May I invite Dr. Yoga Nagendra sir to please felicitate sir. With this, we finally come to the end of the day-long CME. We enjoyed great numbers and great attendance from morning till now. I congratulate people who are hanging on, for the quest of knowledge. Of course, all topics were very detailedly thought of, and I hope you take back some new pearls or some reinforced thoughts. So, at the outset, I would like to thank Dr. Ramesh Dampuri sir, as the president of TCB IAP. Sir, could you please come on stage and just impart few words?
Good evening all. I think we have come to the conclusion of today's CME on perinatology and fetal medicine. So this we planned almost 2 to 3 months back with Aparna. As a president of IAP TCB this year, we are doing a subspecialty CME. We are our EB member, Dr. Srinivas, also here. Till now we have done 3. This is the 4th one. We have in line another 2 subspecialty CMEs. One we are planning in a toxicology in pediatrics, exclusively on toxicology. And last one we want to do some, I think how many of you don't know. So prevention of violence against children. That is a national TOT by our this thing. This we are having every day in and day out, every child at some part of country, they are supposed to be abused or violent. There will be some violence against children. So how to prevent the violence against children, that we are going to have in the month of December. I request who are interested. There anybody can participate, from gynecologist to the pediatrician, surgeon, anyone, because that is the most. So I work mostly on the child abuse, where we will be taking more. So that is there. With these few words, I thank you, KIMS Cuddles Kondapur, for this opportunity of subspecialty CME. So another thing I want to announce, we have our IAP TCB PDCon next September 26th and 27th, along with the Pediatric National Dermatology Conference, wherein all the pediatric dermatology experts in the pediatric dermatology will be coming. So I request all the pediatricians and pediatric dermatologists, please join for us for the conference. Thank you. Thank you once again, Nishita.
Thank you, sir. May I request Aparna ma'am to hand over the memento to Ramesh sir?
I think it's been an exhausting day. I thank all of you who have stayed right till the fag end. We would be failing in our duties if we do not thank some important members who have worked hard for this event. We thank our organizing team, starting from from Divya's team, who have worked in coordinating all the arrangements, mementos. Thank you all. Dileep and his team, thank you for your constant coordination. And our academics team, headed by Srikanth, who have been taking care of registrations and the TSMC registration points. All of you will get your certificates on email. Of course, thank you all the faculty who have come today amidst all your busy commitments, all the senior experts who have graced today's occasion. I know most of them have left, but those of you who are there, I would like to thank you in person. And thanking all the delegates also who have stayed right till the end. Of course, there's one person who has worked for this tirelessly, and that is Dr. Ishita. So I request all of you to please join me in giving a big round of applause. Everything from designing the program, all those cute words or rhyming words that you see, hope or hype, all this has been designed by her. And she has been tirelessly coordinating with all the faculty, sending messages, reminders for PPTs and CVs, etc. It wouldn't have been possible at all without her. And this is her day post duty after Saturday night duty yesterday, saving a 350 grammer. Thank you, Ishita. Great job. And our great team, Vishwanath, Amit, Rajshekar, without whom I think we won't be able to balance clinical work and organizing CMEs like this. Last but not the least, thank you Ramesh Dampuri sir for giving us this opportunity to partner with IAP TCB and do this conference. We had 150 registrations, of course mostly floating. That's why we see fewer members now. Thank you one and all, and sorry if I missed anybody, the AV vendors, IT team, the branding team, and of course our sponsor from Sanofi, Reddy Govardhan. Thank you so much for your support. Thank you all. Thank you one and all. I hand over back to Dr. Ishita.
I think ma'am has covered everything. Let's all go back to Sunday and enjoy the rest of the day. Thank you all.